Welcome everyone to the London and South Eastern Division Conference. My name is Professor Catherine Kinane and I am the chair of the South Eastern Division. This is our second joint event in the last year that the South Eastern Division and the London Division have delivered. And it has been a pleasure for the two divisions to work so closely together and to collaboratively bring you these great programs. Today we have an exceptional lineup of speakers presenting on excellent and informative topics, and both myself and Dr. Peter Hughes, the London Division Chair, hope you enjoy the day and find it educational, useful and enlightening. I would like to thank Dr. Sotiris Posporelis, who is the London Academic Secretary, for putting together this fantastic programme for today, organising the wonderful speakers, and of course also to Dr. Hisham El Nasser, the Southeastern Division Academic Secretary, for his support for today's event. I also need to thank the college staff. They've worked so hard behind the scenes to ensure you have a great, well-organised event today. But most importantly, I would like to thank you, not only for attending today, but also for everything you have achieved and undertaken in your role as a psychiatrist. The last 15 months have been really hard and everyone has had to adapt to new ways of working. But we have come together as a profession and at the same time learned new skill sets. It's been a frightening and uncertain time, but thank you for your dedication, your hard work and commitment. That has enabled services to continue. You are an inspiration and I am proud to be a psychiatrist right at this moment. All that is left now is to say, please enjoy the event, and I'm handing over to Pospo, who is chairing this morning's program.
Fantastic. Thank you, Prof. Hopefully you can all hear me. I think so. Yes. Fantastic. So good morning, everyone. This is Pospo calling from my luxurious office at King's College Hospital. And I say luxurious, not because there is anything fancy about it. I mean, we haven't had heating for the last 6 years, so there's definitely nothing luxurious. But it's the little thing in the NHS that can bring warmth and joy to our hearts. Things that elsewhere are a given, like an office. But I won't be nagging today. It's a sunny day here in London, which is certainly good for a change, as the last few weeks, the weather has been worse than the government's handling of the pandemic. I said I would stop nagging, but I guess I lied. It comes natural, you see. Maybe it's the side effect of 1 year of back-to-back lockdowns. And just as the restrictions, were about to be lifted and life and beer flow back to normal, here we are reveling in endless discussions around vaccines, exotic strains of the virus, and equally confusing information from the government of where we can travel this summer. Or we cannot travel this summer, or we can travel this, or we cannot travel. I'm really confused. Having said that, I gotta say, I'm impressed that so many of you showed up here today, as I have to admit, I have been having a bit of, if you like, Teams, Zoom, and all things virtual fatigue. I just want to go into a room and talk to people, even the ones that try to avoid me. And I think these are my favorites in conferences, because if I know that someone is trying actively to avoid me, I would make every humanly possible effort to find them. But here we are behind the screen once again. On a good note, this gave me the flexibility to invite people from all around the country and the world that otherwise it would have been impossible to join us today. So yes, it's not all doom and gloom. The topics, well, you may recall when at some point I sent you an email asking you who and what you would like to hear in this conference. And I have to say, a few of you emailed back, did I listen? Yes, to some extent. I couldn't bring Oprah or Meghan Markle, Jamie, but I got inspired and let the creative chaos that governs my brain take over. The result? Diverse, to say the least. I mean, where else would you find a talk on neuropsychiatric complications of COVID-19 and an interview with an Assyriologist about mental health in the Assyrian times 4,000 or 5,000 years ago? Well, you can certainly do that here. So before we kick off, because we need to kick off, right? Some housekeeping. I know you're experts already, but still, you will have a chance to ask questions. So fire them to me in the Q&A option, and I'll make sure to ask the more difficult and awkward ones. Of course, there will be breaks, though nobody stops you from moving it with your laptop or your smartphone to the toilet, to be honest. Nobody will notice. If you decide to log in and out and back again, make sure you're back on time for the next speaker. Feedback, yes. We do know we are bloody amazing, but we still know, okay, we're not, but we still want to hear from you. Okay, so we really want to hear from you. How would your appraiser know that you're here for your CPD? Well, we will be making you and your appraiser the happiest people on earth, as we will be sending certificates of attendance, most probably, the latest 2 weeks after the event. Don't ask me why 2 weeks and not 10 days. I don't have a clue, but you will get it. When I tell others that you were here, tweet away using the hashtag LSEconf21, which I know sounds like the London School of Economics conference, but that's the best we can do for the time being. And yes, the event will be recorded, so no need for screenshots, selfies, and handwritten notes, as you will have the recording. I mean, who doesn't want to watch the introduction again, right? Okay, not really. And one last tip, try using the speaker view, as this will give you the best view. So let's kick off the day with, I have to say, my newborn son's favorite activity. It's not about burping, though he does love that too, but what he does enjoy even more is sleep. Our guest not only established, the insomnia clinic at the Royal London Hospital, up in East London, but he also founded the Sleep Special Interest Group in the Royal College of Psychiatrists. He is the immediate past president of the sleep medicine section at the Royal Society of Medicine. So trust me, he knows one thing or two, or maybe more, about sleep. He even edited a practical guide for sleep disorders in psychiatric patients. What brings him here, of course, is his special interest in the relationship between sleep disorders and psychiatric disorders. When I approached Dr. Selsick to give this talk, I was like, Hugh, would you be able to give a talk on sleep disorders? And he was like, can you be just a bit more specific? And he's right. There are around 60 sleep disorders, 60 of them. So we would have needed a few days and sleepless nights to cover each and every one of them. But let's see what we will cover today. So, people, please welcome Dr. Hugh Selsick. Hugh, are you around?
Yes, hi. Thank you very much. Thank you for inviting me to this event. I should say my clinic is actually at the Royal London Hospital for Integrated Medicine, which used to be the Royal London Homeopathic Hospital, but it's now part of UCLH. So thank you very much for inviting me. I'm just going to try and share my screen.
Fantastic.
And hopefully you can all see that. Okay.
Yes, we can see and hear you.
Okay, great. All right. So, as Posporelis said, there are a lot of different sleep disorders, and I'm not going to be able to cover all of them today. And broadly speaking, we have 6 categories of sleep disorders. There are the breathing disorders. This is probably the one that you did learn about in medical school: obstructive sleep apnea, or central sleep apnea, insomnia, the one that we see perhaps most frequently in psychiatric practice, movement disorders such as restless legs, periodic limb movements. For those of you who work with kids, you might encounter something called a rhythmic movement disorder. The circadian rhythm or body clock disorders, where the body clock is out of sync with the outside world. The disorders of central hypersomnolence. So these are essentially neurological conditions that lead to sleepiness. And then the parasomnias, the unwanted experiences and behaviors that occur during the night. And these are broadly divided into those that occur in REM sleep and not those that occur in non-REM sleep. With the non-REM ones being things like sleepwalking, sleep terrors, and the REM ones, nightmares and REM sleep behavior disorder. And one of the really nice things about working in sleep medicine is what an incredibly multidisciplinary field it is. And you can see from the range of sleep disorders why this would pull in people from psychiatry and neurology and respiratory medicine and ENT and a whole range of other specialities. So, as I said, I can't do justice to the whole field in such a short period of time. So I'm going to focus on 4 conditions that you're going to likely encounter a lot in your practice. I'm I'm going to talk about nightmares, restless legs, one of the circadian rhythm disorders called a delayed sleep-wake phase disorder, and then finish up by talking about insomnia. So what are nightmares? Well, nightmare disorder is a repeated occurrence of an extremely dysphoric, well-remembered dreams that usually involve threats to survival, security, or physical integrity. So, having that dream about turning up for your maths exam and discovering you don't have a pen doesn't really qualify as a nightmare. It's generally something that is qualitatively quite different just from a bad dream. On waking from a nightmare, the person becomes rapidly oriented and alert, and either the dream itself with the kind of the emotional content or the sleep disturbance that results from having nightmares leads to significant distress or impairment in social, occupational, or other areas of functioning. Things like low mood, anxiety, fear of sleep, being sleep deprived and therefore having cognitive difficulties during the day or being sleepy. Now, there are different types of nightmares, I guess, or different potential causes of nightmares. They can be idiopathic, and this is certainly, usually the case in children who have nightmares, that there's no underlying cause. Of course, we know that they are common in post-traumatic stress disorder, and 80% of PTSD patients will report having nightmares. Furthermore, following trauma, if nightmares occur, that predicts a subsequent development of a full-blown PTSD. And unfortunately, often when the other PTSD symptoms resolve, the nightmares will often continue. They'll often persist and be an ongoing problem. But it's also important to say that actually, we were always taught when I was training that if you suspect PTSD, ask patients about nightmares. But we were never told to ask about them in other conditions, and yet they are more common in other psychiatric conditions such as schizophrenia, borderline personality disorder, and anxiety disorders. And I'm going to explain to you in a moment why it's so important that we do ask that question of all of our patients, not just those with PTSD. They can also be caused by substances, for example, beta blockers, or the withdrawal of certain substances. And they can be secondary to other sleep disorders. So, for example, we quite often see nightmares occurring as a symptom of obstructive sleep apnea. And when we treat the sleep apnea, the nightmares resolve. So if you do see someone with nightmares and there's a suspicion of sleep apnea, it's always worth getting them screened. Now, occasional nightmares are common and they don't constitute a disorder. And in fact, it's probably true to say that there may be an evolutionary advantage to having occasional nightmares, that it teaches us to be afraid of certain things that we should be afraid of without actually putting us in that situation. We see it in around 2 to 8% of adults, but it's much more common in children. And there's certainly a genetic predisposition to nightmares in both childhood and adulthood. The childhood nightmares tend to start in kind of the pre-primary school years, 3 to 6 years old. And this is often when children are learning that the world is potentially a dangerous place. But the frequency of the nightmares tends to peak in the 6 to 10-year-old age group, and then it gradually gets better in most people. In adult nightmares, it is more common in women. And that may reflect the fact that we often see, for example, that depression or some anxiety disorders may be more common in women. So how do we assess nightmares? Well, the diagnosis is really one that's made on history. You don't need a sleep study to make a diagnosis of nightmares. It's very clear the person has a well-remembered, frightening dream that wakes them up, that affects them during the day. However, it's always useful to do a sleep study to screen for any other contributing sleep disorders. Could this be obstructive sleep apnea that's driving the nightmares? And what we tend to find when we do sleep studies, particularly in PTSD-related nightmares, is that there's really significant sleep disruption. You see a reduction in total sleep time, an increased number of awakenings during the night, and those awakenings are longer than they would be for controls. There's a reduction in deep sleep. And here's one that comes as a surprise, actually, is that PTSD-related nightmares can occur close to sleep onset and can occur in non-REM sleep. So we were always taught, that REM is when you dream. And it's certainly true that we do most of our dreaming in REM sleep. But we can dream in non-REM sleep as well. And this is particularly the case in PTSD-related nightmares. And the reason this is interesting, actually, is because when we're in REM sleep, we are completely paralyzed, and that stops us acting out our dreams. If you're having a PTSD-related nightmare and you're not in REM sleep, you're not going to be paralyzed, and therefore, actually, you're much more likely to act out your dream in the bed. Now, I said I would explain why it's so important to ask every patient about nightmares, not just those with PTSD. And the answer is that nightmares are associated with a 5-fold increased risk for high suicidality. And this relationship remains even if you adjust for the comorbid psychiatric condition or for the severity of that comorbid psychiatric condition. So nightmares in themselves are independent risk factors for suicide. And in fact, of all the sleep disorders, this is the one that is the strongest risk factor for suicide. So we should really be asking about this in all of our patients. Now, we think that normal dreaming is probably something that's controlled by dopamine, and that nightmares are at the level of the brain actually qualitatively different. And we think that what's happening is that there is this noradrenergic cycle. Someone has a nightmare, or maybe just randomly has a cluster of nightmares over a period of a few days, which then increases their anxiety about sleep. That increased anxiety about sleep then leads to increased anxiety at bedtime. They start to fear the bed, and this raises the noradrenergic tone in their central nervous system. Noradrenaline causes nightmares, and so they're more likely to have a nightmare that night, which then reinforces their anxiety about the sleep, and so you get this noradrenergic cycle. So when it comes to treating nightmares, we can intervene in a number of different ways. We can intervene by tackling the nightmare directly, and I'll talk about that briefly in a moment, by tackling anxiety in general or anxiety around bedtime, or by suppressing the activity of noradrenaline in the brain. So the medications that we use for nightmares, the one that perhaps is most surprising is prazosin, which is an alpha-1 antagonist, and it's used as an antihypertensive drug. But it blocks the activity of these noradrenergic receptors, and it's been shown to be effective in the treatment of PTSD-related nightmares in military and civilian populations. Now, there have recently been some doubt cast on this. There was a study that showed negative results, but the vast majority of studies looking at prazosin were positive, and certainly our clinical experience is that if you get patients onto an adequate dose, it can work really well. And an adequate dose is around a median, sort of average dose of about 3 milligrams at night for civilian populations, but in military populations tends to need a higher dose of around 10 to 13 milligrams. And this is in fact why we know that noradrenaline is involved in PTSD-related nightmares, was because of the kind of chance finding that PTSD patients had improvements in their nightmares when they took prazosin. And subsequently, we found that noradrenaline is raised in the CSF of PTSD patients, particularly with nightmares, and the level of that noradrenaline is correlated with the severity of the PTSD. Another treatment option, and one that perhaps people feel a little more comfortable with, is trazodone, which again has alpha-1 antagonist properties. Now, the level of evidence here is not as good, but there was a survey of 74 PTSD patients showing that over 3/4 of them had a reduction in nightmares on trazodone, and that, in fact, half of them had complete remission. And interestingly, those who had complete remission, 91% of them were only on 100 milligrams, which is below the BNF starter dose for trazodone when it's used as an antidepressant. Other medications you might consider are some of the atypical antipsychotics. There's a little bit of evidence for these. Topiramate. I've never used this because I find that the side effects are troubling for a lot of people. And gabapentin, which is one that I have had some success with, actually. And here, again, you're taking these medications only at night. You're not taking them 2 or 3 times a day. So my practice really is if someone presents to me with nightmares, I will obviously take a full medical and psychiatric history, but I'll also screen for and treat any comorbid sleep disorders. I tend to use trazodone as my first line for a couple of reasons. Firstly, a lot of these patients will have comorbid depression, anxiety, and insomnia, and I can treat all of those conditions along with the nightmares by using this one medication. It's also much easier to titrate them because GPs are often very unfamiliar with the use of prazosin as an anti-nightmare drug, and so you have to do the titration yourself, which is quite difficult to do when there's a long gap between appointments, whereas they're much more comfortable titrating trazodone. However, if a patient is already on an antihypertensive, then I'll often ask the GP if there's any good reason why we can't just switch their antihypertensive to prazosin and treat the blood pressure and the nightmares with a single medication. In terms of non-medical treatments, the best evidence is for something called imagery rehearsal therapy. And what happens with imagery rehearsal therapy is you ask the patients to recall a nightmare. They then alter the theme or the ending of that nightmare. So as an example, if they keep having a nightmare that they're being chased by somebody with a knife, perhaps what they do is they turn the knife into a banana, and the person who's chasing them turns out to be a friend who's playing a prank on them. They then rehearse that nightmare every day, but with that changed ending. And what then happens is one of two things. Either the nightmare just becomes less threatening and they therefore start to have fewer of them at night, or what can sometimes happen is they have the nightmare and they incorporate that changed ending into the nightmare. And again, that removes all the threat from the nightmare, and it can be really good at reducing the frequency and intensity of the nightmares. They'll start with the least threatening nightmares, and once they've practiced that for a couple of weeks, they'll move on to gradually more and more threatening ones as they get more comfortable with the technique. And it's effective in both PTSD and idiopathic nightmares. So it's a really useful treatment. Now, the reality is that a lot of places don't have access to imagery rehearsal therapy. And so is there something you can do with your patients? And there is actually. There is good evidence for the use of progressive muscle relaxation. Now, imagery rehearsal therapy, in a way, tackles the nightmare directly. The progressive muscle relaxation is designed to reduce anxiety at bedtime. And I'm sure many of you are familiar with this technique where you simply go through your body, progressively tense, and then relax your muscles. And this then leads to relaxation in the body with a secondary relaxation of the mind. It's really easy to teach and almost impossible to get wrong. And particularly with nightmare patients, we do encourage them to practice it a few times during the day before trying it in bed, because the bed is a very stressful situation for someone with nightmares, and trying to relax for the first time in your stressful situation is going to be difficult. So we ask them to practice it a couple of times outside the bedroom until they're comfortable with it, and then they take it into the bedroom and do it as they go to sleep at night. And if you want a program to give to your patients, just ask them to go onto SoundCloud, type in RLHIM for Royal London Hospital for Integrated Medicine, and you'll see the progressive muscle relaxation program that I put up there. There's no copyright on it, and everyone is welcome to use that and pass it on to your patients. Okay, so moving on to restless leg syndrome, which was once described as the most common disorder you've never heard of, and it's bizarre that there are still some people, I don't think within the psychiatric community, but more kind of in primary care, who genuinely believe this condition doesn't exist. And as someone who had a brief period of restless legs after hurting my back some years ago, I can tell you it's a very real thing. So what is restless leg syndrome? It's an uncomfortable sensation which can occur anywhere in the body, the head, the groin, the stomach, the back, but most commonly happens in the legs. It's worse at night, worse at rest, and temporarily relieved by movement. Those are your 4 diagnostic criteria. So uncomfortable sensation, worse at night, worse at rest, and temporarily relieved by movement. Patients will generally be able to tell you where they feel the discomfort, but will really battle to tell you what that discomfort feels like. They'll just say, I can't quite describe it. And they kind of use vague words like, sort of feels a bit kind of like water in my muscle, kind of electric-y, hollow, achy. They can't quite get their tongue around how to describe it. Now, if something is worse at night, this discomfort is worse at night and worse at rest, it's going to hit when you get into bed at night and you're trying to sleep. And so what happens is this generally manifests as a sleep onset insomnia, although it can also wake people from sleep and then lead to some sleep maintenance difficulties. Now, there is a close relationship between restless legs and depression. Symptoms of depression are common in patients with restless legs. And there is some data to suggest that if you treat restless legs, that can lead to improvements in the depressive symptoms. But perhaps most worryingly, over a third of patients with restless legs and depression will report suicidal ideation as a result of their restless legs. So again, it's something that we do need to be aware of. And particularly because it does often manifest as sleep onset insomnia, it's very easy to miss. And it's very easy to miss because patients don't tend to tell you that they have restless legs. They tell you that they can't get to sleep. And as you'll see in a moment, if you misdiagnose it as insomnia, you could make the situation worse. So general physicians correctly diagnose restless leg syndrome in less than 10% of their patients. Partly, I think this is because it's so difficult for patients to describe, and because patients don't, as I say, don't tend to volunteer that they have restless legs. They complain of inability to sleep. So you really need to specifically ask about restless legs with your patients. And there's a single question that's been shown to have 100% sensitivity and 97% specificity for restless legs in a neurology outpatient population, and here it is. When you try to relax in the evening or sleep at night, do you ever have unpleasant, restless feelings in your legs that can be relieved by walking or movement? Simple as that. What causes restless legs? Well, antihistamines are a big, big driver. Antidopaminergic drugs, any of our antipsychotics, antidepressants. And this is why it's so important to be sure that a patient, when you're treating insomnia, that they have insomnia, not restless legs, because quite often, what we may think about using when we want to treat insomnia is a sedating antihistamine, or people will often use a low dose of an atypical antipsychotic or amitriptyline, but actually, if they've got restless legs, you might be making the situation worse. Iron deficiency is a very common driver. Peripheral neuropathies and radiculopathies, again, are issues. So, always just look out for it in people with bad backs, with diabetic neuropathy. It's common in pregnancy and does tend to resolve shortly before delivery. And it's really, really common in kidney disease, almost ubiquitous in kidney failure. How do we treat it? Well, if the iron is low, we give iron, and generally we'll give oral iron if the ferritin is below 75 micrograms per liter. So the normal level of for ferritin is around 13 to 19 micrograms per liter, depending on the lab. But we would say, if someone presents with a ferritin of 20, we'd still give them iron supplements. Change their medication if you think the medication is causing it. Now, in the UK, the licensed first-line drugs for restless legs are the anti-Parkinson's drugs. And the ones most commonly used are ropinirole, pramipexole, and rotigotine. They're used in much lower doses than are used in Parkinson's. You use them only at night. But they do carry a risk of psychosis. They carry a risk of compulsive behaviors. And they carry a risk of something called augmentation. And what happens with augmentation is that you give someone with restless legs one of these medications, and the restless legs gets better. But then, after a while, it starts to get much, much worse. It starts to occur earlier in the day with much more severe symptoms. And this is a deterioration that can't be explained by the natural history of the condition. It's a kind of a paradoxical response to the medication. And it can be very difficult to treat. So increasingly in sleep clinics, the first line that we use are pregabalin or gabapentin. And in fact, the International Working Party on Restless Legs have essentially said, unless you've got a really good reason not to use these medications as a first line, they should be your first line. Because they don't cause psychosis, they don't cause compulsive behaviors, and they don't cause augmentation. But there is very good data from a meta-analysis showing that they both work very well for restless legs. Clonazepam is still quite widely used, although the evidence for it is a bit equivocal, to be honest. Clonazepam is something that's kind of used a bit like the steroid of sleep medicine. We throw it at lots of different things. But it's not something we're using very much anymore. And so if we've tried one of the anticonvulsants and that hasn't worked, and we've tried the dopaminergics and that's not worked, then we'll move on to the opiates. Oxycodone, some patients will even go on low-dose methadone. So moving on to the circadian rhythm disorders. And what I'm going to focus on is this one called a delayed sleep-wake phase disorder, or I might occasionally lapse into calling it by its old name, delayed sleep phase syndrome, just because it's quicker. And this is where the person's body clock is delayed relative to the outside world. So they'll say, my body's in London, but my body clock's in New York. And what happens is that they have a very delayed sleep onset time. They can't fall asleep at their desired time. They only fall asleep at 2, 3, 4 in the morning. And if left to their own devices, they would then sleep through to 11, 12 in the morning, 1 in the afternoon, 2 in the afternoon. And if they're allowed to do that, they have no problem. So if they work in the theatre, where they only start work at 3 in the afternoon and finish at 1 in the morning, this sleep pattern is not a problem. But of course, for the majority of people who work 9 to 5 jobs or who go to school or college, what it means is that they're often going to be very sleep deprived because they fall asleep at 3 in the morning and are then dragged out of bed 4 hours later to go to school. Unlike in insomnia, because this does again look very much like a sleep onset insomnia, people with insomnia will generally have difficulty if they have difficulty falling asleep. If something were to wake them in the night, they often have great difficulty getting back to sleep, or their sleep is quite fragmented. With delayed sleep-wake phase disorder, once they fall asleep, they generally have no difficulty maintaining sleep. It's very common in teenagers. This may be an underestimate of 7 to 16%. Much less common in adults, but it does occur. And what that tells you is that when it does occur in teenagers, most of them will grow out of it with time. Most, but not all. And it's been shown, for example, that by delaying secondary school start times by an hour or so, you can improve attendance, behavior, and academic performance by getting the school to fit in better with the teenager's body clock rather than them trying to shoehorn their body clock into the what we would consider normal hours. Again, over 2/3 of patients with delayed sleep-wake phase disorder have a comorbid axis 1 diagnosis, and it's also more common in some personality disorders. So we see it's in depression, bipolar disorder, OCD, schizophrenia, and really strong association actually with ADHD. So in 3/4 of children and adults with ADHD, there is a delay in the circadian rhythm. It may not always quite meet the severity criteria to be called a delayed sleep-wake phase disorder, but it's a measurable delay in their body clock. And melatonin secretion, which is a marker of your body clock, is delayed by 1 hour and 45 in adults with ADHD and 45 minutes in children. Now, 45 minutes may not sound like a lot, but if someone's losing out on 45 minutes sleep every single night over a long period of time, they're going to accumulate a pretty significant sleep debt. And there certainly have been cases where treating the delayed sleep-wake phase disorder allows some ADHD patients to discontinue their stimulant medication, where the improvement in sleep is such that actually the condition becomes sufficiently well controlled that medication is not required. How do you diagnose delayed sleep-wake phase disorder? Well, it usually presents as sleep onset insomnia and almost always will start in adolescence. You don't get this starting in your 30s or your 40s. This is something that they say started when I was 11, 12, 13. They can't fall asleep till very late. If woken at a normal time, in inverted commas, for school or work, they'll really battle to get up, because that's like you or me getting woken up at 3 in the morning, when you drag them out of bed at 7 in the morning. If they're not woken up from sleep and allowed to sleep on their normal schedule, they'll sleep till the late morning or early afternoon and feel absolutely fine. They will generally say to you they feel at their most alert late at night. They start to feel really energetic when everyone else in the house is going to bed. And they feel dreadful in the morning. Even if you knock them out with a hypnotic and they get a good 8-9 hours sleep, when they wake up at 7 in the morning, they still feel dreadful, because their 7 in the morning is a bit like our 3 in the morning. Even if we've slept well, we don't feel at our best at 3 in the morning. And if you're not sure, there is the Horn-Ostberg Morningness Eveningness Questionnaire, which is freely available. You can just Google it, and they get a very, very low score on this. It's a self-rating scale which looks at how strong a morning or evening preference they have. And of course, people with delayed sleep-wake phase disorder have a very strong evening preference. So how do we treat delayed sleep-wake phase disorder? Well, we give melatonin in the evening 6 hours earlier than the time of sleep onset the night before. Because what we want to do is we want to give them melatonin earlier than the time that they naturally secrete their own melatonin. Now, we can't predict exactly when that's going to happen, so we use sleep as a sort of a proxy measure of their body clock. So melatonin 6 hours earlier than the time they fell asleep the night before. And using lower doses generally works better than higher doses, because if you take a very high dose of melatonin, there'll still be some sitting in the bloodstream the next morning, and that's actually going to pull the body clock the wrong way. So we want a lower dose in the evening to pull the body clock forward. We also would rather have an immediate release than a slow release. Now, that's a little bit difficult in the UK, because the only one that we have generally available on the NHS is Circadin, which is a slow release tablet. However, if you chew or even just quarter the Circadin tablet, you break the slow release mechanism down and it becomes an immediate release tablet. And then we want to use light in the morning. And daylight is the best, but good luck getting that in Britain. So if you can't get the person outdoors in the morning, using a SAD lamp is second best, but still can be very effective. But they must get that exposure to light as soon after waking up as possible, within the first sort of 30 minutes or so of getting out of bed. Okay, so restless legs and delayed sleep-wake phase disorder are two differentials for insomnia. And they're ones that we want to screen out because the treatment is very different. But let's talk about insomnia itself. This is the big one that we encounter as psychiatrists. And this is a difficulty either initiating or maintaining sleep or waking up too early in the morning, which leads to daytime consequences. And this is a really important point, because there are people who sleep 6 hours a night or 5 hours a night and feel absolutely fine during the day, but get very anxious about the fact that they're not hitting their 8 hours, which we are told is like the gospel we are supposed to be getting. And these people, there's nothing wrong with them. They are just short sleepers. This idea that we sleep for 8 hours, well, there's some truth to it in that the average amount of sleep we need is around 7 to 8 hours. But that's an average, and some people need more and some people need less. So there have to be daytime consequences to make a diagnosis of insomnia, and the daytime consequences are significant. Fatigue, cognitive dysfunction, mood problems, anxiety, increased workplace accidents, reduced productivity. Also within the definition of insomnia is that you can diagnose it if someone is dissatisfied with their sleep. But actually within the sleep community, we tend not to use that as a criterion. If someone is feeling well in the day but dissatisfied with their sleep at night, the work we want to do is to help them to realize that their sleep is okay, rather than treating them as someone with insomnia. What are the psychiatric consequences of insomnia? Well, in adults without any prior psychiatric symptoms, there is an increased risk for depression, for anxiety disorders, and for substance abuse. And treating depression doesn't necessarily result in relief from the insomnia. So insomnia is we're now confident is a significant risk factor for depression. We often used to think of insomnia somehow being secondary to depression, but if you look at the timeline, it's more common for insomnia to precede depression than for depression to precede insomnia. And if you treat the depression, when it remits, the insomnia may get better, but very often it doesn't. Very often it's a residual symptom. In fact, the most common residual symptom when depression remits is insomnia. And if you do get residual insomnia, that is a significant risk factor for depressive relapse. So it's a risk factor for first onset of depression and for a relapse of depression. It's also a marker for suicide risk. And there's been a lot of debate in the literature about whether it's an independent risk factor or just a marker of severity of a comorbid psychiatric condition. But I think we're now really coming to the view that it is in fact an independent risk factor. Not as strong a factor as nightmares, but a risk factor nevertheless. And as I'm going to show you in a little while, if patients have comorbid insomnia and depression, treating the insomnia can effectively treat the depression as well. But let's say that a patient doesn't get depression or anxiety or substance misuse with their insomnia. We should still be seeing insomnia as a serious psychiatric condition. In this study, they looked at quality of life indices using the SF-36 scale, and they compared insomnia. Let's look here at severe insomnia, that's this bar here, and they compared it to major depressive disorder on the right, and this dark one is congestive heart failure. And if you cast your eye across this, what you can see is that insomnia has similar impact on physical function, significantly greater impact if you look at that on physical role, pain, similar impact on health, vitality, social functioning, emotional role perhaps a little bit less than depression, but significantly more than congestive heart failure, and still a significant impact on mental health. So across these different kind of domains, actually insomnia has a similar impact on quality of life overall to major depression or congestive heart failure. So how do we treat insomnia? Well, it's worth just kind of being aware of the neurotransmitters that are involved in promoting sleep and wakefulness, because that gives you a really good toolkit when you're thinking about what medications you might use. There are essentially three substances that promote sleep: GABA, melatonin, and adenosine. And so anything that promotes these neurotransmitters or hormones, such as the benzodiazepines or Z drugs, which promote the action of GABA, are going to enhance sleep. Whereas anything that antagonizes them, like caffeine is an adenosine antagonist, is going to promote wakefulness. And we have a much longer list of neurotransmitters that promote wakefulness: noradrenaline, dopamine, serotonin, histamine, acetylcholine, and orexin. And so clearly, if we want to promote sleep, we want to use medications that are going to inhibit the activity of those neurotransmitters, or avoid medications that promote their activity. And this is why, for example, you tend to see insomnia, particularly on initiation of antidepressants, is because they will increase serotonergic and noradrenergic tone. There's been a lot of stuff over the years in the popular press about how hypnotics don't really work. And actually, when you look at the evidence, the reality is that they do. Whether you're looking at time taken to fall asleep, total sleep time, wakefulness during the night, or subjective sleep quality, these medications generally are actually pretty effective. But perhaps a thornier question is, do they work in the long term? And the answer is that for a lot of medications, we don't know. So, for example, most of the benzodiazepines that are used as hypnotics, the longest studies that have been done have only been a handful of months. The best evidence we have is really for the Z drugs. And I'm going to show you this study because this was a very influential study looking at S-zopiclone, which is I can never pronounce this word, an enantiomer of zopiclone that they use in the States. And to show you what's going on here, this was a placebo-controlled trial for 6 months, which was then unblinded at 6 months. And the people on the placebo group were then given the active drug. And the subjects were asked to take the medication every single night for a year. This is time along the bottom, and this is the total sleep time on this axis. Now, you can see that when they start taking the medication, there's a bit of a placebo effect there, but there's a greater effect for the active drug. Here, when they're unblinded, the trial, they put the placebo people on the active drug, and that's why you get that big increase in their sleep time. But what I want you to focus on is this blue line. This is the group who were on the active drug every single night for a year. And what you can see is that there is absolutely no drop-off in the efficacy of that drug over the year. So the best evidence that we have is for the Z drugs, and there have been other studies using different study designs, and some of the other Z drugs have confirmed this, that at least over a period of a year, we know these drugs remain effective in the majority of patients. Do they work when you stop taking them? Well, with very few exceptions, once the medication is discontinued, the effect is lost. So these medications treat insomnia, but they don't cure it. And so this practice of giving a short course of hypnotics just to reset the sleep cycle doesn't work in chronic insomnia. If they've got acute insomnia, if it's going to be time limited because they're stressed about an exam next week, then yes, using a short course of hypnotics is absolutely fine because you know that they'll go back to sleeping well when the exam is done. But if they have long-term insomnia, a short course of hypnotics doesn't work. What happens is they sleep beautifully for the 2 weeks that they have their zopiclone. At the end of the 2 weeks, the prescription runs out, and of course, the insomnia returns. And they then go back to the doctor and say, oh, I'm sleeping badly again. Please can I have some more of those sleeping pills? And the doctor says, oh my gosh, you must be addicted. Which, of course, they're not. It's just that they have a long-term condition that sometimes requires a long-term treatment. I often get asked about melatonin for insomnia. And this is one of my least exciting holiday snaps. This was from a supermarket in Italy, showing melatonin being sold in the vitamin aisle of the supermarket. In the UK, it's often much more difficult getting it prescribed. And it is an effective medication for sleep onset insomnia. It's got a short half, so it's good at reducing sleep onset latency. It does improve subjective sleep quality. There's no consensus on the optimal dose of melatonin when using it as a hypnotic, but the dose response curve is generally pretty flat above around 6 to 8 milligrams. So there's generally not much point going any higher than that. It is very safe and generally very well tolerated, and significant adverse events are remarkably rare. What about antihistamines? Well, if you could get a really, really pure antihistamine, that can be a very effective and a very safe, well-tolerated hypnotic. And there is a very pure antihistamine, although it's very difficult for us to get. It's called doxepine, which we think of as an antidepressant. But at very low doses, it turns out to be the purest antihistamine we know. So in the States, at 3 to 6 milligrams, it's licensed as a hypnotic. And what's unusual about it is, unlike the other hypnotics where the degree of sedation is closely correlated to the plasma level, with doxepine, the peak sedation occurs about 90 minutes after the peak plasma level. And that means that this is a really good medication for sleep maintenance insomnia, for people who are waking up in the middle of the night or having early morning waking. And it doesn't appear to raise the arousal threshold. So if someone needs to respond to a child during the night, whatever, in theory they should be able to wake up as easily on doxepine as with no medication. Now, as I say, it's very difficult for us to get that, because for us doxepine is very expensive, and the smallest dosage we have is a 25 milligram capsule, which of course you can't really cut up into smaller pieces. So what about using things like promethazine, diphenhydramine? They're often perceived to be safer than the benzos and the Z drugs, but actually we're not sure that's really true, because at therapeutic doses they have very significant anticholinergic effects, and they therefore add to the anticholinergic burden, particularly with older adults who tend to be on multiple medications, and that comes with a whole range of attendant risks with regard to cardiac side effects, risks in overdose, and increased risk of dementia with high anticholinergic burden. They also have very long half-lives, and that leads to daytime sedation, which may in fact increase the risk of falls, for example, or accidents. Now, so far I've talked about using hypnotics in insomnia, but what about kind of using them in depression? Well, we very often give benzo receptor agonists, so benzos or Z drugs, in the early stages of antidepressant treatment, because we know that our antidepressants cause insomnia. And this is effective at improving sleep and doesn't interfere in any way with the antidepressant action. So it's a very sensible practice. S-zopiclone led to improvements in both sleep and an improved response to fluoxetine in depressed patients. And this effect has not been found with other Z drugs. So it might be something very specific to S-zopiclone that it has some antidepressant effect. However, with the benzodiazepines, they do accelerate. They're effective for sleep, but they also accelerate the response to the antidepressant. In bipolar disorder, a trial looking at Ramelteon, which is a melatonin agonist they have in the States, didn't improve sleep in manic patients, which is not a surprise because it's not a particularly strong medication. But in euthymic bipolar patients, it halved the relapse rates. So it extended the period of mood stability in euthymic bipolar patients who had sleep disturbance. The Z drugs have all been shown to be safe and effective in bipolar disorder, and perhaps not unsurprisingly, treating patients with bipolar disorder with a sedating antidepressant rather than with a hypnotic led to a high risk of manic relapse. And as I say, I don't think that's particularly unexpected. In schizophrenia, there is some evidence that zopiclone may lead to better improvements in sleep and a greater improvement in negative symptoms than the benzodiazepines. It is a much more specific drug in terms of its action at the benzodiazepine receptor, and so it may it reduces kind of things like it doesn't affect anxiety, muscle tone, and so on in the way that the benzos do. Now, S-zopiclone improved sleep and cognitive function relative to placebo in patients with schizophrenia, and this is one of the exceptions because on discontinuation of the S-zopiclone, the cognitive benefits were lost, but actually the sleep remained better. So this is one of the few cases where a short course of a hypnotic in what's often a long-term condition seemed to be helpful. And there have now been 2 studies showing a benefit of melatonin in schizophrenic patients. So when choosing a hypnotic, there are a lot of things to consider, but perhaps the simplest thing really to think about is the duration of action. Because you can then tailor the medication according to what time of night the person has the problem. If they have difficulty falling asleep, you want something that's got a rapid onset. But if it's only difficulty getting off to sleep, then you want something that's fairly short acting so that you minimize the risk of daytime hangover. So for example, for sleep onset insomnia, alone zolpidem is a better choice than zopiclone because it's got a very rapid onset of action, got a much shorter half-life, so much less likely to cause daytime hangover. Conversely, if someone has difficulty getting to sleep and staying asleep, then I would think much more along the lines of zopiclone because it's good at getting people off to sleep, but also sits in the bloodstream for a significantly longer period of time. Ask yourself, are they at risk of falls? And if so, generally, there's not hard evidence for this, but it would just make sense to use shorter acting drugs, so there's less daytime sedation. And always ask your patients if they drive, particularly if they drive in the morning. One should not drive for at least 8 hours after taking a dose of zolpidem or 13 hours after taking a dose of zopiclone. So if someone does drive, I would suggest using melatonin as a first line or zolpidem. If they've got difficulty with sleep onset, use a short-acting drug like Circadin or zolpidem. For middle of the night or end of the night, a long-acting drug such as a sedating antidepressant. And if it's difficulty getting to sleep and staying asleep, then zopiclone or a sedating antidepressant, though they may need to take the sedating antidepressant earlier in the evening to minimize the risk, because it takes longer for it to kick in. When should one take a hypnotic? Well, very simply, Z drugs and benzos are pajama drugs. They should be taken only at bedtime or within the first hour of going to bed. Any earlier than that, and patients often do this, they'll take their sleeping tablet at 6 in the evening, hoping to fall asleep at 11 at night, and they're then walking around with a sedating drug in their bloodstream, which increases the risks of falls and so on. And it also means that by the time they get to bed, the plasma levels are already dropping, and that makes the drug less effective. Any later than an hour after bedtime, and there's a much greater risk of morning hangover. So with the exception of sedating antidepressants and antihistamines, which may need to be taken a bit earlier, and melatonin, which can also be taken an hour or 2 before bed, these drugs should be taken at bedtime or within an hour of going to bed. How do you know if your hypnotic is working? The purpose of a hypnotic, very simply, is not to improve sleep. It's to improve daytime function, cognition, energy, and mood. And so if you take a medication that makes you sleep beautifully at night, but you feel dreadful in the day, it's the wrong medication. So the first question we should really ask is not, does this medication make you sleep? The question we should ask all of our patients is, how does this medication make you feel in the day? And then finally, Posporelis, how much time have I got?
Well, it's up to you. You can have anything between 2.5 minutes and 3.5 minutes.
Okay.
No, it's okay. I mean, you know, you can have 5 minutes, and then we can, because we have loads of questions, Hugh.
Okay, great. So I'll try and zip through this. CBT for insomnia. As with all things in psychiatry, CBT is an effective intervention for insomnia. It has durable effects that continue long after the therapy is finished. It can be delivered individually, online, or with apps in groups, through books. And it's composed of a number of individual circumscribed techniques that can be taught quickly and slipped into your routine psychiatric consultations. But it's still not widely available, unfortunately. It's been trialed in a number of different psychiatric conditions, and in all of them, except with patients recovering from alcohol dependence, it's been shown to not only improve the sleep, but to improve the comorbid psychiatric condition. And just as an example, this study by Blom looked at had patients with depression and insomnia and compared their CBT for insomnia and CBT for depression. And what it found essentially is that CBT for insomnia improved the sleep better than CBT for depression, no surprise, but it improved the depression to the same extent as the CBT for the depression. And so if you have a choice of only giving CBT for insomnia or CBT for depression, you're better off giving the CBT for insomnia. And in my last 2 minutes, I'm going to rush through just a couple of the techniques that we use that you can use with your patients. We explain to patients about this thing called the homeostatic sleep drive, which is a fancy word for sleepiness. And sleepiness is the fuel that drives your sleep. And from the moment you wake up in the morning, you start to accumulate sleepiness. So in a sense, you're filling up your fuel tank with sleep fuel. And when your tank is full, you fall asleep. And as you sleep, you use up your sleep fuel. And when the tank reaches empty in the morning, you wake up again. So the first thing we ask patients to do is to set an alarm to wake up and get up at the same time every day, 7 days a week. Because if you wake up at a different time, the point at which your tank reaches full will be different each night. And therefore, the point at which you fall asleep will become unpredictable. Whereas if you get up at the same time every day, your tank reaches full at the same time every night, so you feel sleepy at the same time every night, and you fall asleep at the same time, and your sleep becomes more predictable. We then ask patients not to nap, because any time they nap during the day, they're leaking out some of their sleep fuel, they're using some of their fuel, and therefore are not going to be able to fill up their tank at night. And then finally, we ask them to only go to bed when their tank is full. And the way that we work out when their tank is full is we get them to keep a sleep diary for a week, work out their average sleep time across that week, and subtract that average sleep time from their rising time. So if they get up at 7 and they sleep for 6.5 hours on average, we say 7 a.m. minus 6.5 hours is 12:30 at night. And this now becomes their earliest bedtime. And they're allowed to go to bed when they have reached that earliest bedtime and they're feeling sleepy. They do this for a week, and if over a period of a week they find that they're falling asleep within 15 minutes and not awake for more than 15 minutes during the night, we then allow them to move that earliest bedtime 15 minutes earlier for the subsequent week. So we compress their time in bed down to more closely match their time asleep, and then gradually increase it again to increase the quantity. And then finally, we harness the power of classical conditioning, because good sleepers, we go to bed every night, and we go to bed generally because we feel sleepy, and what we do in bed is we sleep. So for good sleepers, the act of going to bed makes us sleepy and makes us sleep. People with insomnia go to bed feeling anxious, because this is a place where they go to do battle every night, and they spend a lot of time in the bed awake. So for someone with insomnia, the act of going to bed makes them anxious and it wakes them up. So we want to break this association and reinforce this association. And we do it with two very simple but not always easy rules. Rule number one is anything which is a waking activity should be done in a waking space, and a waking space is anywhere but the bedroom. The only things that are allowed in the bedroom are sleep, sex, and maybe getting dressed and undressed, as long as you don't spend a lot of time doing it. Every other activity is done outside the bedroom. Secondly, when they go to bed at night, if they don't fall asleep in about 15 minutes, and we stress about because we don't want them clock watching, or if they wake in the night and don't get back to sleep within 15 minutes, they get up, get out of the bed, get out of the bedroom, and go and do something relaxing and enjoyable. And they only go back to bed when they are battling to keep their eyes open. If they fall asleep in 15 minutes after that, great. If not, repeat the process. Lots of people will have tried this for 2 or 3 nights and they'll tell you it was awful and they slept worse than usual. And that's expected. This is not designed to make them sleep better on the night they do it. It's designed to ensure that that any time they are in the bed or the bedroom is spent asleep. And so over a period of many weeks, it will change their association with the bed so that the act of going to bed starts to make them sleep. And that's me. So I'm really happy to take any questions.
Fantastic. Thank you so much, Hugh. I mean, to be honest, I think I got it all wrong, especially that classical conditioning slide. I think I reversed, everything. But anyway, I loved it. And it seems that it's not only me that loved it, as we do have plenty and plenty of questions. So let's get cracking. We have a question by Dr. Chatterjee. Dear Dr. Selsick, can you please clarify the role between SSRI and nightmares? Despite the theorized view that they suppress REM sleep, and then brackets, which should reduce the frequency of dreams, I have very few patients who report frequent and quite vivid nightmares, particularly on sertraline when prescribed for PTSD, which is frankly a bit puzzling. I'm hoping that your expertise will help resolve this riddle.
Okay. So we can't fully resolve it because our understanding of the mechanisms behind sleep and behind nightmares is not that fantastic. But in a sense, we wouldn't necessarily expect PTSD-related nightmares to directly get better with SSRIs or SNRIs, simply because, as I said, PTSD nightmares can occur outside of REM sleep. They can occur in non-REM sleep. And indeed, normally in REM sleep, there should be no noradrenergic activity at all in the brain. Whereas in non-REM sleep, there is a reduced noradrenergic activity relative to wakefulness, but there's still activity. And so it's expected actually that you would get nightmares outside of REM. And certainly with a lot of the antidepressants, although they are relatively selective, they do probably also increase noradrenergic tone to some extent as well. And so we wouldn't necessarily expect that they would suppress PTSD-related nightmares. And that's why we need to use something like an alpha-1 blocker or psychological interventions.
Fantastic. Thank you. Thank you so much, Hugh. We have a really interesting question, to be honest, that I'm pretty sure that many clinicians, have out there. And it's also my frustration whenever, either I talk with a GP or even here at the King's College Hospital that I need special approval from the board about what? About melatonin. So Eleanor Rachel Tianga is asking, why can't you get melatonin over the counter in the UK?
It's just a historical thing. We're much more conservative here about medications in general, and particularly in the UK, there is an incredible suspicion of any medication related to sleep. When you look, for example, at the United States, at the range of sleeping medications they have available, at the range of options they've got, it's more than double what we have here, and it is incredibly frustrating. I do think that there will be some newer formulations of melatonin available, hopefully, as time goes on, which will increase our choice, but it'll still remain a prescription medication in the long term, is my impression.
Thank you very much. I mean, there is a question about psychological therapies by Tom Rollo Dalton. Do you know of any psychological therapies for restless leg syndrome?
So no, there aren't. There's no evidence really for it. In a related condition called periodic limb movements, which are unconscious leg twitches that happen during sleep, and it often happens with restless legs, there is evidence that CBT for insomnia improves sleep. But actually, with restless legs, there's no psychological interventions. There is some evidence for the use of exercise. It can make it a bit worse in some people, but in the majority of people with restless legs, regular exercise does seem to improve symptoms. And that's about the best we've got with non-medical interventions.
Fantastic. And then we have, there are so many questions, and some of them I have to say they're really interesting. Here is one that, so already reading it, and I feel, and I feel the passion. And the reason I'm saying that is because there was a similar question / opinion on BJ Psych, so the British Journal of Psychiatry. So there was this Professor Silverman that wrote an opinion letter to BJ Psych, and it was about questioning and supporting the longer use of benzodiazepines, particularly though for anxiety disorders. I've interviewed him last week. I have to say that, there was an uproar, mainly from patients, that they disagree about the long-term use of benzodiazepines, particularly from patients, obviously, that find particularly difficult to stop taking benzodiazepines. And I can't blame them, I have to say. So on a similar note, Sitske Mulder, I'm really sorry if I mispronounced your name, is asking, would you recommend long-term Z drugs for insomnia?
So I'll take a step back and say that my strongest recommendation is never to leave chronic insomnia untreated. It's an awful condition to live with. And it, as you said, it has such a huge impact on quality of life. And so it should never be left untreated. The first line for treatment should always be CBT for insomnia. But the problem is getting access to it. And it is improving, our ability, it is becoming more widespread, but it is often difficult to get. And although it does work remarkably well, it doesn't work for everyone. So if there is no option to get the CBT, or if you've tried CBT and it really hasn't worked for that patient, then yes, I would consider using a long-term hypnotic. Because, and you know, it's something to discuss with the patient, is that yes, there are some risks, as there are with any medication. And they can make an informed decision as to whether their quality of life is better with or without the medication, and whether those risks are worth taking.
And I mean, on a similar note, Ellen Bowman is asking, I have often heard that Z drugs give you poorer quality of sleep. Is this true?
So no, actually, that's not true. You know, when you look at sleep quality, both kind of objectively using polysomnograms, and more importantly, subjective sleep quality, because insomnia is really a subjective condition. We treat people by what they feel, not by what a sleep study shows. They significantly improve sleep quality. And actually, when you look at the sleep architecture in people on Z drugs, it looks like a very natural sleep. You don't get, with the benzos, you do get some suppression of deep sleep and some suppression of REM. So you do get a slightly unnatural looking sleep structure. But with the Z drugs, the sleep architecture looks entirely normal.
Fantastic. And from the dementia world, Jenny McCleary, and maybe you've already, touched on that. She's asking, I suspect that restless leg syndrome may be a relatively common contributing factor in evening agitation in my dementia patients. But this is hard to confirm, says Jenny. Any ideas about how to confirm that, how to investigate that?
Yeah, I mean, it is, I entirely agree. I think often the sundowning effect is a good likelihood that a lot of patients are experiencing restless legs. And if most patients can't describe what they feel like, someone who has difficulty communicating for whatever reason, whether it's dementia or whether they have a learning disability, is going to find it even more difficult. So yeah, things to really look for are, I guess, first of all, touching. Are they rubbing a particular body part a lot? Is there kind of lots of rubbing of the thighs or the back of the legs? Do some routine blood tests and check their iron levels. Also look at their folate, vitamin B12, vitamin D. And if those are low, push those up and see whether things resolve. And if not, sometimes the simplest way to do it is really just to treat empirically, to give a low dose of an anti-Parkinson's drug or of gabapentin in the evening, and see whether that settles it down and improves their it improves their symptoms.
Amazing. We have more questions, but I'm afraid that we need to move on. Hugh, thank you so much. Virtual round of applause for you. You really nailed it.
If people are happy to, I'm happy to stay on the chat and answer the questions on the chat while listening to the next talk.
Fantastic. It's totally up to you. Yes, you have access actually to the Q&A, so feel free to type the answer. Thank you very much for that. So thank you so much, Hugh, for making the time today. I do feel, to be honest, that sleep is an extremely underappreciated aspect, of the history that we definitely need to improve our skills on. But enough with sleep. Although I gotta say that, the next topic is going to feel a bit like a dream. Our next guest is not a psychiatrist, and that makes it even more interesting, right? I mean, there are enough of us in here already. With us, an Assyriologist from the Wolfson College at the University of Oxford. Having written on diverse topics in the history of the ancient Middle East, she serves on the management committee of Nahrain, an NHRC-funded project in sustainability and cultural heritage in Iraq and neighboring countries. and she's also on the council of the British Institute for the Study of Iraq. So what brings her here with us today, though, is her work in the history of science and medicine, focusing on the use of metaphor in the description of mental distress. So, London and Southeastern Division people, Dr. Moudhy Al-Rashid. Hi, Moudhy.
Hi, Posman. Very, very nice to be here. Thank you so much for having me. I know I'm a bit of a wild card, so I really appreciate the chance to talk about these texts.
Fantastic, nice to see you. And as you will all notice, we won't be sharing slides. We're just going to have an interview. So we're trying out new things for you. So, Moudhy, first of all, I have to say that I'm really, really jealous of this beautiful attic.
Thank
really,
you.
really beautiful. So, you can imagine how excited I feel to have you here. At last, someone that's not a psychiatrist, a neurologist, or a neuroscientist. And I can tell you, having an Assyriologist, one of our conference, this is amazing. But it is a first, but I have to say that I don't have a clue what your professional life entails. So before we even start and talking about mental health in the Assyrian times, can you please introduce us to the everyday life of an Assyriologist?
Of course, yeah. So it is actually a somewhat archaic job title that we're trying in the field to find an alternative to, but it describes a person who studies the languages and cultures of ancient Mesopotamia from about 3500 BCE up until the very late first millennium BCE, even a little bit into the Common Era. The key unifying feature of those languages and cultures is the use of a writing system called cuneiform, which I'm sure we'll talk about shortly in a little bit more detail. So an Assyriologist is basically someone who studies texts in cuneiform and the culture that can be reconstructed from it. And you have all kinds of texts, including ones that describe problems with sleep, lullabies to quiet a crying baby who won't go to sleep, also marriage contracts, receipts for surgical tools, detailed astronomical texts, all kinds of things. So it's a very interesting field. I'm glad to get to talk about it.
Amazing. So let's then transport ourselves back to these times. So we are, as you said, 3,500 or 4,000 years ago, right in the middle of Mesopotamia. So what's around me? So what do I see? What's the terrain like? What's the weather? The people, how do they look? What do they wear?
So we're talking about a pretty huge region across a pretty huge time period, but essentially Mesopotamia, which I think you will probably know as someone who speaks Greek, refers to the sort of land between two rivers. And those two rivers are the Tigris and Euphrates, which sort of begin in southern Iraq and then branch out all the way up to Syria. So we're talking about a region rather than a civilization. And it refers to a number of civilizations that rose and fell in this region over the course of thousands of years. So it does expand and contract to include some of the neighboring countries, including at one point Egypt in the first millennium BC under the last kind of bastion of the Neo-Assyrian Empire. So if you can just imagine sort of very fertile landscape, these lush reed beds alongside these rivers, which in turn allow for quite silty deposits of clay, which end up providing the medium for the method of writing, which is cuneiform, which is impressed into clay for the most part. But there's also regular flooding. So the geography of this area sets the stage for the need for a writing system. And this regular flooding developed or gave rise to the need to develop irrigation agriculture, which in turn made agriculture so good that they needed a way of keeping track of all the different things being funneled through the state from agricultural products. And this is what gives rise to the need for writing. And so there's a really like a strong connection between the landscape really and the development of writing. And cuneiform is a writing system, not a language. It's used to write multiple languages, including Sumerian, the earliest known written language, Akkadian, and then later an Indo-European language called Hittite, as well as a few other languages. The language of the medical text that I hope we're going to talk about is Akkadian, which is the earliest written Semitic language. It's an East Semitic language. So it's related to modern Hebrew, Arabic, and other Semitic languages still being used today. And it's recorded by both Assyrian and Babylonian scholars in the first millennium BCE. So that hopefully I can narrow a little bit down what we're going to be talking about.
Amazing. And unsurprisingly, one of the first things that attracted our ancestors' attention was their body, its functions, its malfunctions, and everything in between. And while most people think about Hippocrates when talking about medicine in the ancient times, The truth is that Hippocrates was trending in the ancient Twitter around the 5th century before Christ, but the history of medicine goes way beyond that. And it seems that Babylonians and the Assyrians were quite good at it. So tell us about the Asu and the Asipu and the Babylonian NHS, if you like.
Yeah, of course. So I will actually, I'll say that the earliest known medical texts from ancient Mesopotamia come from around 2500 BCE, so around 2000 years before Hippocrates. So yes, a very long and interesting history. But if we fast forward a little bit to Assyria and Babylonia, which again is the 1st millennium BCE, and a little bit before that in the 2nd millennium, you have these two types of medical professionals working. The first is the Asu, which is often translated as physician, and the second is the Ashipu, who is often translated not unproblematically as exorcist. And this sort of reflects modern designations more than ancient ones, because there was a lot of overlap in what they did. But the Asu essentially worked with medical treatments, so salves, actual medications made through mixing herbs and minerals with beer or water, rarely water, more beer, fumigations, the sort of what we would consider medical. And the Ashipu worked with the supernatural element in disease causation, which again sounds bizarre to us, but supernatural things were just as real as natural things. So that is again a modern designation. And they worked to appease the angry god or goddess that is ultimately behind a snake biting somebody or a fever,
Wow.
someone over. So this is two medical professionals that work together, or in competition, actually, evidence of both, to treat illness and that master these different ways of doing that.
And I have to say that, being a doctor in the Assyrian times wasn't an easy endeavor. Not that it's easy now, but I was reading that, if a slave died as a result of an operation, then the surgeon had to replace the slave by another one. If, however, a free man died or lost an eye, for example, through an operation, then the physician's hand would be cut off. And it's, I find really interesting, how the value of life, if you like, is dependent on one's status. So not much has changed, it seems. So were class and race inequality is evident even that back in time?
So those are notoriously difficult questions, very interesting questions, but notoriously difficult to answer, because I don't think race and ethnicity would have been constructed in the same way that we do today. And it's really hard to find that information in a textual record. So for example, the name Layla is quite popular in the UK, but that doesn't mean everyone named Layla is actually from the Middle East, because it's an Arabic name that means sort of dark beauty or night. So it's just in the same way, it's hard to say, well, this person has a Babylonian name or a Kassite name, which is a different sort of tribe, and say, oh, they're definitively of this or that population. But nevertheless, the laws do give us some ideas about social classes. So Hammurabi's laws was composed around in the 18th century BCE, and it survives in many, many copies. It continues to be copied for over 1,000 years afterward. And the most famous manuscript is actually a stela that is now on display in the Louvre Museum. And it has these very interesting clauses about, I guess what we could say is medical malpractice or something like that, if you want to be a bit anachronistic about it. But it's an interesting way to frame it. So it tells us a bit about the possibility that medical activity was regulated in this way. We don't know the extent to which Hammurabi's laws reflect actual legal practice. This is an ongoing debate in the field, a very interesting debate. But nevertheless, someone wrote this stuff down. So it does tell us that, a slave's worth at the time was a monetary value, whereas an awilum, which is another source social class, was more than that. So certainly we can reconstruct those kinds of inequalities from the legal text, but also many, many other texts, administrative texts, and even literature gives us some clues about this kind of thing. But from a strictly medical perspective, it's also interesting because it tells us the surgery was performed as early as the 2nd millennium BCE, probably much earlier. They may have performed it with bronze tools, which is the reference in Hammurabi's laws is a bronze scalpel. And there is some archaeological evidence to bear this out. In the 1st millennium BC, there are surgical tools that have been recovered from Babylon. And there are even administrative texts like receipts where people are purchasing metals to create surgical tools. So all of these texts sort of work together to give us a bit of a medical picture as well as a social picture.
I mean, what is really impressive, though, is that Assyrians had their own diagnostic classification system. I mean, Labat in the 50s wrote that illnesses during the Assyrian times were organized in two major collections, known as the diagnostic and therapeutic series. So tell me more about it.
Yeah, sure. So both Assyrians and Babylonians would have used these texts and wrote them down, and they're sort of found in many copies throughout the entirety of what is now Iraq, Syria, and even beyond in sort of Turkey area that's now Turkey. But the diagnostic series it's about 40 tablets long. So if you imagine something that's 40 pages long, just pretend the clay is paper, and it's a little easier to picture.
And it's heavier.
Yes, it's a little heavier and more breakable, but also more preservable, which is why they're still here. So it's 40 tablets long. It's divided into 6 chapters, and the main chapter, which is chapter 2, organizes symptoms from head to toe, which I think you see in the later Hippocratic corpus as well. But there's also chapters that are sort of thematic. So there's one on seizures, which has often been called the epilepsy chapter. One about pediatrics, so babies and pregnant women get addressed. And then there's this kind of related or parallel therapeutic handbook or encyclopedia that is still being put together, and it's best known from a catalog, which is basically a table of contents found in Ashur, in the heartland of ancient Assyria, but it's also known from copies of the different chapters in it found in Nineveh, the famous library of Ashurbanipal. There was a wonderful exhibit about Ashurbanipal at the British Museum a couple of years ago. And it has sections dealing with also remedies ordered from head to toe, but again, thematically organized ones, including sections on skin diseases, surgery, and also mental conditions, specifically something that translates to heartbreak, but also there's description of fear and screaming in bed, that sort of thing. So there are all kinds of mental components in that chapter.
I mean, it's interesting to hear you say that, because a paper titled Neurology and Psychiatry in Babylon, it was published in Brain in 2014. So Edward Reynolds and James Kinane Wilson argue that our knowledge of Babylonian descriptions, understanding, and treatment of psychiatric disorders is derived from various tablets and texts unrelated to the medical, diagnostic, and therapeutic series that you just described, essentially reflecting the usual perception of psychiatry as an outcast of medicine. And they even go on to comment that the Babylonians had no knowledge of the brain or psychological function. Is that so?
So I would disagree with some of that. I would say there was, if you want to be really pedantic, which I don't want to be, but I will just say it because it's interesting. There is terminology for the brain. That sometimes a literal translation would be skull marrow. So they were aware that there was something in the skull, even though they weren't as aware of internal organs in a human being as, say, the Egyptians, who performed very elaborate embalming rituals on the dead. So there wasn't that kind of surgical accuracy. But there are even some texts that suggest they thought fevers could affect the brain, and it is possibly the brain is also possibly referenced in late Babylonian medical texts, so after 500 BCE, when the medical texts get really interesting. But even if they didn't assign the brain as this seat of cognition, there was certainly an awareness of psychology, in the sense that the seat of cognition and emotion was assigned to a different part of the body, which was called, one of those is called the libu, which translates very widely, but I would say heart is a good translation for that. And you think, you can speak to yourself with the heart. It can break, it can do all kinds of things that suggest that this was a cognitive part of the body. This was a cognitive organ, or an emotive organ. It's
really interesting, because it sounds like they clearly describe symptoms of what we now call neurological and psychiatric disorders. I mean, you've already mentioned about epilepsy, for example, although it seems that all the descriptions were objective, which is not uncommon, as subjective accounts of feelings, thoughts, and behaviors are a relatively new phenomenon in medical texts. So can you give us some examples of some of the disorders that they described?
Yeah, that's a really important distinction, because it also speaks to how difficult it is to try to identify any kind of modern anything in the ancient texts, because they were describing it from a completely different perspective, and one that relied purely on observation. So they couldn't tell you what was actually going on in the brain. They can only tell you based on behavioral changes that might signal something going on in the libu or the brain, or wherever else they might have assigned the causes for that. So there are tons of examples of, let's just call them mental symptoms to be as general as possible in the texts. So we can still meaningfully talk about them, I think, from that as kind of symptoms being the common denominator, even if the disorders are very different and understood very differently. And you have descriptions of disturbances in thought, so confusion, for example. There's a term that expresses an interruption in thought in Akkadian that is a change in mind. That's what it literally translates to. But based on context, we think a better translation, as general as it is madness, or something comparable to that. And in descriptions of that symptom, you find it paired with things like speech problems, so a tongue that continually wanders, speech that continually gets interrupted or changes, speech that stops. So there are, again, behavioral clues to what might be going on inside. There's also this very interesting one called seizing of the mouth that has its own kind of text tradition associated with it. But sometimes it's associated with stroke, mishitu. Sometimes it's said that it's specifically not a stroke. So what could it be other than that? But there are also descriptions of disturbances in mood. So depression, there are several terms, lowercase d, that describe depressed states. And those are described again with symptoms that may be familiar to a modern context for the description of depression, like having trouble sleeping, loss of appetite, again, quite behavioral descriptions. And then anxiety, which is what I look at specifically. There's a lot of terminology for fear. There's an entire section of the therapeutic encyclopedia that we talked about dedicated to fear, and tenseness and heartbreak, which I translate as a form of anxiety. It sounds quite romantic, but I think they're just locating the kind of feeling that you get when you're anxious in the torso region.
Amazing. Amazing. You know, Dodds in his paper, Greeks and the Irrational, back in the 50s, says that the Greeks recognized 4 types of divine madness associated with particular gods. He described, prophetic madness linked to Apollo, telistic or ritual madness linked to Dionysus, poetic madness linked to the Muses, and of course, erotic madness linked to Aphrodite and Eros. So what was the situation with gods, spirits, and the supernatural in the Assyrian times?
So yeah, this is another really important question, because it's basically how all natural phenomena are understood with respect in some way to what we would consider supernatural phenomena, but were as real as rocks and trees and anything else in ancient Mesopotamia to the people writing these texts. So in terms of mental or in terms of illnesses with a mental component, there was no special influence of the spiritual sphere on that. Demons, gods, goddesses, ghosts, witchcraft are responsible for any kind of illness, and there is some patterns to how these are organized. So these are some of the causal agents of disease. There are also natural causes that get recognized, like sun causing sunstroke, or a snake biting you, or a scorpion sting, that sort of thing. But there are certain causal agents within that supernatural realm that are regularly organized with what we have been talking about as mental symptoms. Divine anger is one of them. So angering a god or goddess is a great way to invite anxiety into your life. Ghosts, particularly ones who wander. So different kinds of ghosts are responsible for different kinds of medical experiences. And sometimes they're very specific, like ghosts who drowned or ghosts who died in a fire, that sort of thing. So really kind of unsettled spirits are responsible for causing medical problems. And they are also responsible for diseases or illnesses with a mental component. This may also be a pun, because the word that I translated earlier as brain, temu, the word for ghost is etemu, so who knows, maybe there's some sort of philosophical gymnastics at play. But they may also reflect some understanding of reality. And then again, witchcraft is another supernatural disease agent regularly associated with mental symptoms. So the medical tradition makes use of all available explanations, and this includes supernatural ones. So again, it's not limited to mental or emotional disorder. It applies to everything.
Now, the ancients were really creative and imaginative when it came to interpreting symptoms. The ancient Greeks, I know I'm talking a lot about Greeks, but, I'm biased. They talked about how the uterus moves inside the body of women, causing them a wide range of symptoms, all conveniently clustered under the name hysteria. But one of the greatest misconceptions that survives even nowadays, in one form or another, is the central role and you've alluded to that a bit, that the heart plays in our thoughts and emotions. And interestingly, you wrote about a cuneiform tablet. Essentially, as you've already described, these are clay tablets, correct me if I'm wrong, and words inscribed, on them, that is now housed in the British Museum. And since I mentioned the British Museum, I feel compelled to kindly ask to return the marbles back to Greece. But back to the point, this cuneiform tablet talks about clear symptoms of anxiety produced by a broken heart.
Mhm. Yeah, so this is, again, this expression is the focus of my research, and I think it's a really interesting one because it employs a kind of metaphor that somehow randomly resonates also today. But I think the broken heart, in my understanding, is the anxiety in depending on context in the use. So again, a crash course in the Akkadian language, the libu is the word that we find in this expression, and it can refer to the stomach, it can refer to the actual heart that beats, it can refer to just the chest region, the belly more generally. And then the other element of the expression is khipu, which means break. So it is like some kind of a literal translation. But based on the way it's used, it is often organized with things like fear, with different words for fear. It's organized with sleep, being kept awake at night by your fear, nightmares as a result of those worries and fears, as well as different terms for depressed states. So in my understanding of it, I think it refers to a type of anxiety. And there are several texts in the British Museum that come from the library of Ashurbanipal that are texts that are geared to dealing with issues caused by witchcraft, which can include a variety of issues. And many of them refer to this heartbreak. And then there's another one that's currently in Berlin that is just a therapeutic text dealing with heartbreak, and it organizes it with fear, grief, and again, other emotional experiences you'd associate with anxiety. I think, again, it's a very relatable way to describe distress, one that actually you find the scholars using in the court of the King Ashurbanipal, saying, I haven't been paid, I'm dying of heartbreak. Well, all my other colleagues are being treated so well, and I'm being treated poorly. And then there's a specific scholar called Urad Gula, who's a physician who was outcast from the court. I don't remember why. I don't know if we know why. And his father also writes on his behalf saying, we are all dying of a broken heart as a result of the way we've been treated. Can you please reinstate him? So it is not just in medical texts. It's, these are medical professionals using them, but it appears in other non-medical sources. Literature also, sorry to throw that in.
Amazing. Okay, so let's move from etiology to treatment. In a recent publication on JAMA, so the Journal of American Medical Association, and when I say recent in the grand scheme of things, as it was published back in 1914, so Maurice Jastrow of the University of Pennsylvania reviewed some of the features of the medicine of the Babylonians and the Assyrians, with knowledge mostly derived from a library of King Ashurbanipal of Assyria, correct me if I'm wrong, and the paper is fascinating. They're talking about the various different therapies that were being used, mint, licorice, mustard, anise, but also a bit more, I would say, questionable tactics. And I quote, they say, let him kneel on his feet and let cold water flow over his head. Place his head downwards and his feet up, strike his cheek forcibly, rub him violently, say to his stomach, be good. With the left thumb, manipulate his buttocks 14 times and roll him on the ground. Doesn't sound really pleasant. So any notion about how they were treating mental illness?
So I'm not familiar with that specific text, which sounds a bit like a very colorful treatment for, I'm not really sure. But in the same way that you have these two medical professionals, the Asu dealing with what we consider medicine, the Ashipu dealing with magic. And in the same way that you have sort of two levels or even possibly three levels of causation, where you have a natural cause that's visible like the sun or a snake, and then the supernatural causes like witchcraft, demons, ghosts, or gods and goddesses. Treatments address both of those angles. So for example, there is a treatment for irregular bleeding in a gynecological therapy text that involves both a kind of incantation to be recited over a rub, like an oil, and then the oil is rubbed on the belly to try to address, pain and excessive bleeding. So it combines this kind of magical and medical element. Again, modern distinctions, but they help us try to understand what's going on. So in the same way, for mental symptoms and illness, you have a two-pronged approach, and you'll often have a ritual or incantation, so a spell to be recited that is addressed to the supernatural, the identified supernatural source, like God or goddess. And then you have something that they can drink, like with mint, for example, steeped in beer, usually because it's cleaner than water, that the patient would then drink in addition to this incantation. So there are two approaches in any kind of medical treatment, but especially, including, not especially, those illnesses that have a mental component as well.
I mean, in one of your articles, building on the notion that there was no separate category for mental health and other physical illnesses, you suggest essentially that there was no special stigma, if you like, attached to mental distress. And now I'm getting a bit more philosophical. Is then stigma a byproduct of the mind-body dualism, you think?
I think that's such an interesting question, and I would love to explore it more. I really don't know. I know that, I do know for sure that there was not the same separation in ancient Mesopotamian medical texts, Babylonian, Assyrian, doesn't matter, between what's going on in the body and what's going on in the mind. Everything to do with mood is described alongside, physical or physiological symptoms as well. Maybe that's because they were easier to treat, maybe because they were more visible, easier to describe. Who knows? Maybe it's because of their medical understanding of the body as not being mind-body separation. What I do know is that there was no special supernatural element to mental illness. And maybe that's part of the very early history of the stigma attached to mental illness. Again, I can't really speak to that in a very knowledgeable way. Whereas in Mesopotamia, everything had these kind of shared repertoire of causes. So there wasn't anything special about mental illness in that regard. So that's maybe the first way I might approach that, but it is such an interesting question, and I think we'd have to dig deep into the sources of stigma today and how to destigmatize it to try to really get to the heart of that, the libu of that.
And when I approached Moudhy, to ask her and come here and talk to us about mental health in the Assyrian Empire, she replied and said, yes, it would be great to talk about mental health in the Assyrian Empire. Oh, and by the way, I could also talk about astrological medicine, which is definitely not an option when I was choosing specialties. So let's go a bit off-piste and talk about astrological medicine. What the hell is that?
So so one of the reasons I love talking about astrological medicine is because I get to talk about the zodiac, which is one of the legacies of ancient Babylonia from around the middle of the first millennium BCE. They create the celestial coordinate system by dividing the sky into 12 equal segments of 30 degrees. It's a reflection, in a way, a kind of spatial reflection of the way they organize time. They organize the year into 12 equal schematic months of 30 days, and that sort of just projected onto the sky, as it were. But what the zodiac does, is it allows for other types of information not related to astronomical phenomena or observations of astronomical phenomena to be organized in the same kind of way, in this kind of bounded scheme. And so astrological medicine associates the zodiacal signs, their appearances, or the appearances of phenomena in those signs with treatments or symptoms going on in the body. So why I think it's interesting is that before the zodiac is developed, knowledge is organized in a kind of list format where you have an expansion of an initial situation using incremental variables, and you see this in all of the medical texts. Whereas after the zodiac, instead of trying to be exhaustive by listing every possible symptom, every possible illness or cause, they try to fit it into this more manageable celestial coordinate system that then gets applied to non-celestial things. So another word for this is melothesia. You do see it in the Greek sources as well, in the ancient Greek sources. And then it thrives all the way into the Middle Ages. I don't know if it's still in vogue in circles today. I haven't the faintest idea, but it is interesting for its kind of window onto intellectual history, as well as onto the way the body and treatments of ailments eventually get organized in the late first millennium BCE.
Amazing. I mean, according to Herodotus, it was a common custom in Babylon to to lay the sick in the public square so that passers-by who had suffered from similar complaints, similar symptoms, might give them advice as to what proved beneficial in their case, like a more social version of Google and online forums, if you like. And interestingly, there was a recent paper in JAMA Psychiatry talking about the effectiveness of peer-delivered self-management for rare chronic diseases. And it's fascinating how little things have changed. So on that note, do you feel that they did anything better than us nowadays? Or if you like, what can we learn from the Assyrian colleagues of the past?
So yeah, I want to just before I answer that question, I want to say there, if I may plug a colleague's book, which is open access, called Medicine in Ancient Ashur, that does tell us quite a lot about how did a doctor get to a sick person? What were the kind of rules governing that? So if anyone's interested in that, I won't attempt to summarize this incredible book at any point. But in terms of what they may have done better or not done, I don't know if they necessarily did anything better that we can kind of mine and use and apply to modern medicine. But what I do think we can learn from them is that, we have this shared domain of inquiry that you opened with, that the human body has always been something of interest, and illness has always been around. So treating it has always been something people have tried. So I think what we do learn about the history of medicine is kind of a history of how the body was understood in different ways, but also a history of people doing their best to make sense of chaotic experiences that are very close to home, that are literally taking place in your person or in the person of a loved one. So I think that's really what we can get from these sources, and how some of these problems are very, very old, like depressed states or anxiety or any epileptic type of symptoms, and how we've been doing our best really for a very long time.
So Moudhy, one of the most famous aphorisms comes from Professor Jorge Santayana, Harvard, who said that those who cannot remember the past are condemned to repeat it. And who better to remind us of the past than historians, right? But being an Assyriologist, being a historian, do you feel listened to, or do you feel like an alarm that people keep on ignoring and snoozing until it rings again?
A bit of both. I think history is complicated. It's, there are a lot of sources that you have to comb through. There's archaeological evidence that you have to comb through, and we have to revise it constantly. We revise our methods constantly, our standards, but also the actual histories we write. We're like, oh, I made a mistake, 10 years ago writing about this, because now we have all this new evidence. So I think there is a kind of desire sometimes to simplify it and make it fit, current agendas. I won't say any more than that. But I think it can also be used for good. It can be a very powerful force for good. So projects like Nahrain, which I'm privileged to get to be a part of, works in Iraq in, sort of using history to, bolster people today, making past present. It's a project in cultural heritage and sustainability. So I think history can be used for good. It can also be misunderstood or used for bad. So do I feel listened to? Another half hour.
So Moudhy, last question for today. You were featured in History Today, and I have to say that unwillingly, you broke my heart. So you were asked a really simple question: Rome or Athens? And you gave the wrong answer. You said Rome. So what is it that you have against the Greeks?
Nothing. And if I may revise my answer, we're talking about revision. I would like to revise it to Babylon, if that's okay with you.
Fantastic. Thank you so much. Ladies and gentlemen, this is Dr. Moudhy Al-Rashid. Honestly, that was amazing. And it certainly, I feel at least, that it highlights to an extent, the universality, if you like, of the experience of mental health and distress, beyond the constraints of space and time. And it's fascinating because, in half an hour, we managed to travel 4,000 years back in time. But we can remain stuck in the past forever, whether we like it or not, right? We got to move on. Actually, no, I have a better idea. Let's take a short break and we'll be back in 10 minutes, actually 12 minutes. So don't be late. You'll be breaking our next speaker's heart. See you all at 11:30. Hope everyone can hear me and see me. I mean, basically hearing it's much better. So welcome back, everyone. Hope the juice was cool, the toast crunchy, and I know maybe you would have wanted, another 5 minutes to chill out, but life is too short to chill out. I mean, we managed to travel 4,000 years back in time in just 30 minutes. So I hope you enjoyed our interview with Dr. Moudhy, Al-Rashid, and how Assyrians perceived mental health and heartbreak. I mean, just by saying it, there's something about bloody heartbreak, which is actually the link that joins Mesopotamia with the next talk, which is titled, Don't Go Breaking My Heart. No, sadly, there will be no romance here, though our next speaker is a romantic soul indeed. He's an unstoppable clinical academic force. He studied medicine at the University of Oxford, graduating with distinction, please, something that honestly makes me feel exhausted even just thinking and even talking about it. A member of the Royal College of Physicians, he quickly found the right path in life. And he said, you know what, I just want to become a psychiatrist. And he joined the Psychiatry League, luckily for all of us. An NIHR-funded clinical researcher, he has been working tirelessly at the Moudhy Hospital, predominantly specializing in the care of patients with psychotic disorders. In fact, he's so good that in 2019, the British Association for Psychopharmacology had no choice but to give him the award for outstanding research in clinical psychopharmacology. What brings him here today, though, is his commitment to improving the management of comorbidities in people with serious mental illness. So today, he will be focusing on a common headache for every prescribing clinician, and an even bigger headache for our patients: antipsychotics and cardiometabolic health in schizophrenia. As always, you can use the chat room for your comments. You can use the Q&A tab to send all your questions that I will be asking to Toby right after the end of his talk. Dr. Toby Pillinger, welcome.
Thanks a lot, Pospo. Let me just get my my slides going.
Fantastic.
There we go.
Great. We can see and hear you. Great. Go for it.
Thanks, Pospo. Thanks, everyone. It's a pleasure to be here. So yes, as Pospo mentioned, I'm going to be covering what I think is probably one of the most important topics in the field of psychiatry at the moment. Well, I would say that, but that's the physical health of individuals with serious mental illness. And today I'm going to be, focusing predominantly in people with schizophrenia, but I think there are a lot of take-home messages and that can be applied, across the field in psychiatry. And these are my disclosures. Before I get into the sort of bread and butter of the talk, I think it is worth highlighting sort of my clinical and academic career to date, because it does serve to contextualize some of the material that I'll be talking through. And it also sort of satisfies my penchant for looking at pretty hospital buildings from around the country. So as Posto was saying, I did all my training, but I also did my foundation training in Oxford. And I think I was one of the last people to do any work in this hospital, the Radcliffe Infirmary in the top left-hand corner, which is, I think it's been since turned into the maths department at Oxford. Lucky mathematicians. And I didn't go straight into psychiatry. I did a bit of general medicine and working at this hospital here, the Hammersmith, and then the far right-hand corner, the Royal Brompton, for a few years, doing jobs such as renal, haematology, respiratory medicine, haematology, etc. And then in 2015, I finally took the plunge. I moved south of the river to the Maudsley and to the Institute of Psychiatry, and I started a research fellowship. But at the same time, I worked as a doctor in a community service looking after people with treatment-resistant psychosis, facilitating community access to clozapine. I did that for several years. And it was really when I made that transition from working at the Brompton to the Maudsley that my eyes were opened to the significant burden of physical comorbidity seen in patients with serious mental illness. And I remember marveling, sitting in the Maudsley outpatients, seeing people on behalf of because they had treatment-resistant psychosis, but I was marveling because not only did they have such a burden of psychiatric morbidity, but they also presented with a burden of physical comorbidity that I rarely saw in these tertiary care physical health hospitals, the Hammersmith, the Brompton, and yet these were individuals who were, pretty much, very generally speaking, poorly engaged with physical health services, both primary and secondary physical health services. And it was really that experience that prompted a lot of the research that I've been doing over the last few years, predominantly focusing on cardiometabolic health in people with serious mental illness. I'm going to be covering a few of those papers today. background that I know you already know, but we have to underline it because it is really important. We know that people with schizophrenia die 15 years earlier than members of the general population. Well, actually, it depends which epidemiological study you read. Some people estimated up to 25 years earlier. And we also know that the majority of that excess mortality is not due to death by misadventure, death by suicide, but it's physical health conditions and predominantly cardiovascular disease. And related to that, we know that the prevalence of all those cardiovascular risk factors that we know about are startlingly higher in individuals with schizophrenia. Across the board, it's sort of 2 to 3 times higher the rates of these risk factors. But of course, in some patient groups, such as those with chronic established schizophrenia, looking at rates of diabetes or the metabolic syndrome more generally of sort of 60–70%, so startlingly high. And this is a slide that just reminds us that the reasons for elevated cardiovascular risk in people with schizophrenia and people with serious mental illness more generally is of course multifactorial. We know there are lifestyle factors, poor diet, reduced levels of exercise, increased rates of smoking that play a role. We know that individuals with schizophrenia are less likely to present to physical health services with a problem, and when they do present, they present later. And as we know in across medicine in general, the later, the more advanced a condition is, the more difficult it is to treat. In the bottom right-hand corner of this slide, I've mentioned that people with schizophrenia, when they do present to physical health services, are less likely to get that same gold standard quality of care that a member of the general population might receive. And a very clear example of that is the rates of angiograms and stents being fitted in individuals presenting with a myocardial infarction. So if you present to A&E with chest pain, a troponin rise, ECG changes, all indicative of a heart attack, but you have a diagnosis of schizophrenia, that having a diagnosis of schizophrenia on top of all of those same presenting factors, blood test results, ECG findings, means that you are 10% less likely to have an angiogram than a member of the general population with exactly the same presenting complaint. And that translates into a 10% increased mortality post-MI in this patient group. We know that antipsychotics play a role, and I'm going to be talking about them today, as Posporelis was mentioning. And also there's an evolving body of evidence that might suggest that psychosis or schizophrenia in its own right may induce some form of intrinsic cardiometabolic risk. And this is very much going down the lines of us reconceptualizing psychosis as a multi-system disorder. And I'm also going to be presenting some evidence to suggest that today. Indeed, I have generally four main objectives that I'd like to try and get through. Number one, I'm going to be considering the evidence for whether or not there is evidence of intrinsic metabolic dysregulation in people with psychotic disorder. So forgetting lifestyle factors, forgetting medication for a moment. And once we've achieved that, I'm then going to be talking about antipsychotics and with our prescribing hats on, how should we be guiding our prescribing decisions based on, the most recent evidence. And I'll be presenting that data to you. Then I'm going to be describing the first ever cardiac MRI study performed in people with schizophrenia that we published a couple of years ago. And really that's a focus on whether or not, forget the indirect effects that antipsychotics might be having on the heart via metabolic dysregulation. Here I'm going to be talking about whether or not antipsychotics might actually have a direct effect on the heart. And then finally, I'm going to be considering, what can we do as psychiatric practitioners in terms of improving the physical health of people with schizophrenia and more generally the physical health of people with serious mental illness. So on with the show. So is psychosis associated with intrinsic metabolic dysregulation? Unfortunately, I did not come up with this concept. It is actually quite an old concept. And if any of you have spent any time at the Institute of Psychiatry, you will recognize this statue because it sits in the stairwell of the IOP, I think on the first floor, maybe the second floor. It's been such a long time since I've set foot there that I need to remind myself. But 4 years ago, I decorated this statue of Sir Henry Maudsley with Mars bars in recognition of the fact that actually he was probably one of the first people to make a link between diabetes and psychosis. He wrote in 1879 something along the lines of, and I'm going to paraphrase here, that diabetes is a disease which often shows itself in families in which insanity prevails. Less politically correct times, of course, I think by insanity we can assume that he means psychosis. But remember, 1879, this is in an era where diets were far less diabetogenic, if you will, and of course it predates antipsychotic discovery by decades. So what was it that, Sir Henry Moudhy was observing here? Is there truly some intrinsic link between glucose dysregulation and psychosis? Well, of course, we know that people with established schizophrenia present with higher rates of diabetes, but of course we know that, very much likely related to lifestyle factors, antipsychotic medication, as my previous slides have suggested. But what about in people where those sort of confounders of lifestyle and medication are limited or absent? So what I'm talking about there is people at the onset of psychosis, the first episode of psychosis, and individuals who are antipsychotic naive. Now, if you look at prevalence of metabolic syndrome of diabetes in these individuals, which Alex Mitchell at the University of Leicester has done a few years ago, interestingly, the rates of diabetes don't seem to be actually that much different between first episode psychosis and matched members of the general population in terms of age. The problem with looking at the prevalence of diabetes in this sort of patient population is twofold. Number one, we know that there is a risk of, we know that patients with psychosis don't present as readily to physical health services. There's a risk of underreporting, so those prevalence data are undermined by that. But also remember, the natural history of diabetes is such that you don't just, generally speaking, develop diabetes overnight. It develops on a continuum, as this slide shows, and that continuum is over a period of up to 10 years. As this slide, this is basic stuff from medical school, showing the development, the natural history of type 2 diabetes. As you eat more and more Mars bars, your insulin secretion, as shown by this violet line here, is increasing. Your peripheral tissues are getting bombarded with insulin, start to become resistant to the effects of insulin. Your pancreatic beta cells are working hard. They start to give up the ghost, and eventually your body can't keep up with the continuous influx of glucose, and your postprandial glucose and your fasting glucose starts to creep up until you meet that arbitrary line in the sand, defined by the American Diabetic Association, the WHO, NICE, whoever you want to look at, that arbitrary line in the sand for meeting the criteria for diagnosis of diabetes. Now, if that takes 10 years, and you think about the age range of people with psychosis, it could well be that you've got people who are developing diabetes and a higher increased rate, numbers of those individuals who are developing diabetes, but they haven't yet met that line in the sand. And there may be a greater number of those individuals with glucose dysregulation, although not meeting the criteria for it, compared with members of the general population. So in this slide here, this yellow highlighted area. So what I set out to do was to essentially look at absolute numbers, to look at levels of glucose, glucose levels after the oral glucose tolerance test, levels of insulin resistance in patients with drug-naive first episode of psychosis compared with healthy controls. And we did it using a meta-analysis that we published in JAMA Psychiatry. For those of you who aren't experienced of reading meta-analyses, it's very simply that it takes a series of studies that are all asking the same question. Are glucose levels raised in patients compared with controls, combine those all together, and summarizes them with an individual summary effect size. And you can show that diagrammatically with a forest plot, as shown here on the right. You have all the different individual studies with a square, with a bisected by a horizontal line, and then that diamond at the bottom summarizes all of those studies above it. And as you can see, if you compare fasting glucose levels in patients with drug-naive first episode psychosis compared with controls, there is evidence of increased fasting glucose in patients. If you look at the gold standard measure of glucose dysregulation, the oral glucose tolerance test, again, elevated glucose in patients compared with controls, elevated fasting insulin in patients compared with controls, and elevated increased levels of insulin resistance in patients compared with controls. Now, the critics or the reviewers of the study, had reasonable concerns and made, the comments that, well, hang on a minute, we know that patients in the prodrome are far more likely to, we know that they already present with lifestyle factor and poor diet, reduced levels of exercise compared with healthy controls. So presumably there is residual confounding, and we agree with them. So we did some sensitivity analyses where we only looked at those studies where patients in controls were matched for diet and exercise, matched for BMI, matched for ethnicity, because of course we know that different ethnic groups present with a greater preponderance towards developing diabetes. And where the data were available for us to do those sensitivity analyses, the results were maintained. Elevated glucose levels, evidence of glucose dysregulation in patients with first episode psychosis who were drug naive compared with healthy controls. Now, the take-home message from this, forget for a moment whether or not you want to think about whether or not there is some intrinsic process going on that might explain mechanistically what is going on in terms of elevated glucose dysregulation in drug naive first episode psychosis. The actual take-home message is that when you see someone in clinic with first episode psychosis, before they've had an antipsychotic, they are already further down the line, on average, towards developing diabetes than a member of the general population of a similar age. And so we should really, it might arguably, be considering diabetes right from the onset of psychotic illness, and not from the moment that we pick up the prescribing pad, essentially. So Sir Henry Maudsley looked at diabetes, looked at glucose for the first time, but what he didn't do was look at cholesterol. And so the natural next step for me was to look at cholesterol levels in drug naive first episode psychosis, because if the critics of the first meta-analysis were correct, saying, well, you know what, this is just residual confounding of lifestyle, diet and exercise playing a role, if they were correct, then you would assume, if you did exactly the same study looking at absolute levels of cholesterol, triglycerides, etc., you would assume that if it is diet and exercise playing a role, that cholesterol levels would also be elevated in patients compared with controls. So we did exactly the same study again. We published it in the British Journal of Psychiatry. And what did we find? Well, very interestingly, we found exactly the opposite to what you might have expected if diet and exercise were playing a role, because what we showed is that total cholesterol in drug-naive first episode psychosis was reduced in patients compared with controls, as shown in this slide here. And then, and furthermore, LDL cholesterol, so-called bad cholesterol, is also reduced in patients compared with controls. Interesting finding. The take-home message from this, again, regardless of mechanisms, I'm going to come on to mechanisms in a moment, is that raised cholesterol that you see in people with established chronic schizophrenia, you do not see in first episode psychosis, and therefore arguably is a secondary factor, and you know, we should be thinking about it as being preventable. How do we explain this conflicting sort of these conflicting messages of insulin resistance combined with reduced levels of cholesterol? We can't specifically answer it, but I do have a theory, and one that we're looking to in the moment. In 2018, we published a schizophrenia bulletin, the largest meta-analysis to date, that looked at systemic inflammation, inflammatory markers in drug-naive first episode psychosis compared with healthy controls. And it didn't matter which way you looked at it. And I tried very much to disprove the fact that first episode psychosis was associated with systemic inflammation. So I looked at confounding factors, BMI, smoking, all those sort of things. It didn't matter which way you looked at it. Patients with drug-naive first episode psychosis present with elevated levels of inflammatory cytokines compared with matched population controls. So we're talking about IL-6, TNF-alpha, interferon gamma, etc. We also know that the more classic pro-inflammatory conditions, such as rheumatoid arthritis, lupus, have characteristic metabolic signatures. They present with insulin resistance, but interestingly, untreated rheumatoid arthritis and those other pro-inflammatory conditions are actually associated with reduced levels of lipids, of reduced levels of cholesterol. And the reason for that is that these cytokines, of course, have multiple jobs around the body, and some of them are adipose cytokines. The clue is in the name. They are fat signaling molecules, interleukin-6, TNF-alpha, and their role is to suck cholesterol out of the blood. That's one of their jobs. And so what you see in rheumatoid, the characteristic metabolic signature, untreated rheumatoid, is insulin resistance and low levels of cholesterol. And that's called the lipid paradox. The reason it's called the lipid paradox of rheumatoid arthritis is because patients with low LDL cholesterol with rheumatoid arthritis, which you would say, would you argue is good? You know, that's good in terms of your cardiovascular risk, low LDL cholesterol. Paradoxically, those patients have increased rates of myocardial infarction. It's a paradoxical association. And the reason for that, we think, is that because the reason they have low LDL cholesterol is because they are experiencing a pro-inflammatory state. And we know that systemic inflammation is an independent risk factor for cardiovascular disease and myocardial infarction, hence the lipid paradox. And my question is, are we actually seeing exactly the same metabolic signature in psychosis? We shall see. So we've talked about psychosis presenting with intrinsic metabolic dysregulation. But what about now, you know, the bread and butter of this talk, I would argue, the metabolic side effects of antipsychotics, and how should we be using data that is available to us now to guide our prescribing practice? Before I talk about the side effects of treatment, I think it is important to acknowledge the effects of treatment. So I'm going to just very briefly in the next few slides be running through the good, the bad, and the ugly of antipsychotic treatment. This is a paper that, you know, people talk about a lot, and for good reason. It is a very elegant study performed by Stefan Leut in the British Journal of Psychiatry, published 10 years ago now, or nearly 9 or 10 years ago. And in this sort of mega review, I think that's what you would call it these days, what he did was he took effect size magnitudes for how effective different general medical treatments were for classic general medical presentations, hypertension, headache, thyroid dysfunction, etc. And he compared how effective they were compared with classic psychiatric treatments, so treatments for depression, for psychosis, for ADHD. And he compared them up against each other, really just trying to say, well, to answer that argument, are psychiatric medications as good or worse than medical treatments available on the market? And the take-home message is shown in this figure on the right, where the white blobs show the effect size magnitude of general medical drugs. The blue blobs show the effectiveness of psychiatric medications. The higher you are up on the y-axis, the more effective the treatments are. And as you can see, generally speaking, across the board, in terms of psychiatric medications versus general medical treatments, our treatments aren't too bad, and probably outperform a lot of the general medical treatments. And then circled here in red is the effect size magnitude for the prevention of psychotic relapse by antipsychotics in people with established schizophrenia. It's an effect size of 0.9, so a large effect size. And as you can see, it's outperforming not only the majority of psychiatric medications, but the majority of general medical treatments. So these are effective, generally speaking, effective treatments. The other thing that's good about, psychiatric medication is that if you have schizophrenia and you are prescribed an antipsychotic, you are more likely to live longer than someone with schizophrenia who is not prescribed an antipsychotic. How do we know that? Well, Jari Tihonen from Finland has been looking at this for over a decade now. So he published this landmark study in 2009, I think, in The Lancet, where the Fin11 study, where he looked at the survival probability of individuals with schizophrenia prescribed an antipsychotic versus those who were not prescribed an antipsychotic over 11 years. And he published an updated version of this last year in World Psychiatry, looking at these individuals over a 20-year period. And he had data on 60,000 individuals with schizophrenia. And again, the take-home message from this study is shown in this figure here, this diagram here. You've got a Kaplan-Meier survival plot. You've got time on the x-axis up to 20 years. You've got the survival probability on the y-axis. Obviously, at the beginning of the study, everyone is alive, 100% survival probability. Then you've got a divergent two lines. One, which is light gray, which is those who have been prescribed an antipsychotic, and then the black line, those who have not been prescribed an antipsychotic over time. And as you can see, at any one point in time, those individuals who have been prescribed an antipsychotic live longer or have a greater survival probability than those who have not been prescribed an antipsychotic. So we have two good things. We have an effective treatment, and if you take the treatment, you're more likely to live longer than if you don't. But what is bad about these treatments? Well, we know that they have a whole host, or they have the potential to be associated with a whole host of side effects, and some of them are metabolic, and this contributes to that data that I was showing you very early on in this talk, which is that at any one point in time, we know that rates of metabolic syndrome and all the different components of the metabolic syndrome are 3 to 5 times higher in people with schizophrenia compared with healthy controls, as shown in this figure here across the age range. So on the far left hand, sorry. In this bar chart on the far left-hand side of the x-axis, you've got people aged 15 to 25. On the far right, you've got people aged 55 to 65. The blue lines show patients with schizophrenia and the percentage of those individuals who have the metabolic syndrome, compared with the yellow bars, which are those members of the general population. And you can see at any one point in time, you're looking at a 5 times increased rate of metabolic syndrome. And we know that antipsychotics play a role in this, and that translates into that very ugly statistic, which is that statistic of people dying 15 years earlier in those individuals with schizophrenia compared with the general population. The majority of that excess mortality due to physical health conditions and predominantly cardiovascular disease. And this is a study from Casey Crump, published in the American Journal a few years back, showing that the risks of death from ischemic heart disease are up to 5 times higher in people with schizophrenia compared with the general population at certain time points in their life. Now, how do we, again, I've given you some conflicting data there, or some conflicting statements, which is, I've said, well, antipsychotics are good, you live longer if you take them, but I've also said, well, hang on a minute, they increase the risk of metabolic syndrome, they increase the risk of cardiovascular disease, and you die as a result of that. How do we marry those twin statements? And I'm going to try and explain that in the next few slides here. This is a slide very simply that compares the life expectancy of a member of the general population, when that's shown by the blue bar in terms of years lived, compared with the life expectancy of someone with schizophrenia. And we know that individuals with schizophrenia, for a whole host of reasons, die prematurely. Now, if we give that individual with schizophrenia antipsychotic, then the number of years lived increases, and we think the reason for that is because there's certainly the onset of illness, there is a reduction in death by suicide, death by misadventure, and probably longer term, better self-care, better engagement with physical and mental health services. So you're gaining years of life. However, there is associated increased cardiometabolic risk, and so you are actually, at the same time as gaining, you are losing years of life. But the argument is, or the understanding is that you are gaining more years than you are losing. So there is a net gain in terms of lifespan. But the priority for us as psychiatrists should be, how do we maximize the gain, minimize the loss in people with schizophrenia? And if we think that antipsychotics are playing a role, or some are playing a role more than others, in terms of increased metabolic risk, increased cardiovascular risk, increased cardiovascular mortality, how do we choose drugs preferentially where you get the gain in years life, but you're minimizing that loss? And so really, that is what drove the study that we published last year in the Lancet Psychiatry, which was a network meta-analysis that looked to what the primary outcome was to guide clinicians in being more metabolically minded. Very simply put, we wanted to produce a league table which showed which antipsychotics were the best in terms of their metabolic side effects and which were the worst. What is a network meta-analysis? I'm sure that not everyone is familiar with network meta-analysis as a methodology, and I'm going to do so. I wanted to very briefly run through what a network meta-analysis involves, because I think it is useful to understand, at least a little bit of what's under the bonnet when you're being presented with results. Remember, at the beginning of this talk, I talked very briefly about what a simple pairwise meta-analysis involved, and that's represented diagrammatically here on the far left-hand corner of the slide, A versus B. So essentially, a simple pairwise meta-analysis is collecting a whole series of studies that are all asking the same question. Is drug A better than drug B? A versus B, combine it together, summary effect size, there's your paper. Now, if we want to do a nice big study that compares how effective or the magnitude of side effects of different treatments at our fingertips, ideally, we wouldn't want to use meta-analysis. We would do a nice big RCT with various study arms, with each patient group being given a different drug. And then you just follow them up over time, and you then compare your groups against each other. But of course, in the world of schizophrenia, where there are over 30 different antipsychotics that we can prescribe, that is just not logistically possible or economically or financially viable. And so, you can't do that. So you have to turn to alternative ways of trying to come up with these league tables. And the problem, the next problem that you have to come up against is the fact that some antipsychotics will never have been compared against each other. The studies just won't have been done. And that's where network meta-analysis comes in. Network meta-analysis takes the same principles of a pairwise meta-analysis. So it will compare drug A. So just in this triangle here in the middle, ABC, it will compare drug A versus drug B. And it will take all the studies that have done that, a series of direct comparisons. It will also take all the studies that have looked at drug C versus drug B, another series of direct comparisons. But drug A and drug C may never have been compared with each other in the real world. But that doesn't matter, because what network meta-analysis does is it estimates what the difference would be between drug A and drug C based on the fact that they have a common comparator, which is drug B. And the upshot of all of this, and what's spat out at the end of your analysis, is a league table. It ranks the antipsychotics based on how effective they are or their side effects of choice. And that's exactly what we set out to do. We set out to look at the magnitude of change of different metabolic parameters, so change in weight, change in BMI, change in glucose, change in cholesterol over time in double-blind randomized controlled trials look at the acute treatment of schizophrenia with either antipsychotics or placebo. And by acute treatment, we're talking a median study duration of 6 weeks. And we actually had 3 main objectives. Number one, I've already told you, we wanted to rank antipsychotics based on their metabolic side effects. But we wanted to take things one step further. We also wanted to see if there were actually, could we predict, was there something about the physiological demographic background of certain individuals that make them more vulnerable to greater magnitudes of metabolic change? And then finally, we wanted to define, was there a relationship between symptom improvement in symptoms of psychosis, and degree of metabolic change? In other words, as your symptoms get better, do you put on weight? So those are the 3 things we wanted to do. We gathered data on our 100 randomized controlled trials, nearly 30,000 patients, 18 different antipsychotics, and these were our results. Another series of forest plots, I'm afraid, but these ones are slightly different to the other ones because in these forest plots, we're comparing individual drugs, as shown here on the y-axis, so from ziprasidone down to clozapine, and we're comparing the magnitude of change of different metabolic parameters compared with placebo. So if you are to the right of these vertical dotted lines, you have an increase in a given parameter compared with placebo. The axis on the x-axis, the units are mean differences. So this forest plot on the left is looking at change in weight. And so where it says 0 to 4, that's 4 kilograms. So it's easily interpretable. There are very few surprises in some of these outputs. Drugs like olanzapine, quetiapine, clozapine are generally speaking associated with the greatest magnitude of metabolic dysregulation. No surprises. But the magnitude is quite large. You know, we're talking about a 6-week duration here. And look at the bottom here, clozapine, olanzapine, you're looking at, on average, a 3 kilogram increase in weight compared with placebo treatment. And the same goes for body mass index. You're looking at, after 6 weeks, an increase in 1 kilogram per meter squared of your BMI. These are large, significant changes, I would argue, in a relatively short period of time. Total cholesterol, again, quetiapine, olanzapine, clozapine, anything with PINE, essentially, bad for your metabolic parameters. LDL cholesterol is where things started to get very interesting. So again, drugs like quetiapine, olanzapine, not too good. But look at the top of the forest plot on the right. Cariprazine, one of the new novel partial agonists, so a relative of aripiprazole, compared with placebo, was associated with reductions in LDL cholesterol. Totally unexpected, very interesting finding. HDL cholesterol, these are more subtle changes, but again, the other 2 partial agonists that we looked at, aripiprazole and brexpiprazole, can't get brexpiprazole in the UK, but you can in the States, they were associated with significant increases of HDL, good cholesterol, compared with placebo treatment. Triglycerides on the far right-hand side of this slide, there were no drugs, antipsychotics here that were outperforming placebo, but what we did show is, again, the magnitude of change associated with some treatments. So look at the bottom of this forest plot on the right-hand side, clozapine associated with a 1 millimole per liter increase in triglycerides compared with placebo treatment. That's huge in 6 weeks. Just to put that in some context, for every 1 millimole of liter of triglyceride increase, depending on whether you're male or female, your cardiovascular risk increases by 30 to 70%. Okay, and you know, a healthy level of triglycerides is around 2, and so we're potentially adding a 50% increase, even if your triglycerides were normal at the beginning. Finally, let's look at glucose. Again, drugs like clozapine, big changes in a short period of time, but again here, one drug significantly outperformed placebo in terms of its glucose levels, and that was lurasidone. So glucose was associated with significant reductions in glucose levels compared with placebo treatment. So the take-home message from this bit of the study was that, no surprises, drugs like olanzapine, clozapine, quetiapine, worse side effect profiles in terms of metabolic disturbance. But all things being equal, we identified five antipsychotics, 3 of which were partial agonists, which were associated with either benign or actually outperformed placebo in terms of their metabolic side effects. They were, as I said, the three partial agonists, A, B, C, aripiprazole, brexpiprazole, cariprazine, and then lurasidone and ziprasidone. As you know, all things being equal, you would therefore choose those preferentially. But of course, you know, there are other things that you have to factor in, and we can, you know, if we have time at the end of this talk, we can discuss, you know, caveats to that guidance. We produced as part of the study a heat map, which I've used in clinical practice. which is, to work collaboratively in the spirit of trying to work collaboratively with patients. And what this heat map shows is it tries to summarize the magnitude of metabolic change that's associated with different antipsychotic treatments. So you've got on the y-axis here, all the different antipsychotic treatments, on the x-axis, all the different metabolic parameters. And basically the more red the square is, the worse the metabolic dysregulation with a given antipsychotic. And so you might be sitting with someone who's already got diabetes. You're like, well, I don't really want to be on an antipsychotic with a greater magnitude of glucose dysregulation. And so you look along the glucose line, you go, well, we probably want to be avoiding drugs like olanzapine, quetiapine. But hey, how about, well, we've mentioned lorazepam, but also amisulpride comes out quite well. And so you can try and use it collaboratively, working with patients and making these prescribing decisions. And who should we be thinking about using more metabolically benign treatments in preferentially? Well, we wanted to see if there were any baseline predictors of metabolic change, and it does appear like there is. So what we showed is that you were more likely to have greater magnitudes of glucose elevations in glucose levels, fasting glucose levels, if you were overweight at the onset of the study, or if you were male. And that's shown in this schematic here. As your baseline body weight increases, the magnitude of change in fasting glucose increases. Same thing goes for the proportion of males in the study population. The greater the proportion of males in the study population, the greater the change in fasting glucose. I don't have the figures here to show you, but what we showed is that actually being non-Caucasian was associated with greater magnitude of changes in total cholesterol levels as well. So there are physiological, there are demographic factors that actually we know are risk factors for cardiovascular disease in the general population, just as a general thing, that are also applicable to antipsychotic-induced metabolic dysregulation. And certainly in these groups, non-Caucasians, males, people already overweight, you want to be thinking, and this is, I'm stating the obvious in some ways, I should be thinking about using more metabolically benign treatments. And then finally, is there an association between metabolic change and symptom improvement? And it looks like there is. So what we did here, we plotted and looked to see if there was an association between magnitude of improvement in symptoms, so as assessed using the PANSS, BPRS. And you can see that in this graph here, and that's shown on the x-axis. So that's the effect size magnitude for improvement in symptoms. So the further you are to the right, the greater your symptoms are getting, the better your symptoms are getting, versus absolute change in body weight. And as you can see, as your symptoms improve, your weight is significantly going up. And the same thing goes for BMI. As your symptoms improve, your weight is going up. As your symptoms improve, your LDL cholesterol is going up. And as your symptoms improve, your HDL cholesterol, your good cholesterol, is significantly reducing. So there is an association. Am I saying that you have to have metabolic dysregulation to get better? Absolutely not. Is this a novel finding? I would argue no, actually. We know that clozapine, our most effective treatment, in the armamentarium of antipsychotics, is associated with the greatest magnitude of metabolic dysregulation. Why do I think you have this association? Well, I think that those antipsychotics that we know from the Cipriani meta-analyses that are more effective, drugs like olanzapine, they're dirtier drugs. They have greater receptor binding profiles. And that may underlie in some individuals their greater efficacy as antipsychotic, but they may also be having non-specific off-receptor actions that are also targeting appetite, energy metabolism, which actually have nothing to do with symptom improvement, but it's just a consequence of a blunderbuss drug. Which then translates into weight gain. So the summary of this study as a whole: no surprises, marked variations in metabolic side effects in terms of psychotics. We had those big five, including the 3 partial agonists that we would argue, all things being equal, we should be trying to use these drugs preferentially, especially in those people who we think are more vulnerable to these metabolic side effects, being overweight, being male, being non-Caucasian. But remember, if you preferentially choose to use these agents that are more metabolically benign, they may, in some individuals, not be associated with as good outcomes in terms of improvement in psychotic symptoms. And so ultimately, you may need to consider using these more metabolically active drugs, which is exactly what we do in real life anyway. If you cycle through your 2 drugs of 2 antipsychotics, an adequate dose, adequate duration, you meet the criteria for treatment resistance, and you get clozapine with all its metabolic side effects, and so that's what happens already. But I think this underlines that point. So Moving swiftly on, because we don't have too much time, I apologize for rushing through things. I've tried to present the evidence that psychosis may be associated with intrinsic metabolic dysregulation. I've tried to describe that, that not all antipsychotics are the same in terms of their metabolic side effects, but now what about the direct effects of antipsychotics on the heart? There's actually quite a lot of preclinical evidence that would suggest that antipsychotics do have an effect on the heart. And is that surprising? Well, I would argue not. The heart is studied with a whole host of dopamine receptors, for example. And I'm just summarizing here very briefly some of that preclinical data that suggests antipsychotics, or at least manipulating dopamine regulation, can have an effect on the heart. So far left-hand corner, we've got, we're looking at histopathology slides of heart muscle of mice as they get older, and you've got slides A, B, and C, and that is just a wild type mouse, a normal mouse, getting older. And as you can see, the green bits of tissue are just the myocardium, and then you've got the interstitial spaces between those white spaces in between the green tissue. And as you can see, as you go from 2 months to 1 year to 2 years, those white spaces start to they turn black essentially, and that's collagen deposition, that is fibrosis. So, and that is the unfortunate consequence of getting old. We get creaky, we get fibrotic. Now, look at panel number D as part of that group of 4. That is, panel D shows the histopathology slide of heart muscle of a 2-month-old mouse that's had its D3 dopamine receptors knocked out. And what you can see is it's already prematurely fibrosed. So if you mess around with dopamine regulation in the heart, it's associated with premature myocardial fibrosis. Top right-hand corner, very briefly, don't worry, this is a complicated study by Shinoda. But essentially what it showed here is if you sprinkle haloperidol onto a cardiac myocyte for 48 hours, it starts to show changes in which you would normally see in heart failure, essentially. You start to get autophagy of mitochondria, of cells. They start to gobble each other up, essentially. And that's just by sprinkling haloperidol onto it. And then in the bottom right-hand corner, if you think of myocardial toxicity and you think of antipsychotics, you think of clozapine, don't you? So this is a study which looked at ever-increasing doses, stepwise increases in doses of clozapine in mice given for, I think, for 3 weeks, 21 days. As you see, there's a step increase in degree of, as the dose of clozapine increases, the degree of fibrosis, inflammation, and oxidative stress increases in a stepwise fashion as well. So that's the preclinical data. What about in humans? Well, up until we came along, there was actually very relatively little research done into it, which I found very surprising, bearing in mind how interested, well, I am at least, in the hearts of individuals with schizophrenia. And the studies that had been done had used transthoracic echocardiograms, and the studies between yourselves and myself, I think, were a little, the outcomes were a little undermined by the fact that patients and controls in these studies were not very well matched. So essentially, you had patients who were overweight, who were hypertensive, compared with healthy controls, and essentially you just showed a hypertensive heart in patients compared with controls, i.e. a big bulky heart. But that didn't really tell you very much about schizophrenia or the medication. It just told you that people with hypertension have bigger hearts, and we knew that already from the general population. And certainly there hadn't been any studies that used cardiac MRI, and cardiac MRI is important because it is the gold standard measure of structure and function across the board, and it allows you to look at the tissue more carefully. It allows you to look for evidence of inflammation, fibrosis, things that echocardiograms can't do at all. So that's what we set out to do a simple case control study that to look for evidence of cardiac fibrosis and inflammation in patients with schizophrenia compared with healthy controls, trying to basically see if that stuff, if the data, the evidence that we see in the preclinical studies also shown in humans. But because we wanted to see, is it an effect of schizophrenia or effect of medication, we wanted to try and remove the confounds of lifestyle. So in order to get into the study, be it as a patient with schizophrenia or a healthy control, you had to be physically healthy. You were not allowed to have any physical comorbidities, essentially. You were not allowed, certainly not allowed to have heart disease, but no metabolic disturbances. We checked HbA1c, we checked blood pressure, we checked cholesterol. You had to be, clean as a whistle to get into this study. And we matched patients for a whole host of risk factors. So we matched them for age, BMI, sex, the ethnicity, and smoking status was also the same between patients and controls. How do you measure fibrosis inflammation using cardiac MRI? Well, this is how you do it. This is, imagine if I were to take my heart out and chop the top off it and show it to you like a cup. That's what we're doing here. We're looking top down onto the left ventricle of the heart. And what cardiac MRI allows you to do is it allows you to look at the speed with which cardiac tissue contracts and relaxes in real time. And that is produced as something called T1 relaxation time. It produces a heat map, and you can see that what you really want in your myocardial tissue is a nice homogeneous purple circle. But if you have anything within the myocardial tissue that is slowing down that relaxation process, it comes up, it starts to look like it's on fire essentially. And there are two things that will impair relaxation, that is either fluid inflammation or collagen, i.e. fibrosis. So if you have either one of those two, T1 relaxation time is prolonged. And what did we show in patients compared with controls? Indeed, we showed elevated T1 relaxation time in patients compared with controls. So evidence of fibrosis or inflammation in people with schizophrenia compared with healthy controls. But these were patients and controls who were matched for all those sort of classic cardiovascular risk factors that you would typically blame for those findings. And if you look at more broadly across the spectrum in terms of cardiovascular structure and function, you showed smaller hearts in patients compared with controls, which is very much in keeping with a fibrotic picture in people with schizophrenia. The question mark is this an effect of illness? Because I remember I said at the beginning of my talk that we know that schizophrenia is associated with a pro-inflammatory state, and we know that patients with rheumatoid arthritis, for example, have exactly the same cardiac MRI findings that we've just shown. Or is it an effect of medication? Because I've shown you that data as well from preclinical studies. We don't know is the answer. And that's something that we're trying to work out at the moment with longitudinal studies as we speak. So we've talked about intrinsic metabolic dysregulation. We've talked about antipsychotics. We talked about antipsychotics and the heart. And finally, before we stop for questions, I'm going to talk about, well, what can we do about this whole mess? And it's something that I've been looking at for the last few years. In 2019, as part of a Lancet Psychiatry Commission, international commission, which brought people together to try and work out, not just to think about schizophrenia, thinking more generally, how do we improve the physical health of people with serious mental illness? And we came up with a series of sort of action points, essentially, for the field as a whole. And it's stuff that we already know. Again, it's a little bit of a sort of stating the obvious between you and me, but trying better to implement a physical health culture in mental health services, integrating those physical and mental, integrating physical and mental health, provision of lifestyle factors, reducing the long-term side effects of medication. And I've already talked about antipsychotics today. And with that in mind, for about 3.5, 4 years. At the same time as doing my PhD, I worked with David Taylor and Fiona Gochran on writing a sister volume to the Moudhy guidelines, and that is specifically looking at the management of common physical comorbidities seen in people with serious mental illness. And it is designed to be read by psychiatrists, and it is a little bit like the Oxford Handbook for Clinical Medicine, the cheese and onion, in terms of being a practical how-to guide on how to manage all those different conditions that you see commonly, both in the outpatient and inpatient environment. It has 125 authors from across the world of medicine, psychiatry, surgery, physiotherapy, dietetics, OT, you name it, they're in it. 89 chapters, probably about 130 conditions. And the overarching goal is to improve that skill set of psychiatric practitioners and also primary care doctors in caring for patients with serious mental illness in terms of their physical comorbidities. This is a slide showing some of the people who contributed. It is not exhaustive, but I'm totally indebted to all of those individuals who are giving up their time. And just to give you guys an idea of what the book, how it's structured, it's structured into organ systems with a little emergency section as well at the end. And if we look at sort of 4 of those organ systems here, cardiology, endocrinology, respiratory, and the emergency sections, you then have those sections subdivided into mini chapters. Each chapter is sort of 1,500, 2,000 words long. And it's focusing on typical presentations. So what do you do if someone has a fast heart rate, slow heart rate, high blood pressure, low blood pressure, QTC prolongation, query myocarditis? We answer it, and all of the chapters have a similar structure. So what is the complaint? Common causes in the general population, common causes in people with serious mental illness. What should you be doing? History, examination, investigations. When should you worry? If you are worried, who should you be speaking to? And when you do speak to them, what information should you include in that referral in order to expedite appropriate management for your patient? And if you have the experience, and it very much differs from individual to individual, what can you do management-wise, non-pharmacological and pharmacological interventions? So that's it. In terms of my objectives, and how have I answered them? I hope in terms of take-home messages for you guys, intrinsic metabolic dysregulation in schizophrenia, who knows? But do remember that when you see someone with first episode psychosis who is drug naive, they are on average further down the line towards developing diabetes than a member of general population. Number 2, We know we've got those big five: aripiprazole, brexpiprazole, cariprazine, ziprasidone, lorazepam. They're pretty good in terms of their metabolic side effects. Consider using those preferentially, but remember, they may not be as effective as some of the old favorites that are out there. There may be some evidence that antipsychotics have a direct effect on the heart, but that is not, we don't have enough data there to actually, for that to influence our clinical practice. So watch this space. And remember, there are now texts and resources out there to support psychiatric practitioners in supporting the physical health of people with serious mental illness. Thank you very much indeed for your time, Pospo.
Oh, God. Oh, man, that was, wow. I mean, I warned you, didn't I? He's unstoppable. Toby, you're on fire. To be honest, I mean, there were at least 3, or maybe 4 times that I just wanted to give you a glass of water. I mean, that was unbelievable. Thank you so much, Toby. I mean, we have a few questions. Some of them are directly relevant, some of them not really, but they're all around the psychotics. So let's crack on. So the first one comes from, again, apologies if I mispronounce your name, to take it personally, and this comes from a man that both name and surname are consistently slaughtered. So it's SS and Goon Felice. So how about the quality of years gained, lost? Which is a bit generic question, but
that's a good question. I don't think there's, the reason I'm pausing is I'm trying to think of studies that have tried to address such a question. And it becomes a bit more philosophical, doesn't it? Are your years when you're younger better than when you're older? I think it probably depends if you ask a 20-year-old or a 50-year-old. And quality of, I think, isn't happiness meant to improve post-retirement? Well, yeah, I'll let you know. To be honest, I don't know. I think, but as a general principle, I think we all want to live a bit. We would rather not die early. And of course, we want quality of life as well. But I think, in first episode psychosis, I think use that as a good example. In first episode psychosis, it doesn't. You don't need to use clozapine first line. The data suggests that you can use. It doesn't really matter which drug you use first line, and they are equally effective. And then if we think they're equally effective, then you would hope that will translate into an improved quality of life. And if they are all equally effective, why would you not use a drug that has fewer side effects? And I think that's the take-home message. And I think it does sometimes feel like I'm preaching here, and I'm really not, because actually I think a lot of the stuff that I'm saying people are doing already. I think it's very odd. I would say, well, as at least working in South London, it'd be very odd to find a first episode psychosis practitioner who only uses olanzapine, first line for everything.
Yeah.
I think those days are over. It's a little bit different from my experience in CAMS, where risperidone is still the drug of choice. And maybe there is less thought about the side effects of different treatments. Now I'm going to get slaughtered for that. But I think, I think there is slowly over time, the tradition of just using my favorite drug is changing a little bit. So I think it's just, I think a lot of the work that I do is just sort of adding evidence to things that people probably already know already.
Fair enough. Well, that was a good go. That was a good go. And to be honest, a really difficult question. A really interesting one comes from Jenny McCleary. So Jenny is asking, what are best evidence approaches to supporting lifestyle change in serious mental illness? So I'm assuming that, Jenny, you are alluding to the modifiable lifestyle factors, maybe. So are there any evidence approaches?
We need to get Brendan Stubbs on,
Yes.
who's the head of physiotherapy at the Maudsley, and that is his research interest. That is what he does. He wrote the physical exercise chapter in our book. The guidance that is in the book is based on guidance from the general population. There is not a huge amount of evidence to guide physical health or lifestyle interventions in patients with serious mental illness, and the data that is there is a bit patchy. You know, there was the Primrose study, for example, that was a multi-center study that looked at different interventions to improve physical metabolic outcomes, essentially, in people with serious mental illness. And it divided people into people who got smoking cessation, people who got, encouragement to do exercise, and it was all through care coordinator use. And what they showed is that nothing really worked, unfortunately. But, you know, there were caveats to that study. And I think, so the take-home message is, in terms of specific SMI advice, there isn't much out there. But there is, in my opinion, there's no reason just not to use evidence that we know works in the general population. You know, it's the same principle of, you know, when people ask me about, oh, should we use metformin early to reduce the chances of progression to diabetes in people with schizophrenia, for example. And although we know in the general population that metformin reduces progression to diabetes from pre-diabetes, that study hasn't been done in people with schizophrenia. But why wouldn't it work in people with schizophrenia? It's worth a go. We know that it's associated with weight loss in people with schizophrenia who take olanzapine and clozapine. So again, it's about applying principles. You know, where the data isn't there, we do have data from a general population set that we can apply, but it is tough.
An interesting comment comes from Christina Trifonov. Just a comment, she says, to say that our understanding of cholesterol and interpretation of numbers is outdated. We're taught that LDL cholesterol is bad, HDL good. However, the reality is that neither is always good or bad. And it depends on the particles composition, i.e., your diet and the types of fat one consumes, and oxidation process which damages cells. Christina, I'm really impressed, to be honest. This is not a comment, this is like the whole text. So our patients, though, she adds and closes there, are of course likely to have poor diets, high in processed oils, contributing to higher rates of MI, stroke, etc. Really valid comment, I think.
Yeah, absolutely. And it's all about ratios as well. And, you know, it's difficult to come up with take-home messages without losing some of the nuances of research. And, you know, one of the other things which I didn't show there is triglycerides were actually elevated in first episode psychosis drug naive compared with healthy controls. Triglyceride increases are a trademark of glucose dysregulation, and so it very much ties in with those findings. But I totally agree with that statement.
Fantastic. I mean, we have a few other questions that are not directly relevant to the cardiometabolic risk, but let's give it a go. So one is relevant to the book, which I'm pretty sure that you're confident. I mean, you spent 40 years writing it, you have it as well. So. Eleanor Rachel Tianga asks, does the book cover long-term use of stimulants and impact on blood pressure and pulse?
We talk about stimulants in the context of heart rate and blood pressure. So there isn't a specific chapter on stimulant use. The structure of the book is more on the physical presenting complaint. So heart rate, blood pressure. And as part of that, we talk about which psychiatric medications might be contributing and guidance therein, not just stimulants, but, you know, if you think of high heart rate, you think of clozapine, those sort of things, you know, what should you do in someone with a persistently fast heart rate in patients treated with various psychiatric drugs that may be causing that. And it's a common question to cardiologists, you know, what do I do? Often the cardiologists come back and go, stop the drug. And you go, I can't stop the drug. And they go, well, and it's a tough one. And I think that was just something I didn't mention before, is one of the driving force, the reason for the book, writing the book, is often I would ask a colleague, a cardiologist, a hematologist, about some of these, you know, neutropenias, tachycardias, and they would go, I don't know. And so it was very much about getting everyone in the same room and starting to really think about things holistically, getting, you know, an MDT centered approach within each chapter to these quite complex at times complaints.
And last one, it's mostly relevant, a generic one about antipsychotics. Dear Dr. Pillinger, thanks for the fascinating synopsis on antipsychotics. This is from Jayanta Chatterjee. Thank you, Toby. But are you aware of any studies comparing antipsychotics on the basis of the primary negative symptoms alleviated versus the secondary negative symptoms induced by them? Tricky one.
It's a bit of a tricky one. Well, the cariprazine had a Lancet paper, didn't it, which compared cariprazine versus risperidone and that was looking at negative symptoms, and it's why, you know, everyone goes on about cariprazine being effective in negative symptoms. But I personally think that cariprazine were quite cunning in choosing to compare things against risperidone, because, as we know, you can get secondary negative symptoms from drugs such as risperidone. And so are you truly treating primary negative symptoms, or are you treating secondary negative symptoms? And yeah, I don't think, but I'm happy for someone to tell me I'm wrong, I don't think there has been a study that has tried to tease out primary versus negative. They've just looked at negative symptoms.
I wouldn't even, think about, daring you with that. Thank you so much, Toby. As Michael Jackson would say, you do make the world a better place for you and for me and the entire human race. If you still haven't had the chance to explore his new book, I mean, relatively new, it's a few months old, co-authored, as he already said, along all the usual suspects, David Taylor, Fiona Goffran, and 125 clinicians, it must have taken at least 1 year to get them all together, to get their affiliations, to be honest. So this is the mostly practice guidelines for physical health conditions in psychiatry. Go and get it, and you can thank me later. You can thank me right now, though, because I'm going to be unleashing you to the wilds of your kitchen and enjoy some lunch. We'll be back at 1:15, and make sure you're back on time, because that one is not to be missed. Professor Louis Sass, all the way from the United States of A. See you in a bit. Welcome back, everyone. For people that just joined, this is Pospo for the London and South Eastern Division Spring Academic Conference of the Royal College of Psychiatrists. Hope you enjoyed your lunch. I know it's not as good as, looting the buffet or roaming around the college library, but at least you avoided the funny looks as you're hopelessly trying to fit as much hummus as humanly possible on a tiny plate while balancing 2 glasses of wine on your other hand. Or is it too early for a wine? You see, I've already forgotten what's being served in conferences with all these Zoom meetings. Good thing you're all back, though, because you're in for a treat. Yes, we will stick with schizophrenia for a little bit longer, but we will approach it from a different angle, if you like, and discuss the biophinosocial model. This was, in fact, one of the things a few of you asked. Give us more phenomenology. And I was like, well, you want phenomenology? I'm going to give you phenomenology, but not just any phenomenology. I'll bring you one of the best out there. He's a distinguished professor of clinical psychology at Rutgers University and a member of the New York Institute for the Humanities. He published extensively on schizophrenia, phenomenological psychopathology, psychoanalysis, and some very, very complex, I have to say, papers on Wittgenstein, Heidegger, and Foucault. Books? Yes, he did that too, and many of them. In fact, a revised edition of Madness and Modernism on Oxford University Press was awarded the British Medical Association Prize as Best Book in Psychiatry for 2018. To be perfectly honest with you, when I was emailing him an invite, I didn't think that he would say yes, but not only did he say yes, but patiently, worked with me to find the most appropriate talk for this conference. You could say he's a superstar without the superstar attitude, and that made him, even greater in my eyes. Professor Louis Sass. Prof, welcome.
Thank you very much. Can you hear me okay?
I can hear you. I can see you. Amazing. You have a really beautiful camera. So are you in New Jersey right now?
I am in New Jersey. Yes, indeed.
Fantastic. How's the weather there?
Beautiful. It's a beautiful day.
Oh, come on, lie. We're in London. It rains all the time. Just make up something. It's cloudy. Say something.
Everything is always perfect in New Jersey. What can I say?
Bruce Springsteen is from New Jersey, right?
Sorry?
Bruce Springsteen is from New Jersey, I think.
He is.
Fantastic. Good. Thank you very much, Prof, for joining us today. So the floor is all yours.
Okay, let me just make sure that when I move something on my screen that you're still hearing me okay.
Yes, of course.
So thank you for the invitation. Are you hearing me okay?
I can hear you okay. Fantastic. Yes. And I can see your slides as well.
Okay, no, well, you were going to show the slides. Yes, all right, that's right. Okay, one sec then. Here we go. I have to have something different on my screen. Now you're still hearing me okay, right?
Yes, all good.
Okay. Oh, then I will proceed. Thank you so much for the invitation, for this opportunity to speak to a couple of divisions of the Royal College. Thanks particularly to you, Sotiris Posporelis. I hope I'm pronouncing it decently.
Really good, really good.
And thanks also to Jennifer Edwards and Karen Morgan for all the arrangements. So let me proceed. Schizophrenia, which has been called the sacred symbol of psychiatry, is, as we all know, one of psychiatry's most problematic disorders, given the variety, the changeability, and the sheer strangeness of its manifestations and the uncertainty of its boundaries. One influential attempt to define schizophrenia is the self-disorder or ipseity disturbance model, currently prominent in phenomenological psychopathology. In recent years, there have been some new developments in formulating this self-disorder concept. Next slide, original self-disorder model. Such developments make this approach now particularly attractive, offering a biopheno-social model that's capable of capturing not only the unity with heterogeneity and the distinctive bizarreness of schizophrenia's developing symptoms, which is a contribution, I think, of the original model, but also, and now next slide, recent model also accounts for, number one, schizophrenia's symptomatic overlapping with dissociative conditions. Number two, its variability with circumstances. Number three, its reactive, sometimes quasi-intentional or quasi-volitional quality. And this model can also integrate recent empirical findings regarding both psychosocial and neurobiological aspects. Now I'm going to introduce this self-disorder perspective in its recent formulation, along with some implications for research, but also link it to earlier work that can help to explain and flesh out this perspective, especially my own earlier work on the parallels between aspects of schizophrenia and 20th century avant-garde or modernist art, literature, and thought. So let me begin by outlining the basic self-disorder or ipseity disturbance model of schizophrenia described in various publications over the last 15 years or so, especially a key 2003, I guess it's more than 15 we're talking about, article in Schizophrenia Bulletin, by Sass and Parnas. The self-disorder model postulates an abnormality of basic or minimal self-awareness, that is, of the normal first-person quality of experience that can be termed ipseity. Next slide, ipseity, minimal, basic, or core self. Ipseity refers to the core self of existing the core sense of existing as the subject of one's own experience, an agent of one's own actions. William James called this sense of existing the central nucleus of the self. Ipseity or minimal self, which is grounded in the lived body and inner time consciousness, is not experienced as an entity in one's field of awareness, but rather as the unseen point of origin for experience, thought, and action. That is, as a medium of awareness, source of activity, or general directedness toward the world. It grounds the first-person givenness, what we might call the for-me-ness of subjective life. Now, this self or ipseity disturbance in schizophrenia is hypothesized to have three main aspects. Next slide, basic self. The first is of these three aspects is hyperreflexivity, which refers to certain forms of exaggerated self-consciousness, a tendency fundamentally non-volitional in nature, but then incorporating volitional aspects as well, for focal attention to be directed toward processes and phenomena that would normally be, shall we say, inhabited, or thereby experienced tacitly as part of oneself. The second, diminished self-presence, refers to a decline in the passively or automatically experienced sense of existing as a subject of awareness or agent of action. Now, could you please skip the next two slides and go to the one that says diminished self-presence? For example, as one woman with schizophrenia said, "I am in nowhere land, no feelings, no thoughts, nothing but a blank, empty space where Pam used to be. No needs, no desires, no wants, no urges, an involuntary Buddhist dissolving into the void," end quote. Even her own body, sitting in a chair, seemed to her to be, in her words, as far away as the Hubble telescope and no more important than stardust. Now, the third aspect is disturbed grip or hold. Next slide, please, disturbed grip, which concerns accompanying alterations in the organization or field or feel, the organization or the feel of the field of awareness. Alterations affecting, one, the tacit focal structure or salience pattern in the field of awareness. Number two, the affordance quality, things, the sense of usefulness of things. And third, the reality status of the world. Perhaps this is indicated in the next slide from the surrealist painter Tanguy, which illustrates the loss of affordances, of the usefulness of objects. Now, the hyperreflexivity or abnormal self-consciousness characteristic of schizophrenia is not only especially intense and disruptive, also it often involves a radically inward, yet simultaneously externalizing or alienating quality, as if even the most subjective aspects of experience itself had somehow impossibly been extruded and objectified. No writer has captured this better than the poet and playwright Antonin Artaud, who was both a central figure of the 20th century artistic avant-garde and a person with schizophrenia. In one rather disconcerting passage, for example, Artaud describes his own face seeming to float upward and away like a mask, or what he calls a lubricating membrane, as if this most intimate part of himself, the lived muscular and nervous patterns of his own face as felt from within, were somehow turning into an external object or quasi-object. Indeed, it appears that this could even happen to consciousness itself, to mental life in its most subjective dimensions. It seems that the processes that would normally serve as the medium of social interaction, for example, the lubricating membrane of the lived face, or even as the very medium of or grounding of experience itself, can show up as phantom concrete quasi-objects within the field of consciousness. And this is an experience that is perhaps evoked in the portraits by the great British painter, Francis Bacon, if you know those works. And the effect of this hyperreflexivity is quite understandably to disrupt the very stability of the world. What happens in these experiences is that the tacit becomes focal. There is, we might say, a rendering explicit of the implicit. We could say then that many of the most characteristic and seemingly bizarre of schizophrenic symptoms actually involve an awareness of psychological phenomena that are in fact, in a way, perfectly banal or everyday. An intimate, inner, and normally unnoticed dimension of normal experience has come to be objectified and thereby radically transformed under the abnormal gaze of hyperreflexive awareness. Schizophrenia is characterized then not only by a turning inward, but also by overall disruption and fragmentation of one's sense of vital subjective presence for oneself and before the world, of existing as a unified and living first-person perspective that grounds both itself and its objects of awareness. Now, it's important to appreciate the intimate intertwining, or perhaps it's a kind of complementarity of these three aspects or processes, that is of hyperreflexivity, diminished self-presence, and disturbed grip. Next slide, please. Basic self again, same slide as before. Consider, for example, that whereas hyperreflexivity emphasizes that something normally tacit becomes focal or explicit, diminished self-presence emphasizes the other side of the coin of this same process. What once was tacit, whether this involves the kinesthetic and proprioceptive sensations of the lived body, or perhaps the inner speech that would normally serve as the unnoticed scaffolding of our thinking, comes to be objectified and therefore can no longer be inhabited as a medium of taken for granted selfhood. Next slide, please. Antonin Artaud as exemplar. Now, Artaud brought the altered sense of self and of one's grip on the world together when he spoke of consciousness as, in his words, the essential illumination, that center or phosphorescent point at which all reality is recovered, end quote, around which everything in his word clusters or depends. quote, the very substance of what is called the soul. Artaud spoke also of a dispossession of this vitable substance. He spoke of this ebbing of my soul, which is to say of subjectivity itself. And he associated this ebbing directly with disorganization and what he called constant leakage of the normal level of reality. Now, one might speak here of forms of alienation, referring thereby to the forms of distancing, disengagement, devitalization, and decomposition that typically accompany hyperreflexivity. Next PowerPoint, alienation. Patients often describe a kind of distancing or separation, but it is not a matter of literal spatial distance or of some actual physical barrier, but of the lived or felt sense of separation, unreality, or deadening that's inherent in a stance or attitude of disengagement. I see everything as through a telescope, smaller and at a very great distance, said one person with schizophrenia, yet not smaller in reality, but more in the mind. Everything is far away. It is more a mental remoteness. Now, the Ipseity or minimal self-disturbance model offers a novel formulation. It draws, however, on earlier attempts to capture the core disorder of schizophrenia, especially from the tradition of phenomenological psychopathology. Next slide, phenomenological psychopathologists. Now, these forerunners include Carl Jaspers, with his emphasis on schizophrenia's bizarre or difficult to comprehend essence, which Jaspers himself associated especially with a disturbance of what he called the cogito. Also, Klaus Conrad's emphasis on a constant reflexive attention or a stepping back from experience. Also, Eugene Minkowski's notion of loss of vital contact as what he called the trouble générateur, the generating disorder, and Wolfgang Blankenberg's notion of loss of natural self-evidence. Now, in my own book, Madness and Modernism, first published in 1992 and recently republished in a revised edition. Next slide, please, showing Madness and Modernism. I discuss the illuminating parallels between schizophrenic forms of experience and expression and those characteristic of the art, literature, and thought of the 20th century. As I point out, hyperreflexivity and alienation, the latter overlapping with what today I have been calling diminished self-presence and disturbed grip, are perhaps the key defining features of much of the advanced art, literature, and thought of the past century. And since we have quite a good understanding of the nature and consequences of these trends in the realms of art and culture, examining these parallels can offer a promising avenue for grasping the actual nature of many phenomena in the realm of schizophrenia. Next slide, please. Madness and Modernism continued. Now, such an approach offers a vision of the illness that clearly differs from the standard psychiatric, cognitivist, and psychoanalytic notions that have dominated thought about schizophrenia and psychosis for a century or more. It implies that the core alterations of experience in schizophrenia spectrum disorders do not, in fact, reflect a decline in the fundamental and defining human capacities for rationality, abstraction, and self-consciousness. Nor do they reflect a resurgence of primitive and instinctual factors, as has so often been claimed, but rather an exaggeration of forms of hyper self-consciousness and alienation that are also characteristic, in certain ways, of many of the more sophisticated cultural productions of the past 100 years or more. Now, I'm going to return to these ideas a bit later in my talk. Before proceeding, let me note that this approach, which focuses on subjectivity or the inner life and is grounded in the philosophical tradition of phenomenology, is in no way opposed to the general project of neurobiology or cognitive science. The account I will offer does, however, conflict with some traditional reductionistic assumptions about brain disorders and their role in schizophrenia, especially those that would assimilate schizophrenia to a straightforward dementia, deficit, or irrationality model. But as I have argued for some years, including in a lengthy and now updated appendix called Neurobiological Considerations at the end of Madness and Modernism, And as I shall argue very briefly here, there are other neurocognitive hypotheses, very well supported by research and in fact increasingly dominant, that I think are entirely consistent with a more complex, phenomenologically grounded portrayal of schizophrenic subjectivity. Let us turn now to research on the self-disorder hypothesis, with a focus on recent developments. So recent research. The ipseity disturbance model has received crucial support from a series of studies using the well-known EASE, or examination of anomalous self-experience, a semi-structured interview that operationalizes the ipseity disorder model. Next slide, please, showing the EASE, examination of anomalous self-experience. Now, this important research is spearheaded by the Danish psychiatrist Joseph Parnas and is grounded in our earlier work on ipseity disorder in schizophrenia spectrum. It is clearly demonstrated that self-anomalies consistent with this model, largely involving forms of hyperreflexivity and diminished self-presence, are indeed far more common in schizophrenia spectrum individuals than in severe depression or bipolar illness, or in heterogeneous samples of psychiatric patients. In addition, clinical theoretical analyses suggest that despite some superficial similarities, the severe affective symptoms do not involve the disruption of core self-experience that seems to account for the often bizarre quality of schizophrenia's key symptoms. Skip the next slide, or just hold it for 1 second. You can see a key reference by Parnas, and I think it's Henriksen from the Harvard Review of Psychiatry there at the top. And then go to the slide, examination of anomalous world experience. The recently published EWE, substituting W for S, EAWE, namely the examination of anomalous world experience, will allow further empirical investigation of world-oriented or object-oriented disturbances and anomalies concerning space and objects, time and events, other persons, language, and overall atmosphere, which are associated with this ipseity disturbance model. Next PowerPoint, some recent EWE research. Now, recent work has now gone beyond these general associations in several ways. Next slide, recent and current research. It's gone beyond these general associations in the following ways. Through theoretical analysis of self-disorder's relevance for pathogenetic explanation. 2, by specifying schizophrenic self-disorder in comparison with several non-schizophrenic conditions whose self-experience can resemble schizophrenia, whether superficially, as is the case with mania and psychotic depression, or in ways that are somewhat more profound, as is the case with depersonalization disorder, with panic disorder, and with the condition of intense introspectionism. 3, by integrating neurobiological and psychosocial theories and findings. Crucial to this revised model is consideration of the distinction between what we would call primary and secondary aspects of the illness and its symptoms. At the risk of some oversimplification, if I had more time, I'd elaborate that point. One might distinguish between more fundamental, enduring trait-like features that are largely automatic or passively experienced, which can be termed, borrowing a phrase from the phenomenological philosopher Merleau-Ponty, operative. These would be the largely automatic or passively experienced operative, as opposed to reflective features, versus more consequential or compensatory features that develop largely in some kind of response. Next slide, primary versus secondary. It should be noted that both hyperreflexivity and diminished self-presence can occur in both a primary and a secondary fashion. Secondary, or what we might call reflective, spelled CT, reflecting, hyperreflexivity can involve an exaggerated and self-alienating self-scrutiny that occurs in defensive reaction to, or as an attempt to cope with, either more primary or operative experiential disruptions or traumatic environmental circumstances. It may, however, also occur, we're speaking now about hyperreflexivity, in a more passive or operant fashion, and as a component of a more primary affliction, as for example, when there is a kind of automatic popping out of kinesthetic or other sensations that would normally have been subsumed as part of the standard tacit experience of the lived body. And this we would call operative hyperreflexivity. Similarly, diminished self-presence, a kind of depersonalization, can occur as a self-protective or defensive response to trauma, as is well known to occur in PTSD, but may also derive from a more foundational weakness or affliction of self-experience. Now, all this is congruent with schizophrenia's pathogenetic complexity, which is known to involve both early and enduring, perhaps inborn, neurocognitive vulnerabilities, as well as later developments involving responses both long and short term to these endogenous factors and challenging life circumstances, thus implying two pathways, usually interacting intimately to psychosis. Next slide, dissociative symptoms. It is noteworthy in this light that schizophrenic self-disorder typically comprises prominent dissociative symptoms, particularly depersonalization and derealization, and that, as recently documented in research, schizophrenic and dissociative disorder symptoms appear to overlap considerably. Next slide, some references relevant to dissociation, etc. Now, these associations are especially important in light of recent evidence of the pathogenetic role that environmental social stressors, including childhood trauma and abuse, social defeat, and cultural dislocation alienation, can play in schizophrenia. It seems likely that some key aspects of the Ipsady disorder found in schizophrenia would involve dissociative reactions to such stressors, though these reactions would also interact with and be altered by the earlier and more inborn vulnerabilities, also interpretable as a disorder of core self, though of a more primary kind. Now, several lines of research support this view. Depersonalization disorder and introspectionism is my next section. Next slide, 2E studies. Two quasi-empirical studies examined the presence of ease-like self-anomalies in conditions that lie outside the schizophrenia spectrum, yet seem to involve either hyperreflexivity or diminished self-presence. In these studies, we explored the extent to which conditions incorporating key elements of the postulated self-disorder, but not themselves schizophrenic, might manifest ease anomalies, thereby suggesting the capacity of the postulated factors to account for cardinal features of schizophrenia involving self-disorder. Now, in this research, the ease categories were applied not to interview responses, as was the case in most past research, but to published accounts. First, published accounts of depersonalization disorder, which virtually by definition is dominated by experiences of diminished self-presence. And second, to accounts of exaggerated introspection, namely the early 20th century technique of psychological research, spearheaded primarily by Titchener, English psychologist who spent his career at Cornell University, which clearly involves adopting a deliberate or reflective form of hyperreflexivity. These two conditions, depersonalization disorder and intentional introspection, would seem to involve largely secondary forms of ipseity anomaly. Thus, while the secondary or reflective hyperreflexivity of introspectionism is volitionally initiated, these were graduate students told to introspect on their own conscious processes, the loss of self, told and trained in doing that, The loss of self-presence in depersonalization is generally assumed to involve a goal-directed, though not consciously initiated, process of psychological defense. Next slide. Depersonalization disorder introspection ease showing percentages. Now, these quasi-empirical studies showed that the majority of ease items were indeed found in both depersonalization disorder, 72% of the ease items, and introspection, 77% of them, thereby suggesting considerable experiential overlap with schizophrenia spectrum, considerable affinities, as we call them. Next slide, depersonalization and introspectionism on ease continued. Prominent in depersonalization and introspection, as well as in schizophrenia, were ease items indicating feelings of passivity and alienation, such as perceptualization of inner speech or thought and constant self-monitoring. Also, alienation or fading, we might say, of self and world, described as diminished presence. These are the affinities. There are, however, also some discrepancies. Items more suggestive of severe dislocation, erosion, or dissolution of first-person perspective, such that self and other can seem fused or confused, tended more often to be absent from either depersonalization or introspection. Whereas the first, dissociation-like items, affinities, may reflect more compensatory factors in certain cases, the latter, the discrepancies, may primarily reflect something more grounded in earlier, more affliction-like anomalies. So we believe it's necessary to consider the structure or component aspects of ipseity disturbance in order effectively to explore its temporal variability, pathogenesis, and also neural correlates. Now, the just mentioned findings from the quasi-empirical studies of depersonalization and introspection that I just described were corroborated in a more recent empirical study led by the Portuguese psychiatrist Luís Madeira, comparing 47 hospitalized panic disorder patients with 47 healthy controls. In this case, using standard ease interviewing conducted by experienced psychiatrists with ease workshop training. Next slide, panic disorder and ease. Like the depersonalization and introspectionist subjects I described just before, the panic disorder patients also reported many ease items, suggesting common forms of derealization and depersonalization, perhaps involving more secondary and defensive psychological processes in the development of these disorders. However, like those other two groups, the introspectionism and depersonalization disorder, the panic disorder subjects also tended to lack the ease items, suggesting truly profound distortion of subjective life, consciousness, or basic self, such as confusing one's own subjectivity with that of another person. And these perhaps are related to the more primary factor in schizophrenia. All this suggests a revised self-disorder model, which recognizes that schizophrenic self-disorder may well incorporate defensive or other secondary phenomena, some of which may involve forms of depersonalization and derealization that also occur outside the schizophrenia spectrum. It does suggest that the ease items, or at least many of them, are somewhat less specific to schizophrenia spectrum conditions than has sometimes been claimed. Now moving to neuropsychological dimensions. This refined or revised self-disorder model is consistent with current theory and knowledge about neurocognition and brain function in schizophrenia, and offers a framework for integrating a plethora of findings. Next slide, neuropsychological dimensions. Some neurocognitive theories prominent in recent years concern 1, salience anomalies, 2, disturbances of source monitoring, and 3, abnormalities of the default mode network. Next slide, salience disturbance. Now, salience disturbance involving limbic system overactivity manifests as a failure of attention to be automatically directed toward novel or significant stimuli, but to focus rather on random, habitual, or normally insignificant stimuli, which now stand forth in the patient's experience in disconcerting and sometimes delusion-inspiring ways. This clearly implies a form of disturbed grip, for it disrupts the normal pragmatic orientation organization of one's cognitive perceptual field. Among the stimuli that take on abnormal salience under these conditions are phenomena of bodily or cognitive experience that would normally be experienced tacitly and thereby inhabited as the very medium of selfhood, such as inner speech, normally to the medium of thought, but not directly noticed. And this implies a kind of alienating hyperreflexivity now directed towards such phenomena, such as kinesthetic sensations, and as I said, inner speech. Next slide, disrupted source monitoring. Now, the relevance of disrupted source monitoring, presumably involving disturbances of corollary discharge and associated prediction errors, its relevance for core self-experience is particularly obvious, given that it disturbs the ability to recognize when an action or perceptual change is or is not initiated or produced by the self. A third set of findings concerns abnormal activation in schizophrenia of the default mode network, the coordinated set of brain activity patterns that's normally associated with inner-directed rumination, itself a form of hyperreflexivity much of the time, and diminished practical engagement with the world, implying a form of diminished self-presence. It would be mistaken to treat any of these three factors in a static or reductionistic fashion. Each seems likely to represent something more like an orienting tendency, a shifting attitude or experiential stance that varies over time and is at least partially subject to volitional or quasi-volitional factors, namely hyper-awareness, which changes over time, detachment from active engagement in one's own actions, and ruminative introspection. Such tendencies are also found in various disorders outside the schizophrenia spectrum, of course, and with and without psychotic symptoms. It's noteworthy, in fact, that the neural correlates at issue closely resemble dissociative states, which are generally recognized as serving defensive functions, as in PTSD. Next slide, phenomenology and neurocognition. There are a couple of references, articles that I've been involved with, and then another PowerPoint, next one, neuropsychological dimensions. Now, these propensities may reflect underlying neurological tendencies. Defensive and volitional patterns do exploit inherent capacities, but they may also have a goal-directed or quasi-intentional quality consistent with the documented quasi-intentional, sometimes termed quasi-agentive aspects of schizophrenia. In addition to experiencing foundational or primary alterations of ipseity, the patient may also adopt in more active fashion certain attitudes toward or orientations within his or her illness. Stances involving, for example, active scrutiny of perceptual anomalies, willful withdrawal toward inner fantasy, or exaggerated contrarianism toward common sense ideas. Such intentional or quasi-intentional person-level attitudes toward or reflection on one's illness and its anomalies may in turn have implications for the nature and course of the illness. It seems plausible then that several key processes, hyper-awareness, detachment, ruminative introspection, might represent secondary responses, consequential and compensatory in nature, to a more foundational vulnerability and to environmental stressors. Though secondary in the sense of occurring later in time, these processes might nevertheless be equally necessary for development of a characteristically schizophrenic form of illness, with its typical depersonalization and derealization, as well as its distinctive eccentricity. What then of the more primary pathogenetic factor or factors? Next slide, primary pathogenic factors. A particularly strong candidate for this factor involves disturbed perceptual integration, found in schizophrenia patients and to milder degree in children at high risk for schizophrenia spectrum disorders. perceptual disintegration, spelled DYS, disintegration, has been repeatedly found in schizophrenia patients, and though not unique, seems relatively specific to it. Also, unlike other neurocognitive abnormalities mentioned above, it seems fairly constant and likely to be an early trait factor, given that it's found in children at high risk for schizophrenia spectrum illnesses. Its potential theoretical relevance in the context we're talking about can be readily explained. Next slide, perceptual integration. Perceptual integration refers to the synthesizing of information from different sense modalities, perhaps especially between interoceptive and exteroceptive processes, such as kinesthesia proprioception on the one hand and visual perception on the other. Successful perceptual integration would presumably provide a crucial foundation for establishing normal core self experience early in life, contributing to unified object perception, but also to the complementary senses of being grounded in one's own body and of constituting a particular viewpoint on the world. Interestingly, it can be shown that normal subjects subjected to multi-sensory conflict were found to have schizophrenia-like experiences involving profound self-disturbance, feeling, for example, quote, as if a virtual body seen in front of them was their own body, and mislocalizing themselves toward the virtual body to a position outside their bodily borders, end quote, from an article on that topic. Indeed, the neural circuitry of perceptual integration might well constitute the neural foundation of basic self-experience and the capacity to differentiate self from other. One intriguing interpretation of Ipsady disorder would emphasize disturbed temporality or basic time experience. Next slide, perceptual disintegration. Now, this does seem, in any case, to occur prior to other features, such as reality monitoring. Such disturbance of multisensory integration is also fairly specific to schizophrenia, certainly more so than our salience dysregulation, aberrant source monitoring abnormalities, or default mode network abnormalities. It is, however, found also in autism spectrum disorder, which, interestingly enough, has some symptomatic and neurocognitive affinities with schizophrenia, such as connectivity abnormalities and some shared genetic and perinatal risk factors. Now, it's plausible that such disintegration might be an early trait factor underlying primary, or what I've called operative, forms of disruptive hyperreflexivity, diminished self-presence, and disturbed cognitive perceptual grip on the world. Other factors more associated with shifting attitudes or orientations to experience, more reactive or defensive, might come into prominence somewhat later in the causal sequence. Next slide, basic self-disturbance in schizophrenia. There is, in fact, significant evidence of a correlation between the intensity of all three of these latter neurocognitive factors, the ones I'm associating more with the secondary aspect, and with the intensity of psychotic symptoms. Both primary and secondary factors may be necessary, but neither sufficient for creating schizophrenic self-disturbance. New slide, primary and secondary factors. Primary factors may be more decisive in the so-called poor premorbid patients or cases with early or insidious onset, often dominated by so-called negative symptoms and non-paranoid features. Secondary factors may be more crucial for cases with more acute onset and better premorbid functioning, and with more prominent positive, so-called positive, and perhaps especially dissociation-like symptoms, as well as for acute exacerbations under conditions of stress. There is, in fact, urgent need to explore these secondary factors. And one way to do so is to examine the variable nature of both neurocognitive and neurobiological trends. Such research would manipulate overall mental orientation or stance. For example, getting the subject to adopt a withdrawn, introspective, as opposed to a practical focus of attention. to be engaged in scrutiny versus a more spontaneous orientation, and then study the effects of these changes in both schizophrenic and normal subjects in order to determine the extent to which various symptomatic or perhaps more likely subsymptomatic alterations, including alterations of self and world such as mild perceptual fragmentation, salience dysregulation, disturbed sense of agency, together with their neural correlates, might alter in accord with these changes of set or orientation. Two studies have shown, in fact, new slide, recent research, that adoption by normal subjects of an altered overall experiential orientation, namely of an intensely introspective, detached stance, can bring about what were called psychedelic forms of perceptual experience, at least somewhat akin to what occurs in schizophrenia, including diminished agency and body ownership, permeable ego boundaries, and a quality of ineffability that the patient feels about these changes. It would be surprising if neural level abnormalities were not also produced, at least to some degree, by shifting attitudes or orientations on the subject's part. Such abnormalities are often ascribed to component processes, such as abnormal corollary discharge or salience dysregulation. They may, however, be dependent on varying defensive or even intentional or quasi-intentional factors akin to depersonalization defenses, introspectionism, and perhaps some forms of meditative practice, all of which can be understood as involving an altered overall orientational or attitudinal stance. It would be interesting to study, for instance, the extent to which either the experience or neural correlates of auditory verbal hallucinations might be mimicked, albeit to a milder degree, by a person who withdraws and focuses attention on his own inner thinking. Or to what extent would, for example, perceptions of the concave mask, if you know that experimental paradigm, or perceptual fragmentation, both of which are characteristic of schizophrenia, to what extent would these be increased under conditions of introversive withdrawal, either in normal subjects or in subjects in the schizophrenia spectrum? Such research could help clarify the complex syntheses of primary and secondary factors in the pathogenesis of schizophrenia, and might be relevant for devising treatments to alleviate some abnormal tendencies. Now, let me turn, before concluding, to the issue I mentioned earlier, the relevance of schizophrenia's remarkable affinities with modernist art, literature, and thought. These affinities bear considerable relevance to the issues just discussed, and they reinforce, I think, some of what I have been arguing. Next slide, Madness, Modernism, Revised Edition, the cover of the book. Now, to some, the modernism madness comparison may seem surprising, maybe even outlandish. As we know, schizophrenia was originally termed dementia precox, and most subsequent researchers and theorists have assumed the condition is grounded in some defect or deficit, conceived either in modular or global terms, that is typically thought to be bound up with diminishment of some quintessential human capacity, such as abstraction, volition, rationality, self-consciousness. I argue, by contrast, that schizophrenia's most distinctive affinities ally rather with many of the most advanced and sophisticated modes of art and experience of the past 100 years or more. Modes that, while not entirely volitional in nature, nothing is, do display a complex mix of act and affliction, as I like to call it. That is, of the quasi-agentive or defensive with the what we might call the more deficit, in a way, aspects of the illness. And that involve complex forms of self-awareness that may lie beyond rather than beneath those typical of normal persons. In Madness and Modernism, I described 7 sometimes overlapping features of modernist and postmodernist art. These include a radical contrarianism or oppositional stance toward conventional and practical modes, tendencies toward dehumanization and derealization, and finally, a general turning inward away from standard human concerns and standard objects in favor of a reflexive or reflective focus on the previously tacit medium of thought and expression. In the chapters of Madness and Modernism, I cover all the major symptoms of schizophrenia, suggesting in each case their intimate affinity with forms of experience and expression that are typical of modernism and that differ profoundly from the regression or dementia so often invoked. These symptom domains include, new slide, symptom domains in schizophrenia. A, the famous pre-delusional mood of the prodromal state. This, I argue, has much in common with the detached stare adopted by early 20th century futurists and surrealists who advocated as an aesthetic and existential imperative certain forms of hyperconscious alienation, an orientation best captured by painter Giorgio de Chirico, the proto-surrealist painter, in his memorable recommendation, which was taken up by the surrealists, which is to live in the world as if in a vast museum of strangeness. You might show, next slide, PowerPoint of de Chirico's Enigma of the Day. B, the characteristic types of schizophrenic thought disorder. Next PowerPoint, symptom domains in schizophrenia again. Now, these involve distinctive forms of cognitive slippage and disturbances of distance, to use phrases from the psychologists Paul Meehl and David Rappaport, that have much in common. These features of schizophrenic thought disorder, so-called thought disorder, that have much in common with the perspective and relativism to which the poet Louis Aragon, one of the surrealists, referred when he wrote, quote, "Lucidity came to me when I at last succumbed to the vertigo of the modern," end quote. A tendency that's perhaps most succinctly evoked in the title of Wallace Stevens' emblematic modernist poem, 13 Ways of Looking at a Blackbird. These cognitive distortions, I argue, in Madness and Modernism, reflect more a loss of the orienting ballast of a practical orientation and concerns than any intrinsic decline of rational capacity per se. And C, I would mention the enigmatic nature of delusional belief or quasi-belief in schizophrenia. This orientation, which I also discuss in a companion book called The Paradoxes of Delusion, does not, I argue, correspond to the usual interpretation of poor reality testing, but has far more in common with the ambiguously self-aware, sometimes dreamlike solipsism or quasi-solipsism found in modernism. And this is a topic we've pursued very recently in research led by Jasper Feyerts and reported in two current and forthcoming articles in Lancet Psychiatry. Next slide, delusions, phenomenological approach, several references listed there. And then the next slide, painting by Magritte, The False Mirror, which perhaps evokes the sense of quasi-solipsism of the world being contained within consciousness or within the I, the human being. Now, let me dwell very briefly on a single chapter of Madness and Modernism as a way to evoke at least some sense of the complexity inherent in this comparative analysis. In chapter 6, I think it is, Languages of Inwardness, I discuss the parallels between three distinct anomalies of linguistic expression or comprehension common to schizophrenia and three corresponding trends in the avant-garde literature of early 20th century modernism. These are first, next slide, Madness and Modernism, chapter 6. First, a preoccupation with ineffable phenomena, and indeed at times with the phenomenon of ineffability itself. This can lead in modernism, as in madness, either to a lapsing into silence, what psychiatry terms poverty of speech, or to forms of linguistic expression, often hyper-abstract, that many listeners are liable to dismiss as simply empty of meaning, psychiatry's poverty of content of speech. I'm going to skip the second one and go to the third. Third, focusing on language itself, experienced as an autonomous medium existing independently of any personal or private will to meaning. Such an orientation was forcefully advocated in the anti-romantic poetics of the late 19th century French poet Stéphane Mallarmé, and later proposed in much more general terms by the late 20th century post-structuralist philosopher Jacques Derrida. This represents one of the most prominent and, to some more traditional readers, off-putting trends in 20th century literature, but is prominent as well in persons with schizophrenia, whose abnormal linguistic productions have been shown in various empirical studies to involve the very same trends found in Mallarmé and Derrida, namely decontextualization of the meaning of particular words along with a proliferation of meanings and a tendency to give unusual prominence to features of the linguistic media. Now, what you may ask is the point or value of these comparisons. Why in particular should these affinities interest the clinicians who treat or researchers who study the schizophrenic spectrum of disorders? In concluding, let me offer 3 brief replies. PowerPoint slide that says madness and modernism, why compare? The most obvious benefit of the madness-modernism comparison is, of course, its ability to foster a richer understanding of the patient's actual perspective and existential orientation, which seems likely at least to contribute to forging a better therapeutic alliance. Such an alteration of overall vision might change one's viewpoint on what might plausibly be effective therapeutic interventions. Consider, for example, the implications for understanding and treatment of schizophrenic delusions. Instead of focusing primarily on errors or supposed errors of reasoning processes, or on finding ways of diplomatically refuting the delusion, as is characteristic of at least some contemporary CBT for psychosis, one would look instead to the interpersonal dimension, seeking ways to bring the patient back from their quasi-solipsistic orientation into the shared world of human intersubjectivity. A second benefit of the madness-modernism comparison is its ability to shed light on the motives, the workings, and the typical consequences of what I've called the secondary factors, those involving intentional or quasi-agentive elements. And this, of course, is of important relevance to pathogenetic explanation and in turn to potential forms of treatment. The third point, which overlaps somewhat with the second, pertains to the contrast between molar and modular or molecular modes of understanding. I've already warned against assuming that hyperreflexivity, diminished self-affection, and disturbed grip should be seen as 3 distinct psychological disturbances, each with a separate cause, given that they may well be complementary facets of a broader or more global orientation. And much recent research has in fact focused on rather specific neurocognitive abnormalities. As you know from what I said about suggestions for new directions, focusing more on the alteration of changes in the overall orientation or attitude would potentially be of great value. Such an approach can help us understand how the diverse symptomatology of schizophrenia in the varied domains of perception, thought, language, and self-world demarcation might all go together, at least in a loose sort of way, given that they all reflect in a particular domain a shared tendency toward disengagement and inwardness. Such a tendency may itself derive from primary as well as from secondary or quasi-agentive factors, and as I've suggested, might better be grasped through the more holistic notion of self-disorder. Thank you very much for your attention.
Fantastic. Thank you so much, Prof. I mean, loads of food for thought. And sometimes, to be honest, I wish that we had, more time to reflect about these matters in our, everyday clinical life. Though I have to say, arguing with the bed managers takes up most of my time nowadays. We only have just a few minutes for questions. As I can see already, the Dr. Smith is on the line. So let's start with Dr. Ghulam Mustafa Sumro. So he's asking, Prof. Sass, are dissociative disorders on continuum with psychosis? If yes, should they be treated?
Are which disorders on a continuum?
Dissociative disorders.
Dissociative, okay.
Yeah. If yes, should they be treated in somewhat similar way? If not, how would you distinguish them where ambiguity may be encountered? Tough one.
Well, I think that's an area that needs a lot more research, and we've started on that line, and there's other people doing research on dissociation and schizophrenia. But it seems to me that if it's the case that dissociation primarily has to do with so-called secondary factors, that it involves something that's more quasi-agentive, then that the kinds of treatments that you would use for dissociation could be also adapted to treating schizophrenia, because there's that element in schizophrenia. However, I think the dissociative phenomena that occur in schizophrenia will interact with what we're calling the primary factors, and will therefore have a somewhat different quality to them, so that it won't be such a clear-cut situation of feeling separate from oneself, but really about being much more profoundly confused about what the self even is, where one is in space, and so on and so forth. And that more characteristic of schizophrenia would presumably require other kinds of treatments. Exactly what those would be, I don't know. I could recommend to you an article, a couple of articles by Borut Skodlar, Skodlar, Slovenian psychiatrist. I'm a co-author on one of those, and also Skodlar and Henriksen, who've written on the implications of this whole perspective for treatment.
Prof, thank you very much. Last question, and a bit controversial, I have to say.
Okay.
So there is a bit of divide about what phenomenology can and cannot do. So
Yeah.
on one hand, you have people like, Parnas, you've already mentioned a few papers, Ulhas, suggesting that phenomenology essentially can lead to very, if you like, specific, testable hypotheses about underlying neurobiology, and with a direct, if you like, contribution to classification and diagnosis. But on the other hand, you have people like Binswanger suggesting that phenomenology cannot determine what's pathological and what's not. So where does the truth lie?
Well, I would shift away from the issue of what is or is not pathological, because I don't think one has to even have that category in order to find phenomenology beneficial or relevant to. So you could just say, well, we have these phenomena which are abnormal, brain activation patterns, and we have these experiences which we have reason to believe are also unusual. At least we don't have to use the word pathological, and let's see whether there are correlations between them. It seems to me that without phenomenology, neurobiology is likely to, go up a dead end, because we're only interested in what goes on in we're interested in what goes on in the brain for its own sake, but fundamentally, ultimately, we're interested in how that correlates with, and in certain ways determines, although it's not a one-way process, how that correlates with experience, with subjectivity. That's why we care about the brain. So I think that the failure of the hyper neurobiological project, which was noted by Thomas Insel himself, the decade of the brain didn't do much really for the study of severe psychopathology, at least. I don't think it's due to primarily to our having focused on problematic conceptions of diagnosis, which is what he and others have mentioned, although I think that's a problem. But I think it has more to do with the failure to focus on in a detailed way on experiential life in correlation with what goes on in the brain.
Amazing. Thank you so much, Prof. Yes, we do care about the brain. It has been a great honor for all of us to have you here today, even that early in the morning, because I appreciate that, it's like 8, 9 o'clock in New Jersey. Is it like 5 hours?
We started at 8:15 a.m. here, which is, believe me, early for me, but it was a great pleasure. A great pleasure.
Fantastic. Thank you so much. So what's next? What's next? You would be wondering. Well, no more Greek. Your ears would be pleased to hear there will be no more Greek accent piercing through your eardrums. As for the last part of the day, I will be passing on the hosting baton to Dr. Hesham El-Nazar, the Southeastern Division academic lead. Basically my equivalent, but better. No, you're not getting rid of me totally. I will be back for some closing remarks. Hisham, all yours.
Thank you very much, Prosperous. I will try to do a Greek accent to the best of my ability. Great day so far. Thank you all who are here, and thank you all for many thanks for the speakers. It gives me a great pleasure to present our next speaker, to introduce our next speaker. Dr. Shubulade Smith is a clinical director for forensic services in SLAM and one of the presidential leads for race equality at the Royal College of Psychiatrists. Dr. Smith's research interest and special interests are advancing mental health, equality, Black mental health, intensive care, and emergency psychiatry. So with no further delay, I will hand over to Dr. Smith. I'm looking very much forward to this.
Okay, so first of all, we just need to make sure the technology is working. So I'm hoping that you can see my slides. Yep, good, excellent. So this is going to be a very different talk. Thank you to Professor Sass. That was really interesting talk, actually. And I have to say that I am very much into the idea of the brain being all important. And, you know, that thing that we perhaps have forgotten about is a subjectivity. So very much in agreement with that. And know your phenomenology, people. It is absolutely important. What I'm going to do today is really give you a bit of a kind of whistle-stop tour about mental health inequality, some facts and figures, say a little bit about social determinants, discrimination, equality and equity in health, and then importantly, what we might be able to do about it. And I hope we'll have a little bit of time for questions and comments, but I have to say, I do tend to go on. I will try not to. So what's the problem? The problem is this, that we know that for certain groups of people who have protected characteristics, that there is a higher incidence, there's a higher prevalence, there are worse access, experience and outcomes when it comes to mental health. And these are some examples. So we know, for example, that women are more likely than men to experience mental ill health. And unfortunately, mental ill health in women is on the rise. Now, this statistic, the 1 in 5 women experiencing a common mental disorder like anxiety and depression compared to 1 in 8 men, was something that was found before the pandemic. Now, over the time of the pandemic, and actually also even before the pandemic, there was evidence that more and more men were coming forward with mental health problems. So the question is you know, are we also going to see an increase in men? The likelihood is, however, that over COVID, and in fact, some of the evidence over the COVID pandemic is that women have done worse health-wise than men have, in particular in terms of mental health. So even though the rates in men are increasing, the gap between men and women isn't narrowing. In fact, it's likely that when the adult psychiatric morbidity survey results come out, they're just doing it at the moment, we'll find that the rates are just high in everybody, which is not great, but they're even higher in women. And suicide, of course, is leading cause of death in young women. And worryingly, there's actually been an increase in the proportion of women dying by suicide in between the ages of 5 and 19. In terms of aging, we know that older adults, for example, there's this idea that when people get older, well, inevitably, you know, people become frailer in terms of their physical health and they become frailer in terms of their mental health. And there's an assumption that somehow part of normal aging includes being sad. Why would you be happy if you're older? However, increasingly the evidence is that's a bit of a myth. And in fact, depression isn't a normal part of aging. But unfortunately, the depression in older adults often gets missed because it's assumed to be part of assumed to be a part of getting older. But treating depression in older adults can be very effective if done properly. People from LGBTQ backgrounds have much higher rates of suicidal thoughts and unfortunately have attempted suicide when they're younger. Particularly people who are bisexual are consistently reported to suffer poorer mental health outcomes. On the other end of the age spectrum, young people are we have a particular problem with our children and young people. Up to 75% of mental health problems emerge before the age of 25. Now, that has enormous implications because what it tells us is that if we can help to treat someone successfully who presents with a mental health problem when they're young, then they are less likely to become an adult with a mental health problem. Not only that, if you can treat someone successfully when they're young, then the disability and the difficulties and the inability to achieve potential that comes with not being at your full health means that those things will be mitigated against. So, for example, if you become unwell when you're about 15 or 16, then it impacts on your ability to do your GCSEs and then your A levels. And so, and if you fall off the educational, escalator, then you may not do so well. We know that people who are better educated tend to have better outcomes in life. Very importantly, we know that the evidence is that there's a good effect size when it comes to treating children, and it's easier to treat a child than it is to treat an adult. So you treat a child's mental health problem, and 25% of them will get better. Treat an adult's get better and it doesn't recur. Treat an adult's mental health problem, it's more likely to recur, even if you treat that episode successfully. But you'll notice from the bottom of this slide that actually it's really quite hard for people to get treatment when they're young. And compared with it's not brilliant getting access to treatment anyway, but compared to the all age average, if you're between 16 and 24, it's only a 1 in 5 chance that you'll actually get any form of treatment, compared with, say, a kind of 1 in 3 to 1 in 4 chance, sorry. We know that people with learning disabilities have significant problems with their physical health, but also they have significant problems in mental health, and they don't get access to care for that. And particularly if you are from a lower income household, then you are much more likely to have an unmet mental health need. And we know that there are specific groups, such as those who are sleeping rough and who are homeless, who have enormous mental health needs. So it's estimated that 1 in 2 people sleeping rough in London have a mental health need. I just want to just focus on this bit of the graph, which is about poverty, essentially. And what this shows is the household income quintiles. And you can see that the prevalence rates for any mental health problem in those who are in the highest economic quintile. So these are essentially, rich people, and everyone who's sitting here who's a doctor, we'd all be in this range actually. Then the rates of mental disorder are much lower than they are if you are in the lowest 2 income brackets, basically. I mean, we are talking of an order of 3 to 4 times rates of mental disorder, just because you are poor. This graph shows a map of, so not a graph, sorry, this map shows depression and anxiety prevalence across the country. And the places where the dark blue is where the worst rates of depression and anxiety are. And the reason I'm showing you this is that the dark blue is the worst rates, and the light blue are the places where the rates are lowest. What's interesting is, it's kind of illustrating the point I was making before, is that the places with the highest rates of depression and anxiety, so we're talking kind of 1 in 5 people, correlate almost exactly with the poorest places in the country. So the place with the highest rates, Knowsley, parts of Liverpool in the northwest, Blackpool, other Thanet, and Isle of Sheppey in the southeast. These places, for the majority of these places, other than say Brighton and Hove and the centre of Nottingham, are some of the poorest places in the country. Contrast that with some of the richest places in the country, Richmond, and there'll be some of you actually, I'm sure, who are sitting at home in Richmond, and maybe if you're looking in the Chilterns and the area known as, the Devil's Punch Bowl, some of the areas of outstanding national beauty, and also some of the most, it's around here, some of the most wealthy areas in the country. And the rates of depression and anxiety are far lower than they're half what they are in the poorest places. So what about minority ethnic groups? So you will know this by now, so I'm not going to dwell on it too much, but basically if you are from a minority ethnic group, in the UK, you are much more likely to be detained under the Mental Health Act, and that's all ethnic minority groups, but it's particularly worse for people from Black, African and Black Caribbean backgrounds. And also, to, if you like, add insult to injury, although Black, if you're Black, you're much more likely to be brought in crisis, you're far less likely to access services through the normal route, i.e. through the GP or self-referral or through IAPS. You are, in fact, it's really hard for you to get treatment. And, you don't access to psychological therapy for ethnic minority, for people from ethnic minority groups is just much lower than it is for people from the white British majority. What's of interest is if you are from a South Asian background, you have no difficulty attending your GP. In fact, people from South Asian backgrounds attend primary care very, very, very frequently. But they are the least likely to be referred on for psychological therapy. And just to say, actually, it's not easy for anyone to get psychological therapy, but the rates are much lower in people from ethnic minority backgrounds. Furthermore, if you do manage to get into therapy, it's much more likely that your therapy will end abruptly if you're from an ethnic minority background. So what's interesting is that there was this study that we did recently. This is Feed Me Barnett. It's in Lancet Psychiatry, and it's a meta-analysis, very robustly done meta-analysis looking at ethnic variations in detention. And it was done internationally. It included migrants, not just people from ethnic minority backgrounds. And essentially what we found was, lo and behold, if you are from an ethnic minority background, you're more likely to be detained. We know that already. We also found that if you are from a migrant group, any migrant group, including white migrant groups, you were more likely to be detained than the white majority population. The reason this study was a little bit different is that we also went on not only to look at the rates of detention, but to look at the reasons that were given, the explanations that were given by the authors in the study for what they were finding. And obviously, they based their explanations on the evidence. One would expect that they would base their explanations on the evidence that they found from the research. What we found, though, is that in fact, I don't know why it's done that. What we found was in fact almost only half of the papers that were eligible for the study. In almost half the papers, there was no explanation given for the disparate risks of detention, or the explanations that were offered were unsupported by the evidence. There wasn't any evidence for the explanations, and there were kind of 24 explanations that were grouped together. And it's interesting, the explanation of things like, oh, well, the reason why there are more Black people being detained is because they smoke more drugs, or the reason why Black people are detained is because they're more violent, things like that. And what was interesting about the explanations is when you looked at it, you thought, well, hold on a minute, where's the evidence for this? You haven't actually found any evidence for this, but it was put in the conclusions in the discussion. The issue was that subsequent papers would then take the conclusions from the previous papers and say, as we know, Smith et al. In 2011 found that there were higher rates of detention in Black people because they smoked more cannabis or because they took more drugs. And that would be stated from the outset in the beginning of one paper and then used to determine what their hypothesis would be. And so it went on year after year after year. So we found that of these 24 explanations that were given, 10 recurred in studies over the next 20, 30, 40 years, despite there being no primary evidential support. So we had to one has to question the scientific merits of, number one, employing study designs that don't actually help you to determine any explanatory factors. But most importantly, it was concerning that there were these untested explanations. The explanations tended to deal with, frankly, somewhat culturally kind of demographic bound assumptions of the minority ethnic groups. And also these hypotheses, these are hypotheses, and they were untested. And they were being applied to non-specific ethnic groups. So Black people as a whole, South Asian people as a whole, which is problematic because it doesn't take into account the heterogeneity of the people within those groups. It also failed to consider any kind of intersectionality, and I'll talk a little bit about intersectionality later. It means that you don't fully appreciate the different types of risks that the different types of people within each of those groups might encounter, and also the different types of protective factors. So, oops, why doesn't my thing like going and moving now? Okay. Okay, next slide. So, just about heterogeneity. You know, you'll have heard lots of controversy about this term. I don't use it. You'll notice that I tend to use ethnic minority, but you'll still hear people use the term AIM. Try not to use it because it just, in a sense, bunches everybody who's not white majority into one group. And this is just to illustrate why it's important to start to understand the differences between the different types of people that belong to each of these different groups. And this is a slide showing household wealth in different ethnic groups. And, you know, these are, again, people lumped together, but it's, you know, this is data from the Office for National Statistics. And at the bottom here, it's median and mean. So pay attention to the median, that's the blue bars. At the bottom, this is the median wealth for white British people. This is all your assets, by the way, this is including people's houses. So this is the average, you know, including everything you got. So at the bottom, the wealthiest people are the white British people. But you will see that the people who match them are people who have, as the head of their household, someone who is from an Indian background. And in fact, if you looked at it, I think the Indian background people actually have slightly more assets, slightly more wealth. Now that's interesting because, of course, Indian people often get lumped together with everybody else as in the group of South Asian. Now at the top of the graph here, you've got the people who have the lowest household incomes, the lowest household wealth. And you'll see at the top, we've got Black, African, and importantly, look at this, Bangladeshi. So, and we know that people who from Bangladeshi backgrounds have had very different, very different reasons for immigration, very different, so people who immigrated from Bangladesh to the UK around the 80s, say, were often escaping flood, famine, and you know, war and significant economic hardship. People immigrating to the UK from India in the 80s were a whole heap of doctors, actually, people who were really highly educated, people who were, had the ability to, you know, earn a good living, and were invited to come to essentially prop up the NHS, actually. But it's a very different type of immigration, and it means that people, as we know, this group of people here are more wealthy, we're much more likely to be wealthy. And we know that if you are affluent, then you will spend about 1/6 of your life in poor health. But if you are poor and living in a deprived area, then you will spend about 1/3 of your life in poor health. The point about this is that if you try and lump together everyone who's South Asian, then if you like, the progress and the success of the Indian group of people mask the potentially ongoing difficulties that the Bangladeshi people face. This is just linking to the idea of, you know, being careful about assumptions that might be made. So this is a crime survey of England and Wales, and it's a graph of illicit drug use in according to ethnic groups. Now, the reason it's 2013 to 2014 is because for some reason in 2018-19, which is the last time they did the survey, they didn't categorize by ethnicity, unfortunately. But you can see from here that so this is drug use, and you can see that the rates of drug use are actually quite different according to ethnic minority background, with the people being most likely to use being actually those who are from a mixed background, any mixed background. Interestingly, those from a white British background are about as much likely to be using drugs as those from a Black Caribbean background. If you're from a Black African background, the likelihood of you being someone who misuses substances is similar to that if you're from a South Asian background. If you look at the different types of, you can look at different types, and this is different types of drugs that people are using. So if you're from a white British background, much more likely to be polysubstance user, heroin, cocaine, amphetamine, stimulants, MDMA, etc. This is predominantly cannabis. So the assumptions that are made that, oh, it's because of drug use, don't hold particularly well when you look at the evidence. This is just to remind you about what the etiology of mental disorder is. It's, we know it's multifactorial. This is just a kind of crude way of saying that, some mental disorder seems to be biologically driven. It might be a bit genetic and there's familial inheritance. Then there are perinatal factors, which, seem like they're biological, although, for example, if your mum lives, by a main road and there's lots and lots of exposure to lead, then whilst you're growing as the fetus in the womb, then that might impair your neurodevelopment. And that's probably somewhat socially determined. But in any case, there are some factors we know are biologically driven, but a whole heap of factors are actually not directly biologically driven in that kind of more obvious way. And in fact, a lot of the mental disorder that we look after is driven, as we know, by trauma. So especially trauma that occurs in childhood, emotional, physical and sexual abuse. Early and persistent substance use does seem to play a factor, but of course, we know that that's to some extent socially driven. Negative life events as an adult or as a child, such as bereavement, homelessness, financial difficulties, social isolation. We've definitely seen that in the last year or so with the pandemic. And back to poverty. I mentioned that before, that poverty is associated with being, with having mental disorder, and poverty is not something that is genetically driven. So the question is, why is it that people in certain groups have worse mental health? So remember that the people, at the beginning, I've showed you that there are mental health inequalities in various people with protected characteristics. Why is that? And, is it because of social factors? Is it because of discrimination? Is it because of both? Or actually, is it because of is it genetic? Is it genetic? It might be. So just to deal with the thing about possibility of it being genetic. So I'll illustrate this with the idea of the epidemiology of schizophrenia and psychosis. So you'll remember this massive WHO study done in the 70s, and they were looking at schizophrenia prevalence across the world. And they looked at 7 countries, 5 of which were white majority countries, 2 of which were black majority countries. And what they found was that the prevalence of schizophrenia and psychosis was essentially 1% across the world, no matter which of the countries you were looking at. And that was shown again in 2005 by Dinesh Bhagwan. The lifetime risk of schizophrenia, interestingly, more recently, people looked at lifetime risk of schizophrenia, and they said, for people in less developed countries, including those with, majority black people, the risk of schizophrenia is actually lower than it is for those in developed countries. However, if you live in a developed country like the UK or the USA or the Netherlands, and you are from a Black African or Black Caribbean background, then you are, consistently more frequently likely to be diagnosed as having schizophrenia than someone from the white majority group. Interestingly, Robin Murray said, because there were lots of questions about, is this genetic or what's going on? Particularly where I work at the Moudhy, the Institute of Psychiatry, it's essentially a centre for psychosis research, and much of the research for many years has been, about psychosis and looking at psychosis rates in Black people. compared with white majority people, and why that might be. And there was a question about whether it's genetic. Robin Murray says, I don't really think it can be genetic. I mean, Robin Murray is a well-known social psychiatrist. I'm not sure it can be genetic because the rates of psychosis in the second generation of people from these Black African and Black Caribbean backgrounds are much higher than they are in people from the first generation. So it'd be surprising that there'd be that massive increase in genetic, massive genetic change in such a short time. More recently, Sherifat Odewala has produced this study, and what it is they're looking at incident rates in psychosis over time. And the first thing that they found is that, and this, I have to say, this is a South East London cohort. First thing they found is that the rates of psychosis over time have increased. Our services are already overstretched, so that's going to be problematic. But what they also did was to break down into different groups, and they looked at different ethnic groups. I haven't listed them all here, just pulled out white British and Black Caribbean, people from Black Caribbean backgrounds. Interestingly, over time, they found that the incident rates in the white British group have increased. The incident rates in the, and this is over a relatively short period of time actually, incident rates in the Black Caribbean group have actually reduced. For there to be a change so quickly, it would be surprising this was some genetically driven change actually. And someone asked me about this and they said, couldn't it be, to do with epigenetics? Again, I don't think epigenetics really change things that quickly. So what about social factors? Might it be the social factors? Well, what we know is this: if you are lucky enough to be born into a lovely family with, a mother who really nurtures you in the womb and eats all the right food and does all the right exercises and, plays baby Mozart to stimulate your growing brain and so on. And then when you are born, you're lavished with love and told every day you're loved until, you say, stop kissing me so much and things like that. And you live in a comfortable house with a garden. We know how important that has been this year. Your house is in a nice area near a good school. So you know that the teachers at the school are interested in helping you to achieve your potential. You are supported by family members and community, all of whom want you to achieve your potential. Your family has enough money to have good, nutritious food on the table, not having to worry about whether you have a roof over your head. Eventually, because of all these factors, you go to a good school, you go to a good university, you have stable, non-precarious employment. You are able to afford then to live in a nice area with a good community, and you can access your doctor should you need to. Then you know what, you'll be just fine. You really will. Obviously everyone has stresses and stuff happens, but generally you'll be able to withstand that because of all the foundation that you'll have that will help you to be able to not only achieve your potential, but deal with the slings and arrows that life is going to chuck at you. If, however, you don't have such great childhood experiences, you are abused, you are either directly or indirectly, you live in poor housing, next to a rubbish school, you are bullied at school, or even if you go to a rubbish school, no one really cares about whether you have a good education or not. Social support's a bit lacking. There's always a worry about whether there's going to be food on the table, and if you go to school and there isn't food at school, you're not going to get, and you're not going to get food at home. You end up in precarious employment, and you don't have a particularly great community then, and you don't really know how to access service because you never really were taught how to negotiate the system when you were educated, and so on. Then actually, the evidence is that you don't necessarily do quite so well. The question is, how might that social disadvantage impact your health, or in particular your mental health? So Kwame Mackenzie and his colleagues put together this 4-dimensional model, and they said, look, there are vulnerabilities and resilience factors at an individual level. We all know that. We all know that some people are better at dealing with stuff than others, and some people are more vulnerable to stuff than others. those vulnerability and resilience factors interact with environmental level factors, which is to do with where you live and what group you belong to, what the laws are, you know, in the jurisdiction where you are. For example, you know, if you live some bits of South London, you can walk down the road smoking cannabis, no one's going to care. If you were walking down, you know, the street, the high street in a village in Surrey and you were smoking cannabis, then someone would call the police, okay? There is interaction between these individual risks and the environmental risks, and they are not independent. For example, your social context will change if the main breadwinner in your household dies when you are young. And if your social context changes because you can become poorer, then you'll end up moving house, living near a school that's not so good, and so on. And then, of course, there are important timing issues, because there are certain sensitive periods in development, in your development. So, for example, if the main breadwinner, you know, dies when you are 11 or 12, then that's a very crucial time in your development, just when you're about, you know, going into puberty, etc., and you have to move house and so on. Public Health England also talked about a kind of how inequality might impact upon health. They had they spoke out in a different way, but essentially said that we've all got a position in society, and that social stratification and our position actually affects the differences in exposure that we'll have to positive and negative factors. So there'll be protective factors, but there'll be vulnerability factors. And that impacts our standard of living. And our standard of living interacts very closely with, you know, where we live and things like that. Interacts with what our community is like, what our neighborhood is like, what individual and adverse and protective psychosocial factors there might be. That actually, there's good evidence now that impacts on how we, on our health behaviors. And not only that, but also how the body reacts to you know, stress, and how the amount of stress we get, the amount our body reacts to it, and how our body reacts in terms of our health-related behaviours. So an example of this is we now know that chronic stress is associated with a buildup of adipose tissue around the abdominal area. Now, that, of course, increases the risk of diabetes, for example. So what Public Health has said is that actually, you know, your social position in society might be associated with health outcome. So social factors are important. Social factors clearly are important. What about discrimination? Does discrimination make a difference? Might it be a risk factor for mental disorder? So just to be clear, I know those of you who read me talk before, I've talked about this a few times, but basically different types of discrimination. There's individual discrimination, personally mediated, institutional and structural, and then internalized. Just going to go through those very quickly. Individual or personally mediated discrimination, and that's the overt, covert, unintentional or intentional things that, you know, and there might be acts of omission or commission. And essentially it's prejudice based on the assumptions about a person's abilities and their motivations and their intentions according to that person's race or sex or, you know, gender, religion, disability, etc. The reason that I'm telling you this is because I think that people, well, we often, all of us do this, we often mix up different types of discrimination, and I think it causes a lot of contention and people get into big arguments about it, about what they mean. But I think Kamara Phyllis-Jones's, you know, description of discrimination is actually quite a useful one. Discrimination, so there's the prejudice, which is, you know, a person's thoughts about someone, but the discrimination is when you behave negatively towards another person because of the negative assumptions that you have about their race, sex, gender, religion, etc. And that can manifest as a lack of respect towards them. So, you know, being suspicious about someone who's wearing a hijab, or being vigilant when a black person walks into your shop, you know, devaluing a person, being surprised that a person's competence. So classic thing is, as doctors, as we know as doctors, classic thing is, you know, someone who is South Asian or black, who's from overseas, or overseas doctors. There's an assumption that overseas doctors are not going to be quite so good. And we see that reflected in the differential attainment in the exams. We see it reflected in referrals to GMC. Dehumanizing, so using excessive force. This, of course, we've seen that very powerfully and worryingly with the murder of George Floyd over the last year. And you know, this idea that somehow that was sufficient, that was the kind of force needed to subdue someone who might have been trying to exchange a $20 note, was that kind of force was acceptable. And we also see it in people not getting adequate pain relief and not being looked after properly. Particularly we see this when people are having babies. The difficulty is that direct discrimination has been associated with a negative emotional response in the person who is the victim of that discrimination. And that negative emotional response has been associated with a physiological response that's akin to the type of response that is seen in stress. So what about institutional discrimination? This is when there's differential access to goods and services and opportunities, and that can be by race, by gender, I put just race because it's just easier and it's an old slide, but race or gender or disability, by religion, etc. Again, it kind of manifests as inherited disadvantage. And it tends to be something something that we're all living with. So this isn't something that only happens in certain groups of people who discriminate in this way. It's something that everybody, because we're all living in the same society, and in fact, not just in the country, but across the world, everybody across the world has a general idea that, you know, okay, we know that this group of people are not as worthy as that group of people. And these people with, say, for example, it's only relatively recently in our society that if you were in a wheelchair, that it would be expected that you should be able to go to a restaurant and enjoy it without having to think about the fact that you're not going to be able to go to the toilet because you wouldn't be able to get down the stairs to go to the toilet. Now, it's as standard, everywhere has to be wheelchair accessible. Now, that is something that when I was growing up, it didn't occur to me, and I'm sure that many of you, hand on heart, would admit that if you're able-bodied, it hadn't occurred to you. But now it's as standard. We have wheelchair accessible places, and it's, again, this is a kind of, it was just this idea that that's just how it is, isn't it? If you're disabled, I mean, if you thought about disabled people at all, who people in wheelchairs, for example, physically disabled and in a wheelchair, if you thought about them at all, you might think, oh, well, you know, you can't go to the restaurant or you can't go to the theatre. But most of the time, people just weren't thought about. And the reason that's important is there isn't an active perpetrator. It's just something that's you'll often see in inaction despite the need. And the inaction in the face of need often occurs because people who are sitting around the table making decisions about, you know, what the design of the theatre should be, just don't think about the disabled people in wheelchairs who might need access, which is one of the reasons why it's important to have diversity around your table so that, you know, everyone gets thought about. It manifests in access to material conditions. You know, you might have different types of housing available and employment. Access to power is really important. So we've seen this recently in America with the people in certain areas having their votes suppressed. Lo and behold, a lot of the people in those areas would vote Democrat, and it turns out that they were also Black. So somehow Black people were being discouraged from voting. And when the institutions combine to uphold the existing structures, it's structural. Essentially, it's systemic. And because it's systemic, it's something that we all do, we're all part of. It happen. It's not, you know, it's something you can become more aware of, and but it's easily done. So somehow there needs to be a mechanism in place that helps us to think about the needs of everyone in society, not just one particular group. And internalized discrimination, this is when those people who are stigmatized, the people who are discriminated against, accept the stigmatized views and accept the negative assumptions and stereotypes about their abilities and intrinsic self-worth, i.e. that they are indeed inherently inferior, which unfortunately can be associated with low self-esteem and low self-worth. It can involve accepting limitations to one's hopes and dreams and aspirations, and people might devalue themselves. So for example, colorism, stratification by color, which, you know, so people who are darker skinned are worth less than people who are lighter skinned, black, for example. That happens a lot in the Caribbean. And similar thing can happen in certain parts of India. People using racial slurs as nicknames. And perhaps after a while you sort of think, well, you know, I'm not worth much, I'm not going to amount to much, what's the point in trying? You drop out of school, you don't bother to vote, you know, you get involved in risky health behaviours. And this isn't something that happens just because in people who are from ethnic minority backgrounds. It appears to happen, there's evidence it happens in people who are discriminated against generally. And that Elan Meyer talked about a theory that he described as minority stress theory. And essentially it's an internalized homophobia coupled with the stigma and actual experience of discrimination and violence, and the impact that it has on people who are LGBTQ, who essentially become mentally ill as a result. The thing about these social and structural factors is that they are not randomly distributed. And there's an assumption that they are, but actually it's that thing of the people who are making the decisions are often, if you're not sufficiently diverse, you just don't think about the needs of the other people. Not deliberately, it just doesn't occur to you. And so there's a kind of propagation of, you know, if you like, poor housing for poor people. It won't matter for the poor people. The poor people are less likely, because they're might be less educated, might be less likely to complain, or importantly, don't know how to complain, or importantly, don't know the person who runs the complaints office, so they can't go and have a chat with their mate to say this isn't okay. And Craig Morgan said, look, these social conditions experiences are not randomly distributed. These higher levels of poverty and discrimination and threat stem from long-term historical processes. And there is a systematic marginalization and exclusion of people from minority groups. And because of those barriers to economic and educational opportunities, there are barriers, therefore, to upward mobility and change. Just to say, actually, you'll have heard this term racial trauma, and it's essentially race-based traumatic stress, coined by Robert Carter, a psychologist in America. Essentially, it's basically saying that for some people, racism is such a stress that it makes them ill, and they become ill with symptoms that are similar to post-traumatic stress disorder. Elan Meyer, as I said before, he described a similar thing, minority stress. Again, you know, it's that thing of having stress that results from minority status, and it's a chronic stress, and it leads to psychological distress, which manifests as anxiety and depression. And I've just put this here so you can have a look, if you want to, have a look at the purported mechanism for how minority stress might come about. For women, I mean, the question is, yeah, okay, there's discrimination, but is it really associated with, you know, mental disorder? Well, interestingly, it was suggested some time ago that, you know, sexual discrimination may account for, actually, this is a quote, by the way, so that's why it's this bit old. But it was suggested that women might have more psychiatric symptoms because of discrimination. And then a recent study by Hackett et al. Found that perceived discrimination was actually associated with a threefold increase in depression rates in women. Interestingly, when it came to discrimination because of ethnic minority status, Stephanie Hatch did a study in Southeast London, big study, and found that there was a high prevalence of common mental disorder, depression, anxiety, and that those people who reported being discriminated against or feeling that they were discriminated against had a 2 to 4-fold increase risk of common mental disorder. And that was particularly so in those who were recently migrated to the country. What about psychosis? Well, again, recently, Josie Pierce has found that people reporting a higher frequency of experiencing discrimination plus greater exposure to worse discrimination was associated with a greater likelihood of psychotic experiences. And they postulated that discrimination might actually even be associated with an increased risk of psychosis. And then more recently, Hannah Youngsma and James Kirkbride found that when they adjusted for measures of social disadvantage and measures of social exclusion, that the rates of psychosis in the minority ethnic groups actually compared very favorably with those in the white majority. So what they were saying essentially is, look, this social disadvantage and these structural factors actually are associated with this. This is what they're postulating, that this is what is driving the excess rates of psychosis that are seen in minority ethnic groups. So David Williams in America said, look, it's really likely that if you're from an ethnic minority background, you're much more likely to have a mental health problem, you're at higher risk, and it's probably because of social disadvantage and also discrimination. Michael Marmot said, look, health inequalities and social determinants of health are the main issue. So the question is this: why should we be bothered? If so, what we're going to do about it, and if so, how do we do something? What do we do? So should we bother? The question is, yeah, it's illegal. Actually, we're not really allowed to do. You know, we can't have a situation whereby there's a group of people who, or there are a number of groups of people who are just not being well served by the health, the health system that we have. We're not helping people get better, and it's incumbent upon us as workers in public sector. Basically, we have a public sector duty to, mitigate against and eliminate inequality where we can. Morally and ethically, it's not right. Actually, it's not right that we see some people who just, again, year after year after year after year have worse access, experience, and outcomes, and we don't do anything about it. We've got to try at least. And economically, I mean, it's really expensive. It costs about £50 billion. Not attending to this issue costs us huge amounts of money, and it would just be cheaper to deal with it. And the thing is that we've known about it for years. It's interesting. This is actually about ethnic inequality in housing, and this is another social factor. But it's interesting that, look, the people with the worst housing inequality are the Black, African, and Bangladeshi residents in London. And lo and behold, they were the people at the top of the poverty. They were the poorest people with the worst household wealth. Health inequalities include people's health. You can see that in people's health status, in their access to care, in their experience of care, the behavioural risks, the wider determinants of health. It can be based on socioeconomic factors, geography. I showed you that map before. And obviously, certain characteristics that are protected in law and in different groups. And these are all the things we should be thinking about when we are seeing our patients, actually. We should be thinking about whether they're going to be at higher risk because of any particular characteristic or of their socioeconomic status, because it will help you to think about the kind of support that they will need. Just giving them medication or trying to get them access to psychological therapy may not be enough. It also, of course, it's not just mental health, because across medicine. And again, that kind of goes to the idea that there is something socially and structurally going on. If it was just in psychiatry, then the argument could be psychiatrists we'll just discriminate against our patients. It's not as simple as that. You see this across medicine. Black women are 5 times more likely to die after childbirth. There's much lower life expectancy in people who live in poorer areas. Compare North Kensington, where the life expectancy, North Kensington is a relatively poor area, very deprived. Life expectancy is 14 to 15 years shorter than it is in South Kensington. I mean, literally down the road. And you're much more likely to have cardiovascular disease if you are living in a deprived area. And of course, there's the scandal of the premature mortality in people with learning disability. The World Health Organization said that equity is the absence of avoidable, unfair, or remedial differences. I think that's really important. You know, if you can make it better, then do something about it. You know, and that means trying to make sure that everyone's got a fair opportunity to attain and achieve their full health potential, and people shouldn't be disadvantaged from achieving that potential. This is just a kind of graphic to illustrate that. If you give everyone the same resources, then if they already have a disadvantage, they're not going to be able to get what they need. They're not going to achieve the thing that they need. If you make sure that you remove the barriers to progress, or you give people what they need to progress, then they're more likely to achieve their potential. So, for example, you might decide to give everybody, all the children in a certain area, or all the children, you think, right, let's give children a book a week for a year. That will really improve their reading, they'll be better educated, etc. However, there were certain kids in certain areas that had never been taught to read. So those 52 books are not going to make a difference until you teach them to read. So that will be an example of giving those kids the resources they need to progress. And that doesn't take anything away from the kids who can already read. They'll be just fine. They'll do really, really well. But it helps those children who are disadvantaged, so that they are given the opportunity to progress. As individuals, we think about, you know, what can we do as individuals? The essential clinical things that we need to be doing are, you know, trying to involve our patients in decision-making and doing person-centered care. Truly co-producing and co-designing services. That means, you know, making sure that the people we're working with are actively partnered in developing the services. Otherwise, they're not going to meet the needs of their needs. And we're not very good at this, to be honest. What we often do is the stuff at the bottom of this ladder. So we'll develop a service or develop an intervention and then tell people about it and try and get them to use it, you know, coerce them to use it. If most of the time, most of us are doing this, you know, we develop a service or an intervention, we consult with people about it and we tell them all about it and we inform them about it, and then we hope that they'll use it. It doesn't necessarily work for them. If you develop your service or your intervention, and if you actually go and talk to the people who are in your population that you serve, you find out what their needs are, and then you develop the service and the intervention with them, then it's much more likely that they're going to use the service and that it's going to be a service that works for them and better meets their needs. That would be a truly co-produced and co-designed service. This is just a slide just to show you about the fundamental drivers of health inequity. I think I've talked about these. And the Institute for Health Improvement said, look, if you're going to improve health equity, really, there's the individual factors, but as individuals, we can only do a bit. Really, you need to do something on a system-wide level. And on a system level, you have to make health equity a strategic priority, build your infrastructure, address the multiple determinants of health, eliminate all forms of, you know, oppression and racism, etc. Partner with your community, essentially build an equity delivery system. You have to do something about your system. And what has been happening recently is that NHS England have developed this system, this advancing mental health equality resource, which is a guidance about how you might develop a system that better meets the needs of the population, the people that you serve. And I was involved in developing this. And you can download this toolkit, which is essentially what it is. It's 4 stages. You identify the mental health inequalities in your local area. You find out who your population is. You design services in collaboration with them. You co-produce them. You develop, you have a measurement strategy to ensure that, you want to know that it works, and then you evaluate it and you see if the service or the intervention that you developed works. And we're actually at the moment rolling out an improvement collaborative across the country to, with various trusts to help trusts to develop better services for the population. So first of all, finding out who your population is, and then developing services or modifying services so they better meet the needs of the people in the area. You might have heard about this, the Patient and Care Race Equality Framework. So the AMI, Advancing Mental Health Resource, is actually for all people. if you use the AMI approach and you find out that, guess what, we've got a very large proportion of people from a certain ethnic minority who are really not being served, we didn't even know that they had such terrible problems, then you would opt to use the patient and carer race equality framework. And essentially it's an organizational competency framework. And organizational competencies require organizations to, evaluate what things it does to achieve its mission. There is institutional competence, which focuses on the processes and procedures within the organization so that they can achieve a mission. And then there are individual competencies. And we always tend to focus on individual competencies, but really we should be thinking a bit more about the institutional organizational competencies. The institutional competencies being our knowledge, skills, and attributes. And we all know about that because of the competencies we have to achieve to do our jobs. A competency framework ideally outlines not only the individual competencies, but the institutional and organizational competencies to enable the organization to fulfill its mission. And in this case, it's equality in access, experience, and outcomes for all groups, in particular for the PCREF ethnic minority groups. And essentially the PCREF is an organizational competency framework that has not only staff competencies, but also organizational competencies to support the delivery of race equality in mental health. And it's a very practical tool, and hopefully it will hold local systems to account. So to summarize, because I told you I'd go on too long, so about this, but we do see excessive rates of mental disorder in people who are socially disadvantaged and discriminated against. It's not simply genetic, particularly if you're from a visible ethnic minority, that will increase your risk. Addressing these structural inequalities earlier in life. I didn't talk about criminality stuff, that's a bit old, that. An equity or equality delivery system approach is more likely to provide lasting and infrastructural and therefore meaningful change. And the NHS England, AMI, Resource and PCREF are equality delivery systems that are aimed at doing this. Thank you.
Thank you very much. That was a very interesting talk. And I kept actually a note of one of the things that you said was the less obvious types of discrimination, such as, devaluation or lack of respect or passive aggression can cause persistent distress and eventually make you unwell. So just something I think perhaps to highlight. We have a big number of questions, but in the interest of time, I'm afraid we can only take so much. A question by Dr. Sumari. The terms used to understand some of the inequality are structural or institutional discrimination. Do we have agreed or consensus on methodology to measure structural or institutional?
That's a good point. Is there agreed methodology? No. There are methodologies that people have put forward, but you'll have seen from the recent FRED report, very controversial report, the Commission for Racial and Ethnic Disparity report, that they said there isn't any such thing really. Well, they said there isn't really structural discrimination. And of course, if a government agency, not an agency, but a government commissioned report is saying that, then it's very difficult to agree what a way of measuring it might be. But there are sociologists who do that. So Sophia has said she wants to answer this live. I'm not sure if you want to put it in the chat, but no, it's not clear that there is an answer, but there is.
Okay, thank you for that. And the question from Dr. Phyllis, do you think that the discrepancy between access to mental health services in young people versus the average population is related to the organization of mental health services in the United Kingdom?
Yes, absolutely. In fact, that is a really good example of structural factors. We're also used to it, and I think it's to do with the idea that certainly, when I was children don't develop mental health problems. So there's an idea that your childhood is this wonderful thing. You don't really have any problems. It's only when you become an adult that you have difficulty. Obviously, we know that that's not the case now, but there was this general idea. So the services developed in a way that mirrored that idea. So structurally, we didn't have, structurally, our services are not commissioned for the need that exists for children and young people. So the commissioning, and commissioning is so important because the money and the policies that go behind that are behind what services you see, are determined by, often very historical processes. At some point, I mean, this was all done before there would be paper trails. At some point, someone said, "Oh, we probably need to have a service for those young people who have mental health problems." And someone said, "You don't really get many people with mental health problems who are young, do you? We won't need that much. Should we call it 5%?" And then it will have stuck. In fact, probably something like 20% of our health budget should be on, children and young people's mental health. I don't know what the actual figures are. I'll go and check those actually. But that is an example of structural and systemic discrimination, because we don't really know what the need is we don't know what the need is, and therefore we do not have the we don't know what the need is, so we haven't developed the services properly for the need. We know that we're underserved for sure.
Thank you very much, Shubulade, for this very interesting talk, and thank you for answering questions. I now will bring this to a close, I'm afraid, to allow some time for break before our next talk. And so thank you all for attending as well. And yeah, we'll break now, and we will be back in accordance with the program at 15:30, so 3:30. Thank you very much. Hello and welcome back, everyone. Now, moving on to our next speaker. It gives me a great pleasure to introduce Dr. Tim Nicholson. Dr. Nicholson is a clinical senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience, King's College in London. And he's also an honorary consultant neuropsychiatrist at the South London and the Mostly NHS Foundation Trust. He runs a specialist clinic for functional neurological disorders at the Mostly Hospital. Dr. Nicholson leads the largest international project on functional neurological disorder, the FND Core Outcome Measures project, which includes 40 multidisciplinary experts from 14 countries. So without further ado, I will hand over to Dr. Nicholson. Over to you.
Thank you, and thank you for inviting me today. Apologies to those of you who were at the Liaison conference last week, where I spoke about some similar topics, but I'm here today to talk to you about the neuropsychiatry of COVID-19, a sort of rapidly emerging field, and hopefully there'll be time for some questions at the end. So there's a lot, and things are moving quite fast in this area. So I'll just move my slides on. So I'll be covering a brief background about the neuropsychiatric consequences of COVID-19, and why we might expect there to be some significant complications. I'll talk about a important and early surveillance study that the Royal College has been a critical part in across the faculties, and there's some interesting data to show you from that, some of which you might have already seen, and some new data as well. We'll also talk about the wider picture of the emerging evidence base, including a blog that I've set up that with a lot of colleagues, which you might have seen on the JNMP website, just as a good resource. I'll talk a fair bit about long COVID because it's a very interesting, important topic, which is many of you will have read about or possibly even be involved in seeing in some of the new services that are coming up. And finally, I'll talk a bit about vaccine-related neuropsychiatric complications, which again, I think are going to be relatively significant and things we need to know about across psychiatry and in medicine in general, really. So a bit about the brief background. So this time last year or a bit before, we were starting to, the anosmia thing really got people going, thinking about neurological complications of and therefore brain complications of COVID-19. And of course, it's turned out that the anosmia story is probably more local endothelial damage rather than a sort of a direct neural invasion and a track into the brain, but it really got people concerned about it. And of course, there are plenty of other mechanisms other than potentially neurotropic virus, which it seems, is still possible, but it's not a large part of the CNS effects of this disorder. And most of those that we are seeing seem to be a bit more related to immune response, either the innate cytokine storm or later autoimmune processes that might be occurring. But of course, we also need to be aware of other mechanisms, particularly treatment-related hypoxia drugs, particularly steroids in the second wave, and into the well-known complications of ITU. And within psychiatry, we all know that we have not just the biological causes, we have the sort of psychosocial environment and economic impacts and all these sort of broader environmental impacts that can affect our disorders in terms of worsening pre-existing disorders and leading the precipitation of perhaps what were going to be subclinical or preclinical disorders. So this sort of diagram really puts that into, this is from a paper I'll later show you that we, some colleagues, Tom Pollack and Cam Watson and others put together about the potential for psychosis related to COVID-19. And so we've got these sort of direct effects, the parainfectious storm, the later autoimmune processes, the stress, pandemic, social, environmental effects. And the other thing we need to bear in mind for the long term and not lose sight of is that there's quite a lot of concerns from previous pandemics about risk of schizophrenia due to maternal infection. So there might be some long, we might be brewing some potentially complicated complications down the line regarding COVID-19 in psychiatry terms. But of course, there are reasons to suspect there's a significant psychiatric burden with COVID-19, and almost by coincidence, Tom Pollack, Adriana Kapinska, Robin Murray, Bob Yelkin at Johns Hopkins put together this timely review of the risk of the Spanish influenza pandemic and the potential mechanisms and evidence around the risk of schizophrenia. And top right is a bit of a sort of autoimmune, immune-mediated sort of model, which I think is something that could be something we need to start thinking about testing, or at least setting up the process to test, as I've mentioned about maternal infection. The one of the highlights really, or the headlines in terms of the popularity or what's known about this, is the encephalitis lethargica story. And this was really something that Carl Menninger and others really sort of brought out, and von Economo later on. But with Carl Menninger, it was really the risk of psychosis was something that he particularly focused on. And this sort of early, this is a slide from Tom Pollack, which he gave it last week at the Liaison Conference. But there was sort of great data back then that's quite instructive for the situation we're in. Delirium was clearly something that group 1, delirium occurred early on in the disorder, and then there's a bit of a gap, and then you might get these later, perhaps, and this might speak to the potential mechanisms of a dementia precox, so schizophrenia, sort of psychosis happening later on in the timescale of the evolution related to the onset of the infection. And this is von Economo and really the encephalitis story, obviously popularized by Oliver Sacks's book and the later film Awakenings. But as I'll come back to later on, there was a lot of concern that we might be seeing something similar, but so far, thankfully, the story is that we're not seeing a huge amount of these sort of complex encephalitis, sort of, genuine neuropsychiatric disorders at the borderlands of psychiatry and neurology. Another great early, wasn't a coincidence. This was a great piece of work by Jonathan Rogers at UCL and Ed Chesney at the Institute of Psychiatry, Psychology and Neuroscience, together with their senior colleagues, put together a very rapid review of the other severe coronavirus infections in terms of the psychiatric and neuropsychiatric features. So they did this super rapid paper that was published online in May that reviewed the acute illness and found that SARS and MERS were known to cause confusion, memory impairment, and insomnia in up to 25%. They reviewed the very early COVID-19 data, but there was very little sort of good data back then on COVID-19. And they also reviewed the chronic effects of SARS and MERS and found that depression, anxiety, PTSD, and fatigue were all found at pretty high rates several months or even 6 or 12 months later on. And for those of you who haven't seen this paper, the multi-talented Jonathan Rogers, who you can see bottom right here, did a musical abstract with him playing the piano and singing along to the Pirates of Penzance theme tune with novel lyrics describing his paper. So the just doing a sort of fantastic new way of presenting your scientific abstract. So I recommend looking for that on YouTube for some education and then simultaneous entertainment. So after that paper, we need to keep in mind the causality and association issues. And this was a paper that some colleagues in neurology and some of us in neuropsychiatry put together in the JNMP, really just reminding ourselves we need to be wary of of spurious associations and implying causation, because we're all very aware of this potential neurological and psychiatric consequences, and when we might be over interpreting just the chance that we've got huge numbers of COVID patients and our normal disorders are just presenting within those patients. So we need to remind ourselves of the Bradford Hill criteria of causality as we go through the pandemic. So the coronerve study, this was something, and many of you will probably have very kindly contributed cases to this. So this was a study that built on a dormant neurological study that was designed to capture new infections such as H1N1 a decade or so before, and to really be the canary in the coal mine to sort of pick up what's going on at the start of any pandemic. And so it was really a mechanism with existing ethical permission that could be restarted for any new infection, where there was a sort of online surveillance system where clinicians can report cases. And we were just thinking of doing something similar within psychiatry, and then we realized that we could bolt ourselves on, and there were so many good reasons to do that, not least of which is that neurology and psychiatry, of course, joined at the hip, or even above at the brain, of course. So the initial notification phase just takes 2 or 3 minutes, and submitting your case here will get you as a PubMed listed author on as a collaborator on any publication. So it's a big carrot to sort of submit your cases. And if you haven't already done so over the last year, if you've got any cases of psychiatry or neuropsychiatry that you think are related to COVID-19, please submit them by the college portal. And then once you've done that initial notification phase, you'll be invited to fill in a 20 to 30 minute form, which will be with more clinical details of the case. So this is what the form looks like. It's really very simple. You just tick the box of what psychiatric presentation, and of course it can be, multiple of these, and often is, and we're seeing complicated psychiatric presentations, as you'd expect with organic psychiatry, that might not necessarily fit into our standard diagnostic boxes. We're also interested in those that are occurring in the perinatal period, and particularly interested in those that are happening after COVID-19 vaccines. And then you just report on the neurological status of the patient if known. So this is the first paper that came out of this study in last summer, and it was the first 153 patients from the coronerve study, and there were 23 psychiatry patients within that. And this is just to give you some of the details. You can see here the breakdown. You've got the neuropsychiatric disorders, and of course, if you've got altered mental status, there's relatively easy to separate, but obviously there's not often a clear distinction between those that are encephalopathy versus a psychiatry case. But I think we can fairly convincingly demonstrate that we are able to classify these patients, and within the context of the broader whole of brain complication patients reported, we found there's 23 neuropsychiatric cases, mostly psychosis, but a range of other things, mostly a range of cognitive dysfunction patients, and then a mixed bag of other things from acute severe new onset depressions, personality change, catatonia, and mania. And what has also been interesting is that this breakdown of the broad categories, even though this is very early data from a non-epidemiological study that was purely just to get, potentially biased study in terms of the reporting. But these categories have really been borne out through a lot of the data, as I'll later highlight. So most of what we're seeing is cerebrovascular events. There's quite a lot of altered mental status, whether you classify that neurologically or psychiatrically, and then a sort of mixed bag of a few other things that might be there, but if they are, they're not happening at a great frequency. So the other interesting thing about this study is that the cerebrovascular events, as we'd expect, were in the elderly largely, but we had this bimodal distribution in the neuropsychiatric cases with a younger onset group and then also an older onset group, which is mostly in the sort of delirium type spectrum patients. So sort of interesting differences there that we're starting to see. This is the next paper, which is under review in Brain Communications and will hopefully soon be out. And this is the first 267 cases, but not just the notification data. This is with the full sort of case report form, detailed clinical information. And again, the same pattern, largely cerebrovascular, sort of some inflammatory patients and quite a few psychiatric cases, some of which we classify now as exacerbation of existing cases, and then 19 new cases. And just to go through the details, there's 19 new cases, again, predominantly psychosis with some depression, anxiety, and then a mixed bag of other things. And in this paper, obviously neurologists have more mechanisms by which to classify their presentations, so they can start to split them into central, peripheral, by different types of stroke and by different types of vessel. And this is by other broad categories. And there were some initial concerns, particularly from delirium experts, that we might be misdiagnosing delirium as psychosis and not really appreciating that that's part of a delirium. But when we got the full clinical detail, we were able to really convince ourselves and hopefully others that that wasn't happening very often, because we could get clear descriptions of a delirium episode and then later on an emerging psychosis in a clear sensorium. So really, there were some cases where it's a bit of an overlap, and if there was any diagnostic uncertainty, we would attribute it to delirium rather than a separate disorder. So this is just more detail on that specific overlap of different presentations. The other interesting thing is that we were able to look at the data according to whether these, by these different classifications of patient types, by how the symptoms, the timing of the symptoms relative to the onset of respiratory symptoms at time zero. So quite a lot of patients presenting earlier or having the earlier onset of symptoms relative to their respiratory symptoms. And these different sort of violin plots here can sort of show you that there might be different mechanisms at play. And obviously within psychiatry, there's likely to be different mechanisms even within psychiatry. So there might be a bunch of disorders causing early onset issues, and then later on you're getting other presentations due to different mechanisms. And obviously autoimmune would be something occurring later on, and inflammatory, for example, being something earlier on that might even predate the respiratory symptoms. So interesting data, and it's great that the clinical neurosciences communities across the UK really pulled together and really were sort of leading internationally on presenting this data. So we got, due to these this nested coroner study, or dormant coroner study, that was up and ready to go very quickly early on in the pandemic. And the other thing we realized early on in the pandemic was that the standard way of reporting clinical data or scientific data through systematic reviews and narrative reviews, and normally takes sort of, even when, like with that review of SARS and MERS, even when you get a couple of people working full-time on it, or a big team working full-time on it, it takes several months often just to produce the data, let alone get it published. So we thought it would be useful to set up a blog where we had weekly updates of the data. And it started off with Matt Butler, an academic clinical fellow here at the Institute of Psychiatry, Psychology and Neuroscience, a neuropsychiatry trainee who helped me and others put together a team which has grown from a handful of us to over 40 international students, trainees and senior academics and clinicians across the world to put together this weekly update. So Some of you might have already seen this website, but if not, it's a good resource for the whole of neurology and psychiatry of COVID-19. We have our own Twitter page, and here is a Shrove Tuesday themed coronavirus pancake that one of our star, I think it was Ella Birchall, produced for us, which is we've kept as our icon on our Twitter feed. So at the moment, this is the current setup of the blog, where you have different data papers, different categories of disorder, different types of paper, and we have weekly updates, things on preprint, and a roundup of case reports that are coming out. Of course, as the evidence base matures, case reports become less important, and it's more the quality of data improves as the evidence base matures. But we have a new blog because we realized that the limitations and the rapidly escalating nature of the evidence base meant that we needed something more searchable so people could come and get what they wanted to. So we built this big database that will sit behind our new blog, which will be launched in the next few weeks, which will allow people to come in and pull out by a specific disorder or a specific study type that they want to look at. So there'll be a whole load of other new features that the blog team have put together. So we're very excited about this, and hopefully we'll put a big splash out on our Twitter page when this is out. The team also do 5-minute presentations of the best 5 papers in the last month as part of the Brain Infections Global Webinars run by Professor Tom Solomon and the WHO. So these are some of the past talks here, and they're all put up on this website, and we have links to it on our current blog, and we'll make a big feature of this on the new blog as well. So this is quite a nice little way of catching up with what we consider the top 5 papers in the last month, and they're all presented in rapid fire, and the rest of the presentations are very good. It's an hour-long webinar and 2 talk speakers, and in the middle is our blog presentation. So they're a nice way to catch up on the neurology and neuropsychiatry of COVID for those who are interested. I think what I'll do is just highlight, there's obviously a huge amount to highlight, but I'll just use a few instructive papers to highlight what we've learned over the last year about the neurology and psychiatry of COVID-19. So there were early case reports of Guillain-Barré syndrome associated with COVID-19. And this was quite a key paper by the group at Queen Square, who looked at had some good epidemiological data looking at the prevalence of, or the incidence, in fact, of Guillain-Barré syndrome, and found no convincing evidence, despite there being case reports coming in. They found no convincing evidence of an increase. And what's more, they looked at the homology between the SARS-CoV-2 virus and the human genome and found little homology, which would make the sort of molecular mimicry hypothesis of the autoimmune system sort of attacking our own cells after having been stimulated by SARS-CoV-2. So sort of both epidemiological and theoretical data to really reassure us that Guillain-Barré syndrome might not be a problem, despite us being initially a bit concerned there might be. Another interesting study was looking at the laboratory biomarkers. Again, this is from the Queen Square group, looking at cytokines and other biomarkers in patients with severe COVID-19, and really finding some interesting early data to back up what we're hearing about in the press about the cytokine storm that was raging, that would perhaps explain the confusion and delirium and other cognitive effects of the virus. And this was an interesting paper which really put on the map the fact that what clinicians on the ground were noticing, and many of you, if you're an old age psychiatrist, will have, I'm sure, seen this, of COVID-19 presenting with delirium before the respiratory symptoms were either prominent or noticeable. And so really just made people aware that just delirium in the context of a pandemic needs to be either assumed to be COVID or it needs to be carefully looked for and patients monitored for the development of respiratory and other symptoms. So this was a sort of an interesting learning point from early on. One of the other interesting findings is the association between, this was perhaps not expected, so this is why this is interesting, and you might have seen this, but there was an association between antidepressant use and risk of intubation and death, and found that antidepressants were quite protective theoretically, and there's some mechanistic reasons why this might occur with the way the virus sort of affects or gets into cells. So I think this was something that was quite an interesting thing, and it's obviously interesting to us seeing patients who are taking antidepressants, whereas of course lots of the other data was showing how there was increased risk of mortality and in people with severe mental illness. So an interesting sort of connection with psychiatry here. Also, not to forget children. There was some, you might have heard, although we initially thought there was very little severe complications in children of COVID-19, there were these rare but very severe syndromes that were noticed with inflammatory syndromes within children with COVID-19. And some of these had some neurological complications as well. This is a recent paper that's just came out, and you might, again, there was quite a big sort of splash in the broadsheets about this particular study from Maxine Taquet and colleagues in Oxford, interesting studying a US electronic notes database, so a very large sample of over 200,000 patients with COVID-19, and looking at the 6-month follow-up of what the hazard ratios are of different disorders. And this is quite a nice piece of data to show us, confirm things we already knew: strokes at high rate, not much to worry about with Guillain-Barré and Parkinsonism. If we think back to encephalitis lethargica, not much of a signal of a Parkinsonian type picture. These are all classified by ICD-10 diagnosis, so it's not very specific or detailed clinical information, but really the codes that the electronic notes were having on them. And these were compared to both influenza controls and other respiratory tract infection controls. But I think the few things that jump out are dementia was something that wasn't really something we were particularly concerned about. And of course, there might be other confounding reasons for these, but we all know that delirium can precipitate or hasten the onset of dementia, so this is something that perhaps we should look out for. Also, there wasn't much data to make us concerned about the risk of psychosis in COVID-19, but this hazard ratio of 2 here sort of stood out a bit. So those are the 2 findings we of interest. Another one that wasn't discussed much in the paper, and we've written a letter about to explain, is the highest hazard ratio was actually for myoneural junction. Those of us on the blog team hadn't noticed any data on myoneural junctional muscle disease, but we think this is due to post-ICU myopathy and neuropathy, which often co-occur in patients who've had prolonged ICU stays. So I think that's the explanation for this. So it's not a primary disease of such, it's a complication of ICU or ITU stay. So that data perhaps reignited the debate about psychosis and perhaps schizophrenia being increased risk, and going back to the earlier Carl Menninger studies that I mentioned before from the Spanish flu. So this is a nice review by Tom Pollack, Cam Watson, really covering this, and that's where that mechanistic overview figure I showed you comes from. So there are also some issues potentially about immune-mediated damage, and which we're all, it's quite a hot topic both within, particularly in the whole of, particularly in neuropsychiatry, but obviously across psychiatry in general. And there's been this sort of concern that perhaps a subgroup of many psychiatric disorders might have an immune mechanism, and there's been some interesting data that's come out, and I won't go through these in detail, but just to flag up that this is still an area of active ongoing investigation within the COVID-19 sort of neurological and neuropsychiatric literature, that perhaps these antibodies can be autoreactive, perhaps be unclear exactly why, if there's no particular homology, but as that Guillain-Barré syndrome paper showed, but we need to keep an open mind to this. So there are some other studies which have come out all showing the same sort of hints at this, but it seems to be potentially a rare complication, and even patients who have very severe disease and have CSF taken as part, and the reason for that is they have a very severe neurological complication, still not high rates of antibody positivity or ability to find the virus in these patients. This is a very recent study showing, this is really the most recent one, showing a sort of a range of immune responses in neurological symptoms and some evidence of some autoimmunity in these patients. Another concern is that the virus is persisting in patients with chronic neurological or psychiatric disorders, and this is something that I'll come back to later on in the potentially as a mechanism of long COVID as well, but something we're keeping an eye on. So where are we at now? The blog team that we're involved with have done a systematic review and meta-analysis of the data up to last autumn, and this is coming out in JNMP in the next few days. So this is really just a snapshot of the very early data. So a bit like what the data that Jonathan Rogers presented with SARS and MERS. So this is the linked by point prevalence. So no major surprises here, but it gives us a bit of an idea about the early data, synthesizing it all together in terms of the point prevalence of the different neurological and neuropsychiatric complications of COVID-19. So from a whole range from the usual anosmia, dysgeusia to weakness, fatigue, myalgia, sleep disorders, and down into some other symptoms as well, and disorders, of course. So there's lots of research going on. There's a big new study, COVID CNS study, which was funded after several rounds of application last year, and it's been great that the UK clinical neurosciences community, neurology, psychiatry, psychology, basic neuroscience have all been pulling together. And this is led by Ben Michael at University of Liverpool and Jerome Breen, a geneticist at King's. And this is already recruiting. It's recruited over 50 or 60 patients, and the plan is nationwide to recruit 800 CNS cases and some controls, and compare these to patients from community samples that have been collected via a large ongoing NIHR-funded bioresource study. So there's already more centres than already listed in this slide, but we're up and running the recruitment in London, Liverpool, and also Oxford as of a few days ago. So this is moving fast, and we're able to recruit patients to the coroner study. So those of you who've submitted cases, we're able to contact you to ask for details of the patient to recruit them into this study. And it's not a reason to submit your cases to coroner if you haven't already, if you've seen such patients. So this is really a summary of where we're at visually with the range of neurological through to psychiatric presentations. We have strong evidence for stroke being associated with COVID-19, some evidence, or very strong evidence for delirium. PTSD is clearly found in those hospitalized, and high rates of that. Almost some of the early data from Wuhan, it was almost up to 80% of people in field hospitals having PTSD symptoms, not necessarily disorder, in the immediate aftermath of their admission. So we have some other disorders where we're pretty sure there's something going on. Severe encephalitis and encephalopathies can occur. Luckily, they don't seem to be happening at very high rates, and there's not the encephalitis lethargica type picture, at least yet, that we're seeing. Cognitive dysfunction, and as I've mentioned, possibly dementia syndromes might be at risk. And then we also have a range of other pure psychiatric disorders. And there's a few other things we need to keep an eye on. Psychosis, as I've mentioned, catatonia. I don't think there's a big spike in catatonia. Would have noticed that by now with all these various studies, but still might be a small print complication. And I thought we also should keep in mind disorders like OCD, which given there might not be a huge amount of awareness about OCD in non-psychiatrists seeing patients, and it might just be presenting with severe anxiety, and the sort of hypervigilance and washing might be thought to be culturally normal within the context of a pandemic, but might represent OCD being precipitated either de novo or otherwise tipped into clinical OCD from something that was brewing anyhow. And then there's long COVID. What is long COVID? And many of you will know a fair bit about this. It's been this time last year, the first few reports were coming out about it in the press, but now it's a sort of major headline news, both politically and medically. And so really, if you have symptoms, I think at least 12 weeks, although some define it as 4, but these were really disabling symptoms that were noticed in patients who often weren't hospitalized acutely, so had a relatively mild initial disorder. And this is an infographic sort of drawn by some patients about a year ago, showing the huge range of symptoms that these patients were presenting with. But it was predominantly fatigue, headache, brain fog, cardiorespiratory symptoms, but also quite a lot of neurological symptoms, paresthesias, other sensory motor. Another thing we've noticed is dizziness is very common. Balance problems quite common in these patients as well. But the full range of different bodily systems often affected. This it was another sort of novel feature of the pandemic that these patients coalesced on a Slack group, so a sort of online connection group where the body politic was a group that was set up and already going for sort of gender politics. And within this, people coalesced and they published the first details of the first 640 patients that coalesced on this group. And this is now the main, so one of the main groups internationally for this disorder. This was picked up by Ed Yong in the Atlantic and made quite a lot of impact. And this term long hauler or long COVID started to be used. And this was there was some data coming out showing sort of chronic inflammatory responses and chronic physical findings on investigation in patients who had initially quite sometimes had not that severe initial symptoms. So there was a sort of publicity campaign by another one of the patient groups, the Long COVID SOS group, and this was picked up by along with a sort of growing media campaign where all the broadsheets and started to pick this up. And this was last spring we started to sort of really look at and summer when things started to really pick up. The WHO and political bodies in the UK started to notice this, and suddenly there was funding and for research and clinics, and there's now huge amounts of money going in the US, UK and beyond in terms of setting up clinical services for these patients, but also doing research into the mechanisms of treatment. This is one of the first papers that you might have seen in the BMJ by Trish Greenhall and colleagues. Really just, this was the first real sort of academic paper highlighting the clinical problem. We shouldn't forget kids as well. This is something that seems to be relatively common in adolescents and children as well. And there's a long COVID kids group as well. This is a paper we've got in preparation, which is really putting together the complexities of this disorder, because of course, there's lots of issues about defining how long you need the symptoms for. You need to think about the evidence for COVID, whether that's antigen or antibody testing, or whether it's the clinical likelihood of having had COVID. And of course, in the first wave, there were lots of patients who didn't have access to testing. So therefore, this was the need to be certain about COVID infection was removed appropriately. So, but of course, we need to be wary of just coincidence again, in people developing syndromes, and is it related to COVID or not? There's a huge range of physical symptoms that people can manifest with, but common ones, particularly cardiorespiratory and neuropsychiatric. And another feature of it seems to be these fluctuating symptoms. So people having initial symptoms that wax and wane over days and having good and bad days and weeks. We also need to think about subclassify patients according to how severe their initial illness is, whether they should have had, whether they're hospitalized and whether they're in intensive care, or whether they didn't have a severe initial illness. And then there's all these issues about different mechanisms that I've mentioned. And of course, we also need to think about things we're aware of within neuropsychiatry about cognitive processes that can maintain or generate symptoms. We also need to think about post-viral syndromes in context. We know that other viral syndromes are associated with a wide range of chronic sequelae, and there's quite a lot of similarities, but quite a lot of differences in these different viruses, and including some rare ones that we hadn't really heard of before. Chikungunya virus in Brazil that leaves quite significant arthralgias. So there's a difference between different viruses, but also some commonalities, and particularly around chronic fatigue syndromes as well. So this is another a groundbreaking paper from Hannah Davis and Athena Akrami. Hannah Davis is a US long COVID patient. Athena Akrami is a neuroscientist at UCL who's also a patient. And so this patient-led research is the sort of cutting edge of really of patient involvement in research and patient-led research. So they did a survey of 4,000 patients online, most of whom were not hospitalized, and presented their data. And this, I think, will be out quite soon. The preprint's been up for several months. Well, more than that, 5 months now, I think. A lot of fatigue, post-exertional malaise, brain fog, cognitive symptoms, and interestingly, neurological symptoms. So initially, we weren't expecting a lot of neurological symptoms, but it's quite a big part of this disorder. And although this is a potentially biased sample, it's just online patients rather than those in clinic or collected from some epidemiological sample, I think they're going to be quite representative of the patients seeking care. So here is a sort of just showing the sort of polysymptomatic nature of these patients and the huge range of systemic symptoms and cardiorespiratory symptoms. But these are the neurological symptoms. So a whole range of emotion, mood, sensory motor, sleep, cognitive, memory, headaches, taste, smell, speech, language, and even hallucinations as well. So it's a very complex disorder, which I've attempted to put into a sort of, whether this stands up to any scrutiny. This is putting in, can we define the core of this syndrome? Is it just too heterogeneous? Is there so many different subtypes of patient? But it feels to me that there's a core of this, which is perhaps fatigue, post-exertional malaise, cognitive dysfunction, brain fog, and cardiorespiratory symptoms. And then a whole range of other potential physical symptoms and other psychological symptoms. And these are the psychological symptoms defined and reported in that patient-led research I've mentioned to you. So another interesting thing that you might have seen last week is long COVID symptoms and their response to the vaccine. And this was a headline in The Guardian, and based on quite a small study by Long COVID SOS, which is, I think, is put in preprint here. But again, just, you know, it's by far from a definitive study, but it's just showing that there's a range of responses from no change to positive change, worsening. And the sort of overall picture from the patient-led research here is that there might be some improvement. And obviously there's multiple different mechanisms by which that could be occurring. So it's sort of interesting that what the vaccine does to long COVID is under a lot of scrutiny. And it's going to be an important thing looking forwards. So here's a meta-analysis that the blog team have done, and this is just put up as a preprint a few weeks ago, led by Jamie Badenoch and Ali Rooney in Edinburgh, and the whole blog team. And this was a rapidly put together meta-analysis of the search date in late February. And there's only 51 studies with decent data at this point, but really showing this is the poor prevalence. And sleep problems have the highest prevalence. Fatigue is not, so that was the one headline that's slightly surprising. That's the highest prevalence. But fatigue, depression, anxiety, quite common, and a range of other symptoms. But this was when we rerun this later on, there'll obviously be much higher quality data to put into this. So just to finish off, I'll talk a bit about vaccine complications with COVID-19. So we all know that there's this, initial systemic reactions. We all know that the concerns initially, there was a lot of hot debate about the thromboembolic complications, and although obviously venous thromboembolism and PEs is something that is almost certainly a problem, particularly with some vaccines. The neurological complications, there's not clear evidence yet. The data from the trials showed that there was potentially some increased rates in the active vaccine versus placebo arms of the trials, but nothing definitive yet. But actually just a few days ago, there was a couple of stroke patients reported in JNMP. So we'll need to keep an eye out for stroke potentially as well. But we're also seeing potentially some functional neurological disorders. So this is the neurologically specific form of functional disorder, in which there are diagnosable different features. So the old term for this would be conversion disorder, of course. But our knowledge about this disorder has changed. It's not purely a stress-related disorder. It's a more complex brain disorder that definitely can be precipitated and has a risk factor of stress, but it's not defined by that. But this is something that seems to occur. We've seen a couple of cases. We just had these accepted for publication. There's other neuropsychic, this is a tongue-in-cheek slide about the report in the Sunday Sport about a complex neuropsychiatric reaction to the vaccine. So I don't think we need to be too worried about this sort of complication. But we do need to think about these vaccines more broadly. We also have concerns that severe movement disorders and seizures, there's other FND cases, functional neurological disorder cases, that could be misdiagnosed as a severe organic reaction to the vaccine. So of course, FND isn't related to the constituents of the vaccine, it's more triggered by the initial illness and the expectation of, and a focus on bodily symptoms that can then blow up into a full-blown severe disorder. And there's quite a lot of debate about this, and you can't comment on individual cases that you see in the media, but there are certainly some that have been put out on the media, and there's a lot of policing of the media by Facebook and other groups, and the whole anti-vaccine, vaccine hesitancy debate, for which this has huge implications if people start worrying about having what look like very nasty movement disorders or seizures. And this was flagged up in JAMA Neurology by colleague David Perez in Harvard, really showing that when experts look at these videos, there's quite a lot of signs potentially that they might be FND rather than something else. And this paper from Matt Butler, who's another member of the team that I've mentioned before, this preprint is up talking about how we might decide on whether something is causally related to the vaccine, but also distinguishing organic from FND reactions. And of course, we need to be vigilant for both in these. And this is a table from it really showing the criteria and how we might work through and think through these complex issues. So I think this is a major issue. We're also aware that in previous vaccine campaigns, particularly when children start getting vaccinated, the human papillomavirus vaccine had precipitated outbreaks of sort of mass functional illness in geographically isolated areas, particularly in Colombia, Scandinavia, and Korea. So we need to be aware that these can really take off, these FND, and particularly when we start to vaccinate younger populations. So we need to be aware of that and educate clinicians and control the media messages around safety for these vaccines. So I'd just like to finish there and thanking the Coronerv team who have did all this amazing work to allow these studies to get up and running so quickly, the Faculty of Neuropsychiatry, psychiatry team, the JNMP blog team. And if you're interested in joining us, please do get in touch. We're always looking for new members to help with what is a huge task. And there are some resources which I can put into the, and links of papers I can put into the chat if people want later on. So thank you for your attention.
Thank you very much, Tim. Very, very informative as usual. Very rich talk. We have actually many questions. I hope we have time for everything. So I have a question from Dr. Tianga. Will there also be research into the damage done to people's mental health by the effect of lockdown, such as losing job, closing schools? So I guess this question is more about the secondary reactionary effect of the lockdown. Absolutely. This isn't an area of research that I'm involved in. I'm sort of more involved in the neuropsychiatric side of things, but clearly a massive importance. And we know that the pandemic has so many multiple ways in which it can be caused psychiatric morbidity and even mortality. And I think this is only set to get worse as the economic impact of the pandemic sort of takes shape. So I think definitely, but it's not something I particularly am involved in the research on. Thank you. And the question from Dr. McCleary, with all the cerebrovascular diseases, it seems inevitable that we will see a lot of vascular cognitive impairment and dementia in all age practices. And Dr. McCleary, comment quite surprising that's not coming through in data already. Do you have any comment on that, Tim? Yeah, well, we do. That data I showed from the Maxine Takei Lancet Psychiatry paper showed there was perhaps a signal hazard ratio of 2 for dementia diagnoses. So I think definitely, and there's multiple mechanisms by which that could be occurring, whether it's inflammatory, vascular, so I think it's definitely potentially autoimmune as well. So I think we need to be very vigilant to rates of dementia rising
over the next few, and look at the mechanisms. And we've got an opportunity to study that. And again, one of the silver linings of all this, this horrific pandemic has been the uniting of the clinical neurosciences across this to hopefully start to look at this. And the COVID CNS study that I mentioned is cognitive impairment patients and trying to work out what's causing that as well. So I think that's definitely something to be mindful of.
I think moving smoothly to a question by Dr. Sumero, I guess that's what Dr. Sumero is alluding to. What's the evidence for risk factor for long COVID? Well, I guess what Dr. Sumero is alluding to, well, for people, for instance, with pre-existing vascular changes, pre-existing, well, cognitive impairment related to that, and one of my own favorite, well, how about people with pre-existing brain injury?
Yeah, indeed. So we just don't have much data on the risk factors for long yet. There's been a huge amount. There were some big studies funded just before Christmas in the UK. The NIH in the US has put in an eye-watering £1.1 billion into research into this area, and they're going to be announcing their studies quite shortly. And there's another £20 million call for research into long COVID, which is going to be in the next few weeks. So I think we're going to start to answer those questions. We just don't know what the risk factors are yet. And then obviously there are some similarities with other disorders, particularly chronic fatigue syndrome as well. So we need to but I think it's not going to be just one disorder. It's going to be a bunch of different disorders and different mechanisms. So we need to have quite a complex, nuanced, trans sort of medicine approach to this complex disorder.
Yes, and I guess that touches on the next question by Dr. Phillies. Do you think that the neuropsychiatric symptoms of long COVID will be kept different over time from separate neuropsychiatric entities by formal criteria? So I guess about classificatory diagnostic approach.
Yeah, we just don't know yet. So I think it's very early days, but I suspect there'll be different mechanisms in individuals and also within individuals over time. I think there might be an initial one mechanism, an inflammatory mechanism, then there might be sort of more potentially functional mechanisms that could take over it later on. But there are any combination of things that could be occurring. And we need to just be open-minded that it could be a whole range of physical and cognitive and even psychological processes at work. So we just need to be, and there's obviously there's a very big history of polarized thinking about post-viral syndrome. So we need to sort of, I think we all need to be, both sides of that need to be open-minded to different subcategories of mechanism and treatment approaches, and it's almost certainly not going to be a one-size-fits-all approach.
Yes, thank you. Well, from my side as a clinician, primarily, I have seen some people, and sometimes it's very difficult to treat. I will say, very difficult to sit on one diagnostic box, if you like, and use link it to evidence. I have a question from Dr. Bowman. There was recently an article about the increase in referrals for tic disorder within CAMS since COVID-19, and the authors seem to suggest it might be functional, maybe associated with more people accessing Tourette's TikTok. Has anything similar been noted in adults, or anything suggested that this might be more than functional?
Yeah, I mean, I think I'm aware that there's definitely some reports of tics and its question and other movement disorders, particularly in children. There have been some movement disorders in adults as well. I think it's just there's a mixed mechanism. So I think there might be multiple different subtypes that are emerging, but there hasn't been any that I'm aware of any data on increased rates of tics within adults, particularly. And it's not something that's been noticed or reported, but we need to keep our minds open that could be occurring. And I think in individual cases, there's obviously quite a lot of, it's quite a skilled clinical judgment about whether tics are organic or functional. But of course, tics are something that are genuinely neuropsychiatric. They're generally at the overlap of neurology and psychiatry. So I think, the research needs to be done, and the skilled clinical assessments of these patients to try and disentangle what's going on. But again, that's another quite polarized area of debate. And I think, again, it's just an opportunity that the virus will allow us to hopefully work out, because we've got sort of numbers of patients involved, that we'll be able to unpick these complexities and hopefully provide the right treatment for the patients.
Thank you very much, Tim. Yeah, well, We are actually doing very well for time as well. So thank you very much. Very informative. Yeah, I hope that, well, you wouldn't mind sharing your slides with the audience at some point. But that's a different issue, I suppose. So moving on to a different, to our last speaker, but not by any means least, we have Professor Neil Greenberg. Professor Greenberg is a consultant academic, occupational and forensic psychiatrist based at King's College London. Neil served in the United Kingdom Armed Forces for more than 23 years and has deployed as a psychiatrist and a researcher to a number of hostile environments, including Afghanistan and Iraq. At King's, Neil leads on a number of military mental health projects and is a principal investigator within the nationally funded Health Protection Research Unit. Neil will give a talk that will cover the available evidence about the potential impact of COVID-19 on the psychological well-being of healthcare staff and outline a range of evidence-based approach to protect their mental health. So over to Professor Greenberg.
Thank you very much indeed for letting me present here. So I'll just put the slides up. And just to say, I have been to lots of very dangerous and difficult places, including Denmark Hill. For those of you who've worked down at King's, it can be a bit of a challenge down there as well. It's not just in foreign places. So I'm going to talk on sort of health and well-being for staff. And just to kind of give you, you've got my background in terms of I served in the military and all that stuff. Before I start, I'll just say here's my Twitter handle. What we try and do is pump out all of our academic publications through Twitter as soon as they come out. In fact, we had one just yesterday, which I thought was quite interesting, which is about over-surveying of healthcare staff. For those of you who work in NHS trusts, which I'm sure is many of you, you've probably had loads of surveys come around asking about your well-being. And one of the problems, of course, is you get multiple surveys and then survey fatigue. Anyway, so that paper came out yesterday. But I guess my interest in this topic actually stems from my my time in the military, where I was very interested not just in treating patients, which I did, but also in trying to keep military units functional. Because if you don't have enough people to man the pumps or man the weapon stations or on a ship to keep the ship afloat, then actually everything fails. And one of the difficulties, of course, for the healthcare service over the last year, 15 months now, has been that because of the pressures that have been going on, staffing difficulties have really impacted upon the ability to deliver high quality care. So what I'm going to talk about isn't just about doing the right thing morally for staff, it's also equally about trying to keep people able to do their job. And for those of you who are interested, we have a special interest group in occupational psychiatry at the college that I chair. So if you're not a member of that, please join that too. In terms of publications, if you're interested in downloading the evidence, then these two places, the Health Protection Research Unit, which I work at King's, and also our King's Centre for Military Health Research, actually have most of the papers for free download, so you can usually find them pretty easily. So it goes without saying that over the last 15 months or so, there's been a range of different stressors that healthcare staff in particular have been exposed to. I think it's important, although we talk about healthcare staff, not to forget there's lots of other key worker groups as well, particularly I think social care staff who have also been exposed to an awful lot of very difficult circumstances. As well as trauma, there's been changes in workload and shift patterns. You'll be aware yourself, of course, whatever sort of work you've done, I'm sure your pattern has changed. And for those people who have done a lot of home working, I think it's been said it's not so much working from home rather than sleeping in the office at times. And then, of course, the question just now about what about the impacts of COVID on people generally. There's been a whole range of home life stressors in terms of bereavements, in terms of educational difficulties and financial difficulties. And actually, for those of you who are interested, Public Health England does a tracker, a mental health tracker, which is sort of updates every month, and that's freely available online. And there's a range of really large studies, sort of 70, 80, 90,000 people that Public Health England draw the data from, and they show over time how the mental health of the general population has changed, and also look at higher risk groups. So that may be of interest to some of you. And then there's been this topic which has taken a lot of media interest, particularly, but also practical interest, which is that of moral injury. And moral injury is something as a topic which first started in the military, back at the time of sort of Vietnam, really, but goes back further than that, really. And it describes the real distress that people feel when something happens that violates your moral or ethical code. So all of us have situations where things happen and we feel distressed because of that. And mostly that resolves by itself. Some people, that distress becomes fixed, and usually the distress manifests either as shame, anger, or guilt. And in some people, it can then translate into illness. And the three ways that you can experience moral injury are by things that you or other people did, things that should just never happened. And so one good example here is, talking to an intensive care nurse, who was doing some amazing stuff, saving the life of one patient. But of course, that meant that she wasn't doing something for another patient who died. And in her head, she just couldn't get out. That should never have happened, which indeed it shouldn't, but she should never have been put in that position. But that's the situation. Acts of omission, things that you didn't do. So supervisors not providing staff with the right equipment or the right support because it's just not available because things are just too busy. And also there's betrayal by a higher authority. This is being let down by people who really should have been looking after you. And I think early on during the pandemic, the PPE sort of debacle was a very good example of this. What on earth should have managers done? Should they be sending staff to carry out difficult tasks without PPE, dangerous tasks, or should they not, in which case patients might die? And of course, the thing about a morally injurious event is often there is no right answer, but it can still have important effects. Now, you won't find moral injury in the DSM or the ICD because it's not a formal diagnosis, and nor should it be, I think. But what we know is it can be viewed as a risk factor. And we did a review a few years ago in BJ Psych, looking at the relationship between moral injury and mental health disorders. And what we showed there is that moral injury is linked with post-traumatic stress disorder, with depression, and also modestly, but significantly, with suicidality as well. So what we should view it as a risk factor. And we've got a big study going on, run out of King's, called NHS Check, which covers 18 NHS trusts across England, including some mental health trusts as well as physical health trusts. And what we've been interested in that study is to look at the impacts of the pandemic on healthcare staff in particular. And by this, I mean healthcare staff across the board. So that includes administrators as well as clinicians. And what we did in the study, which got 27,000 people in it, is we had a measure of morally injurious events. So things that could cause people to experience moral injury. And one of the most classic ones for healthcare workers has been the kind of, I want to deliver the good quality care, but I've not been able to. And that should never have happened. And what we did is to split the exposure to morally injurious events into tertiles, low, moderate, and high. And what you can see here is using all these different scales. I won't go into them. The PCL6 is a brief measure of PTSD symptoms. What you can see here is that the people who had the highest level of exposure to morally injurious events were the ones that were most likely to suffer with mental health difficulties. And so we can see here that that moral injury is an important issue for healthcare staff in the same way as it is for many other professions as well. This is another study we've got going on, which is specifically looking at the impact of the pandemic on intensive care staff, who, as you'll be aware, have been very much, in the public eye during the pandemic. And what we've done here is measured since June of last year up until February of this year, and we've done 6 different waves of data collection. You can see the numbers completing it have gone up over time. We've actually done another one just recently that I haven't got the data here. And we've used this scale called the PCL6, which is this brief measure of PTSD symptoms. We don't need to get into necessarily what the rates are, because these are rates of self-reported symptoms. But what you can see here is that as the pandemic appeared to get better last year, so the rates of probable PTSD or possible PTSD went down. And as things got worse again, the rates went up. And so what this shows us is actually there is a lot of reported PTSD symptoms, 40, 60%, depending on which threshold you use, in intensive care staff. And indeed, we know this from other studies across the board in all sorts of healthcare staff, including mental health. But that actually, as the situation gets better, those symptoms in many cases improve by themselves. And that suggests that this is probably more like adjustment in terms of adjustment disorder rather than frank illness such as PTSD. But there is a remainable proportion, a small proportion, who will have an increased rate of proper mental health disorders. It's not that adjustment disorders not, but more serious ones like PTSD. But we will have to judge that over time when the situation hopefully continues to improve. So the question is, what does the evidence tell us can make a difference to improve the mental health of staff who are doing really challenging tasks? I think it's fair to say that even outside the pandemic, healthcare provision can be pretty challenging at the best of times. And so the first thing is we know that there is an awful lot of evidence, as you're probably aware, about buddying people up, about social support, what we call horizontal support, so that's support between colleagues. This is a paper we looked at that I did as part of my doctorate some years ago now, and this looked at military peacekeepers who had deployed to the former Yugoslavia on difficult peacekeeping duties, exposed unfortunately to lots of ethnic cleansing and mass graves and other really quite unpleasant stuff, as well as threats to themselves as well, including snipers and the like. We found overall, unsurprising, that staff who spoke about their experiences with others were more likely to have lower rates of poor mental health, and that's not surprising. But we asked them, who did you speak to about your experiences? And 97% said we spoke to people just like us. So people who walked in the same shoes, who used the same language, who had the same experience. The military has its own mental health and welfare service. Only 8% of people went and spoke to, a healthcare professional about their mental health. And what this tells us is that most people prefer support to be coming from people like them. And our NHS check study is again showing the same preference amongst healthcare staff to speak with their colleagues rather than go and seek out professional sources of support. So as well as trying to create horizontal cohesion between team members, the most important aspect here is actually being able to get supervisors to be able to speak to people about their mental health. And by supervisor here, I mean the team leader, I mean the ward manager, rather than the medical director and the chief executive and the board members and all that sort of stuff. So what we need here, and this is a cheesy phrase, I get it, but it works for frontline staff, is that supervisors need to be able to do a checkup from the neck up. They need to feel confident in order to speak about mental health matters with staff who might be going through difficult times. And I know, we hope as mental health professionals, most of us feel pretty confident in speaking about mental health, but it may surprise you to know that actually amongst healthcare staff generally, they may be very good at putting a catheter in, about changing dressings or doing some surgical procedure, but actually having a conversation about well-being actually is something that many staff don't feel confident to do. And the evidence in support of this comes from a number of places, but two particular studies are important, I think, to sort of show you just how important this support from your immediate line manager is. So one study we did in military personnel in Afghanistan 10 or so years ago now, is we looked at the rates of probable PTSD in troops who were in really austere, really difficult environments. And what we found is if the troops felt that their immediate line manager was supportive, so they didn't take on extra tasks to make themselves look good at the expense of others, they treated all members of the team fairly and questions like that, and actually they had 1/10 of the rate of probable PTSD than troops who felt their immediate supervisor wasn't supportive. So that's a 90% reduction in PTSD symptoms if you felt your boss was really looking out for your welfare. Another study done in Australia in firefighters, it was a randomized controlled trial of a management training intervention, which aimed to train up fire station managers in New South Wales to be able to speak about mental health matters with their staff. Now, I'm sure many of you are aware, that firefighters is a pretty robust sort of profession. I can tell you firefighters in Australia are probably even more robust in terms of their attitudes towards the well-being. And what this study did, it got published in Lancet Psychiatry in 2017. It looked at the sickness absence costs in the 6 months before the intervention and the 6 months afterwards. random allocation of people who got the intervention and people who didn't. And what they found is by training these managers, it led to a 90% reduction in sickness absence costs in firefighters over the next 6 months. And the key thing here was about supervisors feeling confident to speak about mental health matters with their staff. So on that basis, we designed an intervention. I ran the mental health strategy at London Nightingale Hospital when it was up and running for a couple of months last year, to basically train up healthcare managers and supervisors to be able to have what we call a psychologically savvy chat. And this was a 1-hour training package delivered over Zoom, which involved sort of 15 minutes of didactic teaching, showing people how to have an active listening sort of template, how to use a template to speak to colleagues and staff, a 5-minute demonstration, take a few questions, and then we got people into breakout rooms to practice using this template to get them to be able to do active listening. And this template stands for recognize, engage, actively listen, check risk, and talk about a specific plan. We did a brief pilot, which was published in Occupational Medicine earlier this year. We found that before people had done the 1-hour training course, over half of them did not feel confident to identify problems, discuss problems, and help solve problems in colleagues who had potential mental health difficulties. 1 month after the course, nearly 85% felt confident. So from a bite-sized intervention delivered online, we were able to dramatically increase the confidence of supervisors to have those well-being focused conversations. Another thing we know works, or there's good evidence for, is peer support. And so this was a Delphi study we did some years ago. And a Delphi study is where you ask lots of experts to provide their views on consensus statements about what a particular intervention should do. And this was about peer support in high-risk organizations. I think we probably all agree, certainly large areas of the health service are high-risk organizations for exposure to challenging events. And peer supporters should provide a listening ear. They should provide low-level psychological interventions. And this is talking problem solving and sort of brief coaching. This is not talking about delivering any sort of psychotherapy. They should identify people who are at risk themselves or others and help those people get forward to have a proper assessment by someone who can do the right sort of questioning and the right sort of assessment process. One way, not the only way, but one way this has been done is through a peer support program called TRIM, Trauma Risk Management. TRIM is a peer support program that first started in the British military in the late 1990s. It involves training up frontline staff to be able to sit down with a colleague and use a 10-item checklist to speak through what's happened about a trauma, not with the idea to debrief or counsel them, but with the idea of identifying how much they might have been affected by it. If they are affected early on, then you would support them and then you recheck about a month later, and hopefully by that point people are doing better. And there's over 50 NHS trusts now across the UK which use TRIM, and 15 ambulance trusts as well. So it's not everybody, but it's it's pretty popular. And what the evidence on TRIM shows is this is not penicillin for trauma, but this is, we've got 13 academic papers now. We've done a randomized controlled trial of it. We've done lots of other studies, and it shows that actually it helps people get forward and seek professional care, and it also helps improve organizational functioning. Which is important because we want to keep people at staff, and it reduces sickness absence as well. But one thing, of course, we should not be doing is psychological debriefing. So hopefully most of you are aware of the NICE guidelines on the management of PTSD. They were refreshed, updated at the end of 2018, so they're pretty current. And for those of you who don't know the NICE process, I was on the NICE committee. NICE very rarely say don't do something. So NICE normally just stays silent where the evidence is lacking. So for instance, when we looked at the evidence on meditation and PTSD, there wasn't enough evidence out there to make a recommendation. The NICE guidelines don't mention meditation. They don't say don't use it. They just don't say anything about it at all because there's no evidence to guide what to say. The reason NICE say do not do psychological debriefing is because on balance, it doesn't just not work, it causes harm. And so the UK guidance, the Australian guidance, and the American guidance, none of them recommend the use of debriefing, and the Australian and the UK guidance specifically recommend against the use of debriefing. Now, this might sound, well, you understand this is pretty common. I can tell you that some NHS trusts still use the psychological debriefing model. They call it critical incident stress management, to give it a different name. But at the heart of it is the idea of bringing in someone from the psychology section or from a sort of welfare section to come in and hold a team debrief afterwards, even though NICE are very clear you shouldn't be doing it. What NICE say you should be doing is you should be actively monitoring people. It used to be called watchful waiting. And this is keeping an eye on people and then checking in with them to make sure that if they do have difficulties, that they then are helped to get the right sort of care. And as we know, the right sorts of talking therapies that we know work are trauma-focused cognitive behavioral therapy and EMDR, and there is good evidence for both of them, probably slightly better evidence for trauma-focused CBT, but both are good. And then the other thing that you can do in the workplace is to do forward support and supervision. Now, what this basically means is someone becomes distressed in the workplace. Managers may well feel that they should just say, well, you just, go home, sort yourself out, come back when you're ready. But actually, that doesn't seem to be the best way. The best way seems to be the use of what we call these PIES principles. These, again, started in the military. This is a study here published in the American Journal of Psychiatry in 2005. And this was of a 20-year follow-up. As you know, you don't get many 20-year follow-ups. A 20-year follow-up study of the use of PIES by the Israeli military after the first Lebanon War of 1982. And what they found is distressed troops who were treated by or managed well using PIES, the more of the PIES principles used, the better their health was 20 years later on. And the 4 principles are, first of all, the principle of proximity. And what proximity means is that if someone's having a tough time, don't say go home. Instead, you need to increase their support and decrease their pressure. So these are things that a manager can do within the workplace, change their job around, keep them feeling functional, keep them within the social support, don't just send them home. Immediacy says that if people are having problems, you need to try and nip things in the bud. And that means having one of those psychologically savvy conversations, peer supporter or supervisor, identify what the difficulty is, because we know, unfortunately, there's very good evidence that people don't tend to come forward and ask for mental health support until they reach a crisis point or until something really bad happens. And what we want to do is to try and solve the problems early on so they don't reach crisis point. Expectancy is the expectation. Remember that intensive care graph I showed you earlier on, that actually when things get better, so most of people's symptoms will begin to improve as well. And that actually it's okay to say that you're probably not ill, you're probably having a reaction to a very challenging event, which is quite normal. But the other side of expectancy is that if people start to become functionally impaired or their symptoms start to become very severe, then the expectation is we will get them forward to have a professional assessment. And then the last principle is the principle of simplicity. And what simplicity says is that actually, if you've got someone who's really distressed because they don't understand how to do a particular procedure, or they're being asked to monitor a piece of equipment they don't understand, they don't need to see a psychiatrist. They need to be mentored and coached to use that piece of equipment better, because that's the way to solve their anxiety symptoms. So simplicity is about trying to put in place simple problem-solving strategies that often make a big difference to people's mental health. And then we come on to hopefully the period that we're in now is what do you do in the aftermath of difficult situations to help people recover? Now, it's important to say when you look at meta-analyses of risk factors for post-traumatic stress disorder, they universally say that if you split it into what were people like before the trauma, how nasty was the traumatic event, and how were people managed afterwards, it's what's done afterwards that has the biggest influence on people's mental health. So this period that we're in now isn't just, well, we've done it, we didn't do it great, let's just move on. This is the point now where we actually stand to make the biggest impact upon people's mental health in order to try and prevent them becoming unwell. And the other thing here is it's not about just preventing people becoming unwell. It's also trying to encourage what's called post-traumatic growth, which you've probably heard about. Put simply, is anything that doesn't kill you makes you stronger. And there is good evidence that many people go through adversity and actually don't come out broken or even unaffected. They come out thinking, do you know what, if I can cope with that, then I can cope with anything. So what sort of things can help in this recovery period? So the first thing is about giving people a proper thank you. I don't know if you've seen, but there's been some fabulous examples out there of NHS trusts who have really tried to say thank you to staff properly. There's even ones where they've reached out to healthcare workers' families and said, thank you so much for letting your mummy and daddy come to work. We know it's been really difficult for you. So it's about giving a personalized thank you, which says thank you for what you've been doing, and also giving people information about the range of resources that are available to help them. People shouldn't be asked to go straight back into another really difficult task. They should have a graded return to work to give them some time off. And then it's important, going back to this moral injury piece, about giving people a chance to do some meaning making. And many people don't begin to process what's happened to them until perhaps they become less directly involved in it and they've got some time to think about it. And the evidence is that reflective practice, that is thinking about what happened, not just in how did I do right or what went wrong, but what was the impact is really important. And what we know about reflective practice, and Schwartz round on one example of this, is they really need to be led by the leader. It needs to start off with, I'm in charge here. Let me start off by saying, I don't think I've got everything right. There were times that I felt really bad, and to try and encourage the team to speak honestly about the impact. And one way of doing it is to use this little acronym, which is FINE, Facts, Impact, Functioning Now in Education. And what you're aiming to do is to create what's called a meaningful narrative. And that's a story in which you try and make sense of what's happened to you. And it's not all your fault. It's not the fault just of your bosses. And this is a bit cheesy, I know, but we weren't always in the same boat, but we were absolutely in the same storm. And if you can come to that collective understanding that despite things not being right, and despite you doing things and not doing things because of the pandemic, actually everyone did do something useful, and we all did our best, and we tried to support each other where we can. And that's a much better place psychologically to be than feeling that you've done something terrible, that you're a monster, or that you've been let down by others. And then, as I mentioned already, NICE say we should do active monitoring. Oh, I'm going to start this bit here in a second, which we should be doing. So we know that mental health problems won't all sort of come out straight away. Good evidence that actually people don't present until very much later on in some cases. They worry about their careers and other forms of stigma, as you well know about. But what we think is really useful, and what there is good evidence for, is for supervisors to be having an individualized discussion with all members of staff. Now, this actually fits with the NHS People Plan, which is good news. And what we really want here is this conversation is about, tell me about what you've been doing for the past year, what your experience is, and tell me about what's been going on at home. Because how will you know if someone's had a bereavement? How will you know if their partner's lost their job and financial difficulties? How do you know about the education? How will you know unless you ask those questions? And once you've asked the questions, and once you've understood what someone's experience has been like, then you're in a very good position to say, well, what can we do to make it better? And that might be some sort of flexible working. It might just be an opportunity to listen. It could be a whole range of things, but unless you've had that discussion, you will never know what's needed. And then lastly is, unfortunately, as we well know, there will be people who, despite the best support put in place by their organization, who will become unwell, who will develop a depressive illness, a PTSD, or some other disorder, substance misuse or the like. And what we know here is that actually mental health care is obviously important, but the evidence is pretty strong that mental health care really could do with having an occupational focus. And that's basically meaning that what we want is for the healthcare intervention to have return to work as a specific goal. And when you look at the evidence, it's pretty clear that actually occupationally focused mental health care is much more likely to get people back to work than healthcare, which says, well, let's forget your work. Let's just focus on getting you better. And that suggests that we do need a very good link between mental health care provision and also occupational health. And we know that, generally speaking, as long as your work is not too toxic, working is good for you. And therefore, if we can help get people back to work, that's not only good for the individual, which it probably is, it's also good for the organisation, because we need the NHS to have as many staff available to deliver high quality care as possible. So my sort of summary is that we shouldn't over medicalise normal distress. There'll be plenty of people out there who have lots of symptoms. Many of those symptoms won't be indicative that they're ill, but that they're just been having a really tough time. What we want to do is to adopt a nip it in the bud approach, try and solve problems early. And it's really important that colleagues, and particularly supervisors, are able to have psychologically well-being focused conversations. And that makes a really substantial difference. Don't forget those PIES principles to manage acute distress. Don't just be sending people home. And then make sure you have a recovery plan. And the college has one, a template, which is called Going for Growth, which is available on the college website. And actually, if we get this bit right, this recovery and evolution, even if we haven't got all the other stuff right, we stand not just to prevent mental ill health, but we will be likely to encourage post-traumatic growth, which can only be a good thing, because there will be another disaster, I'm sure, around the corner. Thank you very much. I'll happily take any questions.
Thank you very much, Professor Greenberg. And may I say, finished with military precision, 1650, 1 minute summary, and exactly 9 minutes for questions. I salute you, sir.
You're very welcome.
Right. So we have, we have questions. One from Dr. Sumro. are there differences between classical PTSD and COVID PTSD with implications for tailoring specific treatments for COVID PTSD?
So I think it's probably, to be fair, too early to say, what COVID PTSD definitely is, but there's plenty of evidence around, and we do have information from our big NHS check study. So I think one of the key features about what's happened during COVID is, yes, there's been trauma, although there's been death, whether COVID's been happening or not. But we think that moral injury will feature very highly in the mental health, and particularly the PTSD that clinicians will see. And the important thing to recognize from a treatment point of view is, if someone comes to talk to you about their experiences and they can't stop thinking about it and they've got classic PTSD symptoms, they may very well concentrate on, I saw lots of dead bodies, or that something really bad, I thought I was going to catch COVID or give it to my loved ones. And so those threat-based aspects of trauma are what people feel generally more comfortable talking about. What they may feel a lot less comfortable talking about is, I think that people died because of what I did. So that moral injury part may well not come out. And what we find during treatment with military veterans is that actually they don't do as well with classic PTSD treatments than non-veterans. And the reason we think that that's the case is many military personnel also have moral injuries. And so if you've got a therapy sessions going on, it may well be that they do quite a good job at addressing all the threat-based and fear-based aspects, but they never really touch on the moral injury stuff because someone doesn't want to talk about it because that shame and guilt is so painful. So what I'd be saying to clinicians who are assessing people who might have PTSD because of their work during COVID is to make sure you don't just focus on the classically traumatic and threat-based and fear-based, but to actually ask them about what their view is on the meaning of this, what about themselves, and to probe gently for shame and guilt or anger. Because actually, if you can bring them out and address them as well, you may well get a much better outcome to the treatment.
Thank you very much. Well, yeah, I'm actually made some notes for my own learning, potentially more injurious events, and well, COVID perhaps ticks most of the boxes, if not them all. Yeah. Okay, I have a question from Dr. Pillinger. Do you think that this is why the 1% pay rise seems so difficult, because it's not sufficient? Thank you.
Well, yeah, I can absolutely understand. That's a really good question. The question is, if you spoke to NHS staff back in 2019 and said, do you think the NHS has your back? I think the majority of NHS staff would say, no way. I think I would hope that within many units that they might say, well, look, my boss has got my back, all my colleagues have, but the trust, the NHS, now, I don't believe it. And that's because I think over the years, there have been plenty of people plans and, new initiatives. And what happens is they sound good on paper, but when it comes to it, it's a chocolate teapot. It doesn't deliver, anything useful. And I think what's happened actually during COVID, I think actually there have been a lot of really good wellbeing initiatives. I don't know how much people know, but the National Wellbeing Team, they have introduced a lot of stuff, and there's been lots of money pumped locally. And I know it's been variable around the country, but there have been lots going on. What I think, unfortunately, we've seen is the free sandwiches have gone. The car parking now returns to costing you £5 to pay to go to work. And I think the danger is that the pay rise can also fall into that. And so what we need going forward is for the NHS to actually deliver on what it says it's going to deliver. It wants to make the NHS the best place to work, and that people want to work there and they feel supported and valued. That's what they want. Okay, that's a great aspiration. So the question is, how do you do that? Now, I don't think giving a 5% pay rise by itself, or 10%, although that'd be very nice, I don't think that's, but I think part of the whole suite of what happens, the pay rise says, you know what, we don't really care. So I think if they did keep free parking, if they did keep wellbeing spaces, they did keep people time off, I think the pay rise by itself wouldn't be overly important, but I think it's part of a whole suite of of messages that and everyone's going to be thinking they're not going to keep to their promise anyway. And so this potentially is part of that.
Thank you very much, Professor Greenberg. And yeah, I guess we are coming to the end of this program. So my good Greek friend just joined us.
Amazing. I mean, to be honest, no, listening to Prof. Greenberg, I can see why he's best friends with Simon Wesley. Both of them a river of free-floating consciousness, unstoppable. I know I said that I'm going to disappear into thin air, but here I'm back with my Greek accent, and sadly, that's the end of London and Southeastern Division Spring Academic Conference, a day that, trust me, we put loads of love in making it happen. We started with sleep, and hopefully we did put you to sleep at any point, during the day. We heard about the Asu and the Asipus, heartbreak and mental health in the Assyrian times 4,000 years ago. We explored the complex relationship between antipsychotics and cardiometabolic health, but also the biophinosocial model and how phenomenology can still be an indispensable tool for practicing psychiatrists. And, regardless of how much we may condemn inequalities, the truth is they are all around us, and they're still adversely impacting our patients, but also our fellow colleagues. It would have been absurd to leave COVID out of the picture, so we were indeed updated on the advances in our understanding of its neuropsychiatric complications, and closed with Prof. Greenberg and how COVID and all this mess has been impacting, because it still does, on our well-being, and how, hopefully, we can improve it. A massive thank you to all the speakers, as without them, there would be no conference. And of course, the London and Southeastern Division Manager Mastermind, Jennifer Edwards and Karen Morgan, without who, I can reassure you, we would be all still trying to log on. So before you disappear into thin air, yes, the event was recorded, so you can safely delete all your screenshots and invite your family over to watch it all over again in the weekend. In fact, you can watch it even on Monday, as if it's spring bank holiday. Yes, you will be receiving a certificate of attendance to wave at your board appraiser's face. And yes, we need your feedback. So go on and fill that feedback form. The link is in the chat room. Tell us what you like, tell us what you didn't like, as otherwise we will remain crap in eternity. And to be honest, you would lose the right to even be able to nag or say, oh, I told you so. So it's Pospo and Hashem for the London and Southeastern Division Spring Academic Conference. Over and out.